Welcome back to Hong Kong WAFs 2022. Good morning, everyone. And I have to say good afternoon and also good evening as well, because we have more than 1,000 participants all over the world. So I hope you enjoy your good weekend. So today is the day 2 program. Yesterday, we have gone through multiple keynote lectures and also recorded case on innovations and also hot topics in TAVI. And also, we have widened our eyes by all those international specialists talking about the new devices and some innovation that we haven't thought about. So if you have missed some of the lectures, welcome to check it out on Facebook and YouTube. So today, we continue our discussion on mitral valve and tricuspid valve as well. So I hope you can all enjoy today's program. Thank you, and see you soon. Hello, it's Daniel again. So let's start the first session of Day 2 program, the innovations on tricuspid and mitral valves. So, of course, we will have an expert panelist. Before we start, let me introduce them to you. So we have an overseas expert panelist, Dr. Yeung. He's a cardiac surgeon from Zhenxing Hospital, Taiwan. He's a specialist in TAVI and also minimally invasive surgery. He's a renowned surgeon, and he's been a proctor for multiple devices. And also, we have Dr. Yeung. He's an expert cardiologist in Macau. He performed multiple complex PCI and also intervention in structural heart diseases. And also, we have local faculties, Dr. Eric Wong, cardiologist from Queen Elizabeth Hospital, Dr. Ivan Wong from Queen Elizabeth Hospital, Dr. Tommy Ling, cardiac surgeon from Queen Mary Hospital, and Dr. Lam Yui Ming, cardiologist from Queen Mary Hospital. So we go to the first lecture. Let me introduce Professor Gregory Scalia to you. Professor Scalia is a director of echocardiography of Prince Charles Hospital and president of Structural Heart Disease Australia. He's an imaging specialist but heavily involved in interventions. He is the principal echocardiographer for the transcutaneous mitral valve repair program and the world's first percutaneous mitral valve replacement with the tandem device. He has published over 300 articles, and he's actively involved in teaching ECHO and the co-director for the ECHO Australia program. So Professor Scalia going to present to us today's topic, echocardiographic imaging of tricuspid valve. So may I pass the microphone to Professor Scalia?
Well, good morning, and thank you for having me. I will maximize my screen. I hope that you can see me there coming through nicely. So thank you for having me at your conference, and I'm going to talk about tricuspid valve imaging. So as you know, the tricuspid valve has three leaflets. It has a large anterior leaflet, which is underneath the right ventricular outflow tract in the right coronary artery. It has a smaller posterior leaflet, which is adjacent to the right ventricular free wall and the distal right coronary artery in the atrioventricular groove, and a septal leaflet, which obviously is attached to the atrial septum and near to the coronary sinus. This is a very important landmark. There are three commissures, and we refer to them as septo-anterior, and as you can see from the red arrow, that is near to the aortic root, and you might want to put an edge-to-edge repair device there. There is the septo-posterior commissure, which is adjacent to the IVC and coronary sinus, and you might want to put a clip there. And the third commissure is antero-posterior, which we refer to as the divide between anterior and posterior. Now, the reason why this is important is I want you to imagine a septal leaflet, which I've drawn in a cartoon there, as being wall-to-wall across the valve, and it is septo-anterior or septo-posterior. That is to say, it is septo-something, and the septal leaflet is wall-to-wall. Now, when you turn this around and have a look and have a from the right-sided view of the right ventricle, you can see that there is a single large papillary muscle supplying the anterior and posterior leaflet. This is the marker of the divide between the anterior and posterior leaflet. There is a smaller posterior pap muscle, and the septal leaflet doesn't have a papillary muscle, it has multiple caudal attachments to the ventricular septum, the RV side of the ventricular septum. So when you unwrap the right ventricle, you'll see these septal attachments. You'll see this larger anterior papillary muscle, which is at the divide, and this smaller posterior papillary muscle. Now, all surgical textbooks are drawn with the diagrams as if the patient's lying on an operating room, with the superior vena cava to the left, the inferior vena cava to the right, and the sternum at the top of the screen there. And so the picture on the left and the picture on the right are a surgeon's eye view with the anterior leaflet and the divide to the top of the screen. So this cartoon here, which is a usual cartoon we see, shows you that layout. And also, if you look in blue, that is the triangle of Koch, and that's important because at the apex of that triangle there from the coronary sinus, where you see the yellow dot is the AV node, which is obviously very important for surgeons not to put a stitch through when they're doing open heart surgery. But what we look at when we do echo is we have the alignment like this. And so all of our echo views have the aortic valve at the top of the screen. And you can see in this transthoracic image on the left there, anterior, posterior, and septal, and you can see the divide there just above that P letter. And you can similarly make the same picture in transesophageal. This is the lower esophageal view with anterior, posterior, and septal leaflets, and you can see the divide there just below that A letter. Now, just like in mitral, there is a Carpentier classification for TR, with type 1 being normal leaflet motion and annular dilatation. This would be functional. Type 2 would be tricuspid valve prolapse and elongated or ruptured cords. And type 3 would be restricted motion, which is almost always rheumatic. Now, as it turns out, primary TR, which is type 2 or type 3, either prolapse or restriction, is relatively uncommon, about 1/5, and that's prolapse, Epstein, carcinoid, trauma, perforations, radiation, that sort of thing. But 4/5 is functional, FMR, or FTR, I should say. Functional, related to leaflet tethering, right ventricular remodeling, pressure overload, but basically annular dilatation. So if you look at this CT scan here of the right coronary artery in the AV groove, I took this from our position paper, guideline paper from the ASC. You can see in blue there is the attachment of the septal leaflet, and in yellow you can see the attachment of the anterior and posterior leaflets. I'll just superimpose a valve on there. And so the septal leaflet is attached to a relatively fixed area of the annulus, and the anterior and posterior in yellow, on the yellow part there, that part of the annulus is stretchable, such that when you see the valve beating like this in a normal situation, you've got the triangular orifice, but as you develop progressive right ventricular dysfunction and annular dilatation, you see here now that that yellow part, or the right ventricular free wall part of the annulus, dilates. And so as you go from mild functional TR, grade 1, through moderate functional TR, through to moderately severe functional TR here, and then severe functional TR, what you see is progressive annular dilatation, no real movement of the septal leaflet, but the anterior and posterior leaflets are pulled apart such that you have extremely poor leaflet coaptation like that. So if you take this typical cartoon of a tricuspid valve and the anatomy right next to the aortic root, turn it upside down, because remember, transthoracic echo is viewed from below, then this is your index view, and this is the most important view for tricuspid. It doesn't look like it's the most important view, but it absolutely is, because you've got the anterior and posterior leaflets on view there. And the septal leaflet, remember from at the beginning, the septal leaflet is wall to wall, but it's on this side of the screen, because you're looking from below in transthoracic, such that if you put an X-plane cursor through that part of the valve, you will be septo-anterior. And you can see the septal leaflet and the anterior leaflet on the right-hand side there. In fact, you can actually see the coronary sinus in there too, just under the S. And if you move the trackball to the left on the workstation, you will now be executing through the septo-posterior. So as you move the trackball left and right, it's always septo something. But depending on where you've got the trackball, it's either septo-anterior or posterior. Now, the exact same thing is true for transesophageal, but have a look at the picture at the top now. I've inverted that, because from transesophageal, same picture, anterior and posterior leaflets, but the septal leaflet is behind the screen, because in transesophageal, you're looking from above. So you've got wall-to-wall septal leaflet behind the screen on that right-hand picture there, such that if you put an X-plane cursor there through the tricuspid valve at that position, then on the right-hand side of the X-plane picture there, you will have septo-anterior. And if you move the trackball to the left on the workstation, same septal leaflet and septo-posterior. And you can see the concept here is if you trackball back and forward across the valve, you will always be septo something. And in fact, you could imagine a situation if that dotted line was going exactly at the junction there of A and P on the cartoon, you would be at the divide between the anterior and posterior. That is septo-anterior, tracking across, past the divide, septo-posterior. When you do this, then you can put color on, and here's a situation where you've got color on. And in this situation now, you can see that most of the leak is septo-anterior. And so by putting color there and then X-planing through that color, you can see that you've got regurgitation mostly septo-anterior, which is mostly where it actually is in most cases. And you can trackball left and right across that area to show that you've got the extent of the tricuspid regurgitation. Now, the second view for looking at the tricuspid valve is the deep transgastric, actually the shallow transgastric. In this view, you are looking from the right atrium, but you're upside down. And so the septal leaflet, anterior leaflet, and posterior leaflet there is as displayed. So let's go through the landmarks. You've got the septum, obviously, and coronary sinus associated with the septal leaflet. Inferior vena cava is this side of the screen. Septal leaflet, anterior leaflet, posterior leaflet. And on my cartoon there, I've drawn the divide between the posterior and the anterior a fair way around. But if you have a look at the echo on the right there, you can see the divide between anterior and posterior is actually just above that letter A. You can explain when you're in the deep transgastric view there, and I've drawn on the top left picture there, the divide between anterior and posterior. And when you explane onto the divide, you pick up that large anterior posterior papillary muscle, which is the marker of the division between anterior and posterior. When you put colour on, you can again show where the leak is coming from, and I've freeze framed that right picture to show you that this leak is mostly septo-anterior, and you'd probably want to put some sort of clip device there. The last view is the mid-esophageal 3D view. This is septo-anterior. This is probably where the jet is. Let's have a look on the colour. Yes, that's where the jet's coming from. Usually you have to freeze frame on the colour to show exactly the orifice. So when you're steering a device down, this is again done in X-plane, and you steer down onto the valve using the index view on the left and the grasping view on the right. When you're in that position, you can then allow the operator steering for manipulating the device such that if you want to go more posterior, pull out. If you want to go more anterior, near to the aortic valve, push in. And when you're in the X-plane view, they're turning clockwise, and counterclockwise will bring you more septal or more the other way, either anterior and posterior leaflet, depending on where you are. Doing this from the deep transgastric, you can X-plane there. This allows you to look for flexion and rotation. And lastly, axiality is achieved in the esophageal view in 3D, allowing you to get perpendicular to the coaptation line. So in the last minute, I'll just show you a case example. This is an elderly lady of mine on high-dose diuretic with severe atrial functional tricuspid regurgitation and bad heart failure. And so steering down, in this case, 2 clips onto the valve, using the X-plane to get you in the right position. And if you look there now, the 2 clips have plicated the valve. Both of these clips are in the septo-anterior position. You can see them on the left picture there, lined up along the length of the valve as per the cartoon. And what this does is take a very severe leak and turn it into a moderate or moderately severe leak. And you might say, well, that's not perfect. But I say this lady went from 4 or 6 or 8 diuretic tablets of furosemide per day down to 1, with complete resolution of her heart failure, edema, and swelling. And so I think the point here is that using these complicated multi-planar imaging, 3D, in 2D, and but most importantly in 2D X-plane, will allow you to successfully make these clip implants to help these people with tricuspid regurgitation. Thanks very much.
Thank you, Professor Scalia. It's an excellent talk. So as a cardiac surgeon per se, I would say this talk is really helpful for me to, visualize the the TE imaging into what we see actually the heart is. So we have a discussion time here. May I pass the microphone to our panelists to see any comments and also questions for Professor Scalia?
So, Professor Scalia, I'm Eric Wong from Hong Kong, and I'm also an interventional echocardiologist, mainly doing lots of this imaging guide intervention. So, you mentioned about transgastric view is a very important view to orientate the edge-to-edge repair device. But obviously, many of us will feel rather difficult sometimes to get a good transgastric imaging. So, is there any tips and tricks for us as an echocardiologist or echocardiographer to obtain a good transgastric view? And also, some people, if they find difficult to get a transgastric view, they might consider using the real-time 3D MPR to replace the transgastric view to for the orientation of the edge-to-edge device. So, what's your opinion about that?
Yes, thanks very much for that. I totally agree. And I've got a few things to say about that. Firstly, tricuspid unlike mitral, tricuspid, you have to do what you have to do, because sometimes you just can't get the beautiful views that you want. And so those things that I've just shown you are not necessarily available in every person. And so we have to use our tricks. And I agree, and I didn't show it, perhaps I should, is real-time multiplanar 3D. If you've got enough pixels, then that is a very good thing. And that might be gettable from the transgastric. It might also be gettable from the lower esophageal. But the problem is, as I'm sure you've all seen, is when you're doing tricuspids, it is far away from the probe. And so the pixels are not so good. And so sometimes you have to use some of your tricks to get this to work. Now, one of the things that I also get asked about in this situation, I get asked a few questions about this, but one of the things that I get asked about, and if I might take a moment to reshare my screen, if that's all right, is this. So in this picture here, if you look at this picture, you can see here I've drawn in that view there. I'm hoping that green line's coming up for you. But the problem is that sometimes the aorta there is in the way. And so for example, this picture here, when you look at the right-hand picture, there's a lot of shadow here of the aortic valve and the aortic root. And it doesn't have to even be a prosthesis. Just the actual shadow of the normal aortic valve and the aortic root can get you into trouble. Now, the trick for this is to push the whole TE probe into the person about this much, about a centimetre, and then pull the big wheel of the TE probe so that you're pivoting around your angle of attack and you're going around the side or around the back of the aortic root there. So, because most times when you take this picture, you're coming from this direction. And that's okay if the aortic root is not too white. But if it's too white, then push the probe in, bring yourself around here, pull the big wheel back, and that way your angle of attack is not going through the aortic root. I hope that showed up all right.
That's a very nice trick. Thank you. Is there any other questions?
While you're thinking about that, the other thing that people say to me is, what about ice? We don't have ice for this, but I'm sure that might be a use. And the third question I get asked is, what about transthoracic? And surprisingly, sometimes transthoracic actually is very good in this situation. I'm not sure what's going on with the screen. But sometimes transthoracic is actually very good, particularly in the subcostal view.
Right, Professor, I got a question. So now, we got a lot, as a cardiac surgeon, we got a lot of referral for valve surgery beforehand. So do you think TOE is a mandatory assessment before the surgery? Because most of the time 100%. We just got a transthoracic one.
No. 100%, absolutely, positively, 100%. There is no place for going to valve surgery without a transesophageal echo. Now, sometimes that might be in the room, if you're sure, but so many times you find things you weren't expecting. And in our MDT system, you don't even get to go to the MDT, the case, unless you've got transthoracic, transesophageal.
Right. So among all those assessment of the severity of the TR, which one you think is the most important one or most significant one?
Okay, so that's two questions in one if you think about it. One is actual volume of severity, and we use things like the vena contractor, but what I personally like is flow reversal in the hepatic veins. I'm very big on that. JVP with big V waves. But to me, actually, much more important than all of that is the anatomy. Because if you've got wide core coaptation, so instead of this, you've got this. And if you've got that over a fairly wide area of the coaptation line, to me, that is severe tricuspid regurgitation. And I think what you're asking me is, if you're doing a mitral, say, should you do the tricuspid while you're there? And that's a good question. It's a hard question. And to me, that's probably not a question that you should be answering in an operating room. Because in an operating room, you're nil by mouth, your volume is low, you've usually had diuretic, you're under general anaesthetic, and oftentimes what looks severe in real life is not severe in the operating room. And then you go home the next day, you didn't do the operation on the tricuspid, you go home 1 week later, there's severe TR. So I really do think that that's not a decision for an operating room transesophageal. That's something that you need to decide before the fact. This is when you're doing open heart. Now, another question we get asked a lot is, we'll do a mitral clip and we'll see how we go. And if the tricuspid gets better, we might not do it. But if the tricuspid stays the same, we might do it. Typically, we decide before. We're either going to do both or we're not. And if we don't, we will often say, we're only going to do mitral today, and then come back in a month, have another look, see where we've landed, because going back to do a tricuspid is not difficult. You know, it's venous puncture, it's not difficult.
Thank you. That's a nice trait. May I invite Dr. Yip? Dr. Yip from Macau. Do you have any comment? Sorry, Dr. Yip, you are still mute.
Hello, Simon,
Yes.
and excellent presentation. I agree. The echo guide is really important for the structural heart operation. So I learned a lot from you, and hope to join you soon, face to face, to have the meeting together.
Well, Dr. Ip, I'm looking forward to coming to Macau. So whenever you're ready, I'm there.
Sure. Welcome.
So is there any question from the panel or from the floor? May I ask, like a local panelist, what is the change of the prevalence of the tricuspid problem nowadays in your daily practice? Is that getting more, getting less, more complex? Or how frequent you feel about you need an intervention on the tricuspid? Is there any change in the recent years locally in Hong Kong?
Well, I think we don't have an exact figure, but I would say we are now really more aware of it, and not just letting the patient to hang around in the clinic or in the outpatient without more intensive or aggressive treatment. So we don't know. I don't have a number, but we are getting more and more cases, and we are more aware about that.
Yes, I agree with what CY mentioned. Indeed, for example, in the past, always the tricuspid valve is the forgotten valve. And most of the time is for isolated tricuspid valve pathology. Most of the time, we won't operate on these patients. But nowadays, with the advancement in the transcatheter approach, most of the time we are dealing with those with isolated tricuspid regurgitation patients with a minimalistic approach. So this I would believe it would further expand the treatment population in this evolution in the transcatheter approach.
Dr. Lam, how about in your unit?
This patient is always there, I would say, because we are getting older and older population with previous mitral valve intervention. Then quite a lot of them has significant tricuspid regurgitation. Previously, we don't have many options, but nowadays we start to have doing some more tricuspid valve percutaneous intervention. But just as Professor said, sometimes the imaging is quite a big limitation because patient may also have aortic mitral valve surgery and make the imaging very difficult. And sometimes it's the imaging quality limited our procedure and may be left with a significant amount of residual regurgitation even after the procedure.
The rule is, if you can't see it, you can't clip it.
That's very true. If there's no further questions and comments, so thanks again for your fascinating talk, Professor Scalia. So let's move on to the next lecture. May I introduce the next speaker? So it's our old friend, Professor Vinny Bapat. So Professor Vinny Bapat was professor in cardiothoracic surgery in Guy's and St. Thomas Hospital, London, and is now the chief of cardiothoracic surgery in the Abbott Northwestern Hospital and Minneapolis Heart Institute in the USA. And he specialized in aortic surgery, minimally invasive surgery, and percutaneous treatment of structural heart disease. So he leads the research on valve-in-valve interventions. So every one of us know because we use the apps quite a lot, which is developed by Vinny. So he also didn't stop there. He was the PI for multiple innovative devices and intervention. So today, he's going to give us another talk. Today is a tricuspid valve replacement, surgical update and transcatheter tricuspid valve replacement now and the future. So thank you, Vinny. So you can start presenting.
Thank you for the invitation to speak on tricuspid valve surgery, current status, and transcatheter device options. These are my disclosures. First of all, apologies I couldn't join because I'm traveling to India. And I gave the similar talk last year. And in tricuspid valve surgery, not much has changed, except the fact that we're operating more isolated tricuspid valves. We know that very well that tricuspid regurgitation, the symptoms don't guide us like aortic stenosis and mitral regurgitation, and do not guide us in terms of early intervention. The recommendations are based on older evidence, and the guidelines essentially support only concomitant tricuspid surgery with a left-sided surgery, as well as, of course, primary TR such as infective endocarditis. We know that as the tricuspid regurgitation increases, although it's a functional disease, there are changes in the right ventricle, right atrium, but also in the annulus. The annulus tends to be large, and the measurements more than 4 centimeter in 4-chamber view are considered as dilated annulus. Recommendation of surgery is based on certain assumptions. One is that we're planning to do repair more than replacement. The repair we're going to do is a robust repair, which is essentially a ring-based repair. As you know, the panel A, which is essentially bicuspidization of tricuspid valve, and panel B, which is de Vega suture-based annuloplasty, is not very reliable long-term. But something like C, which is a ring annuloplasty, is more reliable, although the failure rates in 7 to 8 years are nearly 30%. And finally, of course, replacement is always an option. Pacemaker rates are not that influenced by repair, but with certain rings or with double valve procedures, the pacemaker rates are higher. We also see tricuspid regurgitation many times associated with pacing leads. If you look at the Mayo Clinic experience, 622 patients over the period of nearly 20 years, you see that pacemaker-induced TR was an indication in 42%. And in 58%, pacemaker-associated TR was found. That means one half of their population TR was caused by pacemaker leads. And when such thing is so, it's hard sometimes to remove the pacemaker leads, or the damage is so permanent that replacement becomes the only option. Tissue valves are favored more than mechanical valves for reasons that mechanical valve thromboses early in the tricuspid side. Repair, which is essentially leaflet augmentation, leaflet suturing to each other, that means bicuspidization, and sometimes lead separation and lead translocation in one of the commissures can be successful, as shown in these pictures. The 30-day mortality in this isolated TR population was 9.5%. This is one of our case examples from 2 months ago. You can see the lead has done two things. One, that the lead has caused a perforation, which you can see, which I have closed with a patch, but also the lead had gone through the cords, and you can see that once we removed the lead, we still had to repair the tricuspid with a patch and then place an epicardial pacing wire in this particular patient. Replacement is an indication when the leaflets are tethered. Our repair is based on the anterior tricuspid leaflet, but many times it's the septal leaflet which gets tethered and plastered, and hence even with pericardial augmentation, not repairable. I prefer replacement also in patients who have got large RV, who already have some liver pathology because of back pressure, and obviously, as I showed before, for pacemaker. I prefer to use a porcine biological valve. This is general trend in US as well as Europe. As you can see here, the data we have for tricuspid isolated surgery is around up to 2013. It's time again we look into it. And you can see that only 5,000 surgeries. And although there has been a steady increase now, the mortality also has come down with that. We are seeing more and more patients in our clinic for tricuspid valve. And when we don't have any transcatheter option, we look at them with CMR as well as echo, and then liver, of course, and then decide whether they are good candidates for surgery or not. And we'll be presenting that data soon in one of the surgical and transcatheter meetings in 2023. You can see that a lot of these patients do get tricuspid replacement. And with the current option of a valve-in-valve, sometimes I feel that may be a better option, although with replacement, the pacemaker rates are higher. What about the TTVR landscape? Last year when I presented, we had only 4 devices, and now suddenly the landscape is more crowded. We have got experience in more than 6 devices or 7 devices now, and more devices are coming on the horizon. So let's try and make some sense out of it. Why I think this is a 93-year-old who underwent a Navigate device in Colombia when I was there. You can see that if you get such result, why would you not consider it? And this is a patient we did through a transatrial approach in the early stages of this device development. Anchoring and sealing, unlike that of the mitral valve, is slightly easier for the tricuspid. RV systolic pressures, of course, we know are much lower than the LV. And also there is no risk of RVOT obstruction because the RV inflow and outflow, which is the infundibulum, are separated. The anchoring mechanisms essentially could be either annulus, leaflet, and cord. You can see here I've just shown 3 representative examples. Lux valve, which has got great experience in China as well as Canada. It fixes on the anterior leaflet with a clip, which you can see around at 11 o'clock. And then RVOT tab, which you can see around 5 o'clock. Intrepid device, on the other hand, fixes just by the shape and engages in the annulus because of a cork shape. And the tines on the stent engage with the leaflets, which you can see small tiny barbs which are on the stent frame. While the Evoke fixes around the cords with the legs, and also and the annulus by virtue of oversizing. RV shape and size is really important, and we have learned this over the last year, that RV, although feels bigger, the depth which we need to deploy the device is much shorter. What I mean by that is the perpendicular plane to the annulus is much shorter as seen here. So the apex to the annulus length may be 7 centimeters, but it's of no use when we deliver devices coaxial to the valve. Moderator band can come into play. It can obstruct the device the deployment, and so are the many cords and papillary muscle in the tricuspid. This is a Navigate device. This is deployed essentially from the left ventricle into the right ventricle to the right atrium. Here, the depth is not that important, but you can see as we open the device, the tines on the device can get easily caught in multiple papillary muscles, and we have to be very careful about that. On the other hand, with the Intrepid device, where we deploy in the ventricle, the good thing is you open the brim, align it, and deploy it towards the ventricle. The issue may be the right ventricular depth, and as you can see here, the capsule moves forward and then deploys the device. And again, we measure these depths on the CT scan and then decide whether we can release the device safely in the patient or not. We have also gained a lot of experience in presence of pacing leads. not just planning, but also inclusion, exclusion. And slowly what we are studying in TTVR is what is the effect on these pacemaker leads if we decide to implant a TTVR. And I think we are learning a lot from our EP colleagues. So if you are thinking of doing a TTVR, please get your EP colleagues involved. This is again, these are two examples, one of Intrepid and the other of Luxval being done with the pacing leads. And again, I think you need to have a backup in case these leads fail or there is a lead fracture happens in future. We have implanted micras in 1 or 2 patients in our experience. Very quickly, the device parade, Navigate is one of the largest experiences. It's a much shorter valve, which I showed you already before. The delivery system is either transjugular, transatrial, or even now transfemoral. Intrepid device is now exclusively transfemoral. More than 15 cases have been done with a dedicated delivery system. It's recapturable, retrievable, and a very forgiving device. The main limitation at present is the sizes, because majority of the tricuspid patients we see are very late. That means their size can be more than 50 millimeters. The oversize we use at present for all the tricuspid devices is around 2 to 5%. EVOLUT is again one of the largest experiences and currently under pivotal trial. There's a dedicated delivery system. It's transfemoral, and again, it has now we have got experience with even pacemaker wires through the tricuspid. Luxval, which I have already mentioned, has again experience. Initially, it was transatrial, now transvenous. You can see here the fixation depends on the anterior cusp and the interventricular septum. Advantage of this being there's less radial force and hence probably less conduction problems. A Vidine is a very unique device. It has valve anatomy such that you can implant it and custom made it up to very large sizes. The inner valve is 30 millimeter porcine pericardial valve and is deployed in a sideways manner. The tab is put into the RVOT, atrial cuff sits into that top of the atrium in that ledge, and then the rest of the valve is delivered into the ventricle and it opens sideways. Now they have done compassionate 6 cases and the last case has been successful and doing well. Trisol is a very unique design. This device we're going to see in late 2022, 2023. You can see that it opens actually in the middle. That means when in systole, it's the dome, while in diastole, it collapses in the middle. The advantage may be less stress on the leaflets and some benefit to the RV function. So more to watch this space as well. Lastly, but not the least, the devices which are implanted in SVC, IVC are similar to that, not addressing directly the tricuspid valve. Tric valve has the largest expansion in the world. A lot of experience now in Australasia and India and again Middle East and Europe. More than 300 cases. It has shown good outcomes and patients have survived up to 4 years plus. So more to watch, and the US EFS will start soon with Dr. Kapadia and Dr. Puri as their PI. And there are 2 unique concepts at present. One is Croy valve. You can see it's a stent in the SVC, and then there is a pedicle, and attached to that pedicle is this tricuspid valve, which you deploy within the tricuspid valve of the patient. And this is similar to Forma, which was a spacer. Only here is you have a spacer with 3 leaflets. Again, novel concept, hard to say whether this will work or not. And more importantly, once the RV remodels, whether it will stay in the central place or not. So to conclude, surgery is not uncommon anymore. In fact, most of the big centers where we get referred a lot of patients, we are operating more and more tricuspid. We prefer biological valves when we have to replace, but we tend to repair these patients if possible. TTVR is promising, of course, because it eliminates TR. We are learning a lot about anticoagulation, also about the risk of pacemaker after TTVR and how to manage it. And finally, but not the least, we have to assess durability in these patients. Again, thank you very much for this opportunity to discuss my experience in both these subjects.
Thank you, Vinny. Thank you. But unfortunately, I'm sorry that Professor Bapat's plane should have some delay. So we are sorry that he cannot join us live to have the discussion. But we can open the discussion to our expert panelists. So may I first invite Dr. Yeung. So how about your experience in tricuspid valve surgery, and what do you feel about the percutaneous approaches?
Yeah, the first thing I will ask all of you that is the caliper over superior than the replacement, because this question arises some problem when we do the tricuspid valve replacement, and the right ventricle function sometimes deteriorate, and the patient get very difficult to manage after operation. So that the surgeon usually repair the valve and use the tricuspid. However, there are a lot of new devices for replacement, and I don't know, especially when when repair failed, sometimes the patient hope to receive a replacement. However, I think that the clip is more superior than the replacement. I don't know all the other side here.
Thank you, Dolly. It's a good comment. So may I ask Dr. Tommy Ling? So I know you also performing surgeries for congenital heart diseases. What do you think about the tricuspid surgery so far?
Yes, thank you, Dr. Chan. So for most of the cases presenting with congenital heart disease patients, adult congenital heart disease patients, they are usually redo patients. So usually the cause will be due to functional dilatation, so it can be dealt with most of the time with just placing a ring for this group of patients and bring down the severity to like moderate or even better in most cases. But I do have some question for Professor. I can see from the slides that you mentioned that when patients present with a tether leaflet of the tricuspid valve leaflet, you usually perform a replacement already. For us, sometimes especially when we are dealing with our first two operations, surgeries, even if we see a tether valve leaflet, we still try to do a leaflet augmentation with bovine pericardium and then put a ring in. Is there any comment about this approach? What do you think about the durability? That would be the first question I have for you, Professor. And I also have another question, because in the earlier lectures, Professor Scarlett just talked to us about the use of tipping for TR. So how do you choose patients between tricuspid tipping and TTVR? Thank you.
It's a good question, so I can send to Winnie offline. So, and how about Dr. Lee? What do you think about valve repair, tricuspid valve repair with the patch enlargement? Do you do that, and what do you feel about that?
No, I don't do that, and because in Taiwan, the patient always concomitant left side disease, and in Taiwan we only do the replacement in the Epstein anomaly, and the others we usually use the ring downsize and the leaflet application or the chordate transfer to repair the tricuspid valve, and that's I don't know that we do not have much of experience of the augmentation.
So do you agree, Winnie just said, if there is a tethering of the leaflet, so go ahead for the replacement? What do you feel about that comment?
I don't know, because we will try ring repair, and if we have a problem, maybe that some year the TR become severe, we will do the valve in ring, but not do the replacement initially, because the replacement, if we use the tissue valve, 10 years later, the patient may need another replacement. So that we will use the repair first. And the patient usually tolerate the repair and downgrade the TR.
Thank you. So I'd like to divert the questions to our cardiologist. This is an embarrassing question. So what do you feel is like the tricuspid after the surgeon's repair? Is it good, not benefiting to the patients? What do you feel about, so far the post-repair tricuspid valve patients?
I think quite a lot of patients after repair still have some degree of residual TR. And it seems that with maybe after a few more years, the TR may get worse. But I think not much we can do. But I'm not sure if that anyone will consider tri-clip in patient after putting a tricuspid ring. I'm not sure.
Yes, I can supplement on this. So indeed, we have done or we have seen cases that we can do what we call the clip-in ring. So most of the time is because, of course, a valve-in ring is also a very feasible alternative. But sometimes if the annulus is too large, even after the annuloplasty, that's the valve-in ring would not be possible. In those cases, then we may consider the feasibility of the clip-in ring. And of course, the clip-in ring, the challenge would be, of course, again, is the imaging, because you would have the artifact or the shadow from the annuloplasty. So that would be also one challenge. But and if both the valve-in ring or the clip-in ring are not feasible, then perhaps we can consider would be another possibility would be the cable valve implantation would also be a possible option.
Actually, I have a question for surgeons. So we see that we are doing more from the presentation. We're seeing we're doing more isolated tricuspid open heart surgery, but the 30-day mortality seems to be quite static at around 8 to 9% in the early postoperative period. So when I assume that the surgeon sense are good enough, and so what the reason the mortality still kind of in that static level, would that be because of the patient selection when the patient has a very big RV or poor RV function that may affect the surgical outcome? And because as we always mention, tricuspid is a foramen valve. So actually, in the older days when we do the echo assessment, we really have to confess that not really doing too much about the RV function assessment in our echo. So would the surgeons think kind of more thorough assessment of the RV function, RV volume before sending you to the isolated valve surgery would be helpful in selecting a better candidate for the open heart isolated tricuspid valve surgery?
Yes, thank you for your question. I think for isolated tricuspid valve surgery is still a dilemma. On one hand, you're worried about the risk of the surgery, so we want to delay the surgery as long as possible. Not to mention that most of the patients are quite asymptomatic because of the symptoms have been quite forgiving. And however, when you wait too long, then the patient becomes heart failure and RV dysfunction. Then at that time, when we do surgery, as I said, the surgical risk will be much higher. And so I think there's still a dilemma for us about the optimal timing for surgery. But I do not have a good answer regarding the timing of surgery. So it depends on when the cardiologist refer the patient to us, honestly. When the patient refer to us, we already have severe tricuspid regurgitation with symptoms, and we will offer surgery. And regarding the risk and the mortality after the surgery, for us, I think it's not that high as 89% for myself, but it will be lower. But of course, it will be high risk for patients with chronic right heart impairment.
Thank you. Because I see Professor Kentaro is already here. Maybe we'll move to his talk and grab him into this discussion together later on. Okay? So let me introduce Professor Shuyashi Kentaro. Professor Kentaro is the Chief of Cardiac Surgery and full professor in Washington University, the States. He specializes in open aortic surgery, minimally invasive valve surgeries, TAVI, and endovascular thoracic aortic aneurysm repairs. So he's the site PI for multiple keynote trials, including the Partners trials, the Apollo, and etc. He is also the chair of Publication and Research Subcommittee of the Society of Thoracic Surgeons and chair of Michael Davidson Award of the Thoracic Surgery Foundation. He's going to talk to us about the transfemoral valve-in-valve or valve-in-ring implantation for failed mitral and tricuspid bioprosthesis. So welcome, Professor Kentaro, and the stage is yours.
Thank you so much. Can you hear me okay?
Nice and clear. Thank you.
Okay. Let me try to share this again. Well, thank you very much, Chairman and the selection committee. It's an honor to be invited. It's too bad that I cannot visit directly. I recently relocated from Boston to St. Louis, and I'm very happy to give this talk. So transfemoral valve-in-valve ring implantation for failed mitral and tricuspid prosthesis. It's a very, very wide topic. So I'm going to focus on mitral valve first, but I think the tricuspid part has a lot of implications, especially on the discussion that we were just having. So these are my disclosures. So this is the US transcatheter mitral valve replacements that are being performed. And this is FDA approved. So these are all either valve-in-valves or valve-in-rings. And they're not that increasing in terms of numbers over the years as people have expected. And the 1-year mortality and the in-hospital and 30-day mortality has not also been improving that much compared after around 2018, has been around stable. So when we talk about these valve-in-valves and valve-in-rings, of course, Dr. Vinny Bapat created this app. It's too unfortunate that he's gone because I'll be advertising this app throughout this talk. But one of the key things when we do a valve-in-valve is what we call a true ID of the valve itself. When you have a porcine valve, it's usually -2 centimeters from the size that is actually written. So if it's a 27 millimeter porcine valve, the true ID is usually 25. And if it's a bovine valve, it's usually 1 millimeter less. And the app will show all that. And it's actually a very, very useful tool. I'm sure everybody uses this when we do the procedures. So the problem for the mitral valve-in-valve and mitral valve-in-ring, the biggest problem is the LVOT obstruction. And it's really from the retained prosthetic leaflet or the native leaflet in case of valve-in-ring. So when you place a valve inside, this anterior leaflet, which typically when we do surgery is resected, this gets pushed towards the LVOT and causes an obstruction because it creates a cylinder. And there are several risk factors for these LVOT obstructions, but when it occurs, they're deadly. So this is a registry published by the Cedars-Sinai group. When there was an LVOT obstruction that occurred during these mitral valve-in-rings or mitral valve-in-valves, the procedural mortality was over 30%. And conversion to surgery was higher, and the percutaneous reintervention was higher with much, much lower technical success. And the risk of LVOT obstruction was much, much higher with valve-in-ring compared to valve-in-valve. So the risk factors for LVOT obstruction is four terms. So one is the depth of implant. If you implant this valve deeper, the risk is higher. If the degree of flaring is much, much more, then it becomes higher risk. If the angle of the aortomitral angle is less, then the risk of LVOT obstruction is much, much higher. And you can predict that from the CT scan. And if they have a septal bulge, that also narrows the LVOT and increases the risk. And you can predict this a lot from the preoperative CT scan. A lot of you have seen these CT scans before, but these are some of the risk factors that we see. And one of the things that we check for is this area called a nil LVOT, which is a predicted LVOT area after we place the valve-in-valve. So what is the magic number for this nil LVOT? This was, again, a large study from the Cedars-Sinai, and they saw that the cutoff value was 1.7. And if you have nil LVOT over 1.7, the outcomes were much, much better with less risk of LVOT obstruction. Some of the group have challenged this, and we are doing at a less nil LVOT numbers, closer to 1.5, and we also use some different phases but 1.7 is sort of the safety ground, and everything lower that becomes more of a yellow flag. And before, there was a lot of transapical mitral valve and valve that was performed. As a matter of fact, I did a lot of these back in the days when we really didn't have a great system. But now, a lot of these procedures are done through a transeptal approach because the outcomes are much, much better with a transeptal approach. And we all know that transapical procedures are less popular nowadays, and that is sort of following the trend as well because of these outcomes. So I do like to show a case here. This was a 65-year-old patient who had a previous CABG and a mitral valve replacement with 25mm epic. She had end-stage renal disease, and the STS risk score was very, very high. And 25 epic, the true ID is 21mm. So it's a very, very small valve. And this is the pre-procedural TTE. The mean gradient across the mitral valve was 15mm of mercury. And luckily, the Neil LVOT was very large. It was over 3 square centimeters, so definitely above that cutoff of 1.7. So the procedure, the first step is to perform a transeptal puncture. You want the puncture to be about 2.5 to 4 centimeters. It doesn't have to be that accurate with this procedure. Some people do it with ice, and you want it slightly posterior rather than right in the middle. And after you do a transeptal puncture, you use what we call a Gillis sheath, and you curve it towards the mitral valve. You can go directly with a pigtail without a wire. Sometimes you do this purposefully so that you don't catch the cord. And then you place a stiff wire. We tend to use a lot of safari wire in these cases. Then balloon septostomy is performed. You can see the waist here. We typically use 14mm Armada balloon for this, and then deploy the valve through the transfemoral approach. You can see that one of the challenges of transeptal approach is that the coaxility is slightly off compared to transapical approach. So you have to go very slow, and there are some techniques that I will show you later on that we can accommodate some of these troubles. So in this particular case, after the deployment went well. The valve looked good. The mean gradient was 8, but we thought it was okay. So she left without any problem. However, 1 year later, she came back with very, very tight valve with mean gradient of 24mm of mercury. She had class 4 symptoms. So after further discussion, we decided to take her back for a procedure. So because the valve was so tight, we decided to do what we call a balloon valvular fracture, BVF. And this is the actual image. You can see that after a certain while, this stent will completely flatten. And that's sort of what we did at this case. After we did the balloon, there was quite significant MR. So we placed another sapien valve, 23mm, and the final gradient was 7. She's out 2 years and she's still doing okay. So this was a successful case. So we actually published this in Circ Interventions back in 2018, and now in the app it will actually show whether the valve is fracturable or not. So a lot of people are doing these BVFs even for mitral valves in certain cases. So talking about the gaining coaxility, when the axis is completely off, there are several things that you can do. One of the technique is what we call a push-push technique, meaning we push the delivery system and then we push on the apical wire. That really stands the valve and allows you to gain some degree of coaxility. But when you look at it, the AP angle, it's still canted. So it doesn't fix that, but at least you know exactly where to position. The other way to do this is called a posterior deflection. You can actually add a complete flex and then rotate clockwise, and that will sometimes bring that coaxility into place. So here, we're putting more flex on, and then by twisting, it aligns the valve itself. So there are several things that you can do in these cases. So there are several things that you can do to treat LVOT obstruction, septal ablation. There's another technique called a lampoon technique. where you can actually lacerate the leaflet of the anterior leaflet of the mitral valve. However, when you're doing a valve-in-valve, you can do a much easier technique called a tip to base, and that is because the aortomitral curtain is protected by the mitral valve ring. And when you do when you don't really have to perforate the leaflet itself, you just have to cross, snare it, and then lacerate. So this is one of our case that we did the tip to base lampoon. This is after we grab the wire. Sometimes snaring that wire could be a little tricky, but we sort of pull. This was with my partner, my interventional cardiology partner. And after you pull towards, this is the ring right here. So you can see that the wire is heading towards there. And afterwards, you see a clear cut on the leaflet itself. And after that, you just have to do a standard mitral valve-in-valve. So we spoke a lot about the mitral valve-in-valve. I will talk briefly about some of the other techniques. So mitral valve-in-rings, there's 3 key things to remember. One is to look at the type of the ring. So some of the rings are better than some of the other rings. So if they're a complete ring, it's better. If they're circular, it's better. If they're semi-rigid or flexible, it's better. And when it's flat, it's better. So you sort of have to look at the type of ring and see which one's better. The second key thing is you have to oversize these to make sure that they stay in place. So when we usually use the S3, the cutoff number is usually about from 330 to about 430. But in mitral valve-in-ring, the area recommendation is much lower. We have to remember that when we do a valve-in-ring. The other thing is you have to watch out for what we call a valve ring dehiscence. So if sometimes, all the surgeons, we don't want to see this, but occasionally we see it. Sometimes the suture pull through the annulus. And when you have a ring dehiscence, and when you place a valve inside of that ring, it's not going to do anything. It's going to continue to have a regurgitation. So we have to know that there's no dehiscence before doing a valve-in-ring. Tricuspid valve-in-valve is probably the most easiest procedure. And the main part is the lack of transeptal puncture. And also there's no such thing as RVOT obstruction. The angle of the tricuspid valve and the pulmonic valve is just so favorable for this procedure. And we hardly ever see any RVOT obstruction. So it's a very easy procedure compared to the valve-in-ring. But some of the things that people discuss, one is whether we should put the wire in the pulmonic artery all the way. It's much preferable than putting in the RV in terms of popping out. So it's more stable, but sometimes the angulation becomes off axis. So that's sometimes a trouble. And when we do tricuspid valve-in-valve, we always do it in the RV, but we have to be careful because if we push too much, it can actually lacerate the RV. So we had some discussion earlier about the tricuspid valve-in-ring. So this is relatively an old study, but tricuspid valve-in-ring is associated with a very poor outcome. It's associated with very significant perivalvular regurgitation, and it's really because of the shape of the ring. It's not a complete ring, it's open. And in 3D, a lot of the surgeons will know, but there's 3-dimensionally in a different plane. So if you try to land a valve in these type of rings, you can see that there's always going to be a gap. And if you try to oversize, what's going to happen with this tricuspid ring is it's going to keep opening and opening. So it's sort of like opening a can, and you will create more perivalvular regurgitation that way. So please remember, outcomes of valve-in-ring is bad. And that is sort of the reason why Bapat was saying that he is replacing some of these tricuspid valves. And I agree with that statement. Yes, the tricuspid valve can fail in 10 years, but you have the option of valve-in-valve. But if you put a ring and if it fails, then the valve-in-ring is not a good option for those patients. The outcomes are not good. So we all have to remember that for the future. And that's why I think a lot of people are shifting towards replacement in this field. So, when you're doing all these procedures, all you need is the app. By advertising this much, I'm supposed to get a big whine from Dr. Vinny Bapat. So I will call him after this talk. So thank you very much for having me. It's an honor to speak in front of you and hopefully to meet everybody in person very soon.
Thank you. Thank you. Thank you, Professor Kanako. So welcome here first of all. So before we come to the discussion on the valve in ring, so I'd like to seek your comment on previously we just discussed about surgical tricuspid valve repair and replacement. So you mentioned that we are now shifting toward replacement. As a cardiac surgeon myself, also have the same feeling. So especially in those rheumatic patients, we don't repair that much. So if there's a little bit query about the leaflet quality, we just go ahead to replace it, especially the patient is still in a good condition in the tricuspid surgery. So what's your approach for those surgical decision on repair and replacement?
Yes. I think it's a little different when you're talking about a concomitant operation and an isolated surgery. So, we do a lot of tricuspid surgeries as a surgeon in association with mitral valve, left-sided valve surgeries. So whenever we're doing a concomitant tricuspid surgery, I will have a much, much higher threshold to replace that valve. I will try to repair that valve because the main issue is the left-sided disease. And once you fix, the right side is not usually the cause of it. So they will get better. And by repairing and by reducing that amount of TR, I think there's going to be a lot of benefit. However, if they're coming back as an isolated TR surgery, for the reasons why I mentioned, for future valve-in-valve option, here I will have much, much lower threshold to replace that valve. If it's a straightforward repair, I would still repair it. But if it seems to have some issue, then I will have much, much lower threshold to replace that valve.
Thank you. So one question further to that. Let's say patients with a previous left heart surgery and then come back to you later on with the tricuspid valve problem. So what's your approach? Go ahead for the redo surgery, catheter-based. Yes. What's your approach to tackle that kind of patients?
Yeah. I think these are the type of patients that we're going to see more and more. And my prediction is that in the future, these are one of the groups that will probably be preferably treated by transcatheter therapies. I will have to say that first. But if they're not a candidate for transcatheter therapies, and if they need an operation, again, they are coming in for an isolated tricuspid valve surgery. And going back to the previous discussion, the reason why these tricuspid valve mortalities are high is not because the surgery is difficult. Surgery is not, it's not difficult at all. I mean, tricuspid valve is very anterior and the visualization usually is not a problem. It's usually related to how sick the patient is. And, based on, like the previous discussion, it's the RV failure. And to replace a tricuspid valve on a severely RV dysfunction patient is also a risk. And those are the patients that will need some support for a short period of time. And, those are the patients that will have higher mortality. So again, going back to your question, I think I will have a lower threshold to replace that valve, even if it's a secondary problem to a previous left-sided surgery. But we need to have a better way to assess these RV dysfunctions ahead of time. And we have to operate on these before they get sick. Some of these echo measurements are just not good enough. And RVPA coupling, TAPSI, there's all these metrics that people use, but they're not perfect by any means.
I'm totally with you. So I open the discussion and questions for the panels and the floor.
Yes, thank you, Professor. So this is Ivan Wong from Hong Kong. So I would like to ask a bit technical about the mitral valve. As you mentioned, the LVOT obstruction is always the challenge. So I would ask, how would you choose between the alcohol septal ablation versus the lampoon if the patient really has the risk of the LVOT obstruction?
Right. I think there are some groups that will do alcohol septoablation and then wait 6 weeks. The issue with alcohol septoablation is that it's not risk-free. That in itself can cause a pacemaker risk, and it doesn't. The effect of the alcohol septoablation is not completely proven. If the septal branch is too small, it's not going to work. So, in some ways, it's somewhat unpredictable with some risks associated with it. If we think that the Lampu technique is going to open up that LVOT, then we would heavily weight towards that, because that's something that can be alleviated procedurally. One thing that I didn't talk about in today's talk is that when we calculate the Neal LVOT, we don't just calculate the Neal LVOT, but we also calculate a metric called a cuff Neal LVOT. This is something that my good friend Myra Guerrero has proposed. But what that means is that the sapien valve that we place, they have a cuff in about 50% of the height. So I think the height of the sapien valve is about 26 or 27 millimeters. But about 13 to 14 millimeters, there's a cuff that is covering the valve frame itself. So no matter how open it is, that cuff of the sapien valve can still cause LVOT obstruction. So we calculate the half of the height of the sapien valve, and then calculate the Neal LVOT as if all the rest of the cells are open. So that's what we call a cuff Neal LVOT. And if the cuff Neal LVOT is still very small, if that's like 1.4, 1.3, then we will be very careful because that means that even Lampoon's not going to open that LVOT. And those might be some of the patients that we may consider for alcohol septoablation. Or the other strategy that I also do is the transatrial valve and MAC with more of a surgical approach, cutting that leaflet, cutting some of the septum, and implanting the sapien valve under direct vision.
Thank you, Prof. And I'd like to ask Dr. Leung Tsai. So you also did a lot of valve in valve, valve in ring. So what's your experience? Can you share some of your comment?
It's for mitral valve in valve, that's our cutoff point is 1.3, and it's a porcine valve. For the sapien for the Perimount, it should be around 1.4 or 1.5 as the clinical say. And for the porcine valve, the leaflet is shorter, so that we like to do the porcine valve. And currently, if the Neal LVOT less than 150, we use the Lapin procedure, and we have done 5, still getting experience. And I have a question about the tricuspid valve in ring, because we did 2 cases, and the one is the 28 tricuspid MC ring, and the other is 26. The most difficult thing to do is decide what valve we should use. So the 28 we use the 29 plus 4, and only mild regurgitation, and the 26 one we use the 29 plus 2. So I think the measurement of the tricuspid valve is just not as the same as the CT or other image. You should use the balloon sizing. And the other thing, I think it's open get failed is no landmark for the area we should focus on the valve landing, the landing zone of the valve, because it's like the spring is open and we cannot see which one is the correct one. So that we usually put the HN side more, and finally that's the end up maybe that's a 1-9 position.
Yeah, I think tricuspid valve ring, I think the reason why it's difficult is right where the ring sort of collapse, it's in 3D, it's not in the same plane. So there's not a lot of room for an error. So if you have a good implantation, I think, it still works well. It may work well if you have the valve that has entire cover to it, because it will have no issue in terms of hitting that space. But I think that's part of the problem. But those are great results. But I don't think a lot of the places, even based on our TVT registry, we're starting to report that, and I don't think we're being able to replicate that result in terms of tricuspid valve and ring.
Yeah, you are right. Yeah.
So I have one more question for you, Professor Kentaro. So how about the mitral valve in valve fracturing the previous O valve? So now you show us the case that it comes back with some problem. So do you do the fracturing now routinely, or how do you select those patients intraoperatively? Who should frac and who shouldn't?
Right. This goes into the conversation of patient prosthesis mismatch. And if we believe that the valve is too small for the patient, then I think we will have that BVF in our mind. Some of the other things that will guide us is, number one, the gradient intraoperatively. If the gradient's extremely high, if the gradients are in the teens, we tend to do a direct measurement with that. And I think the other aspect is the shape of the sapien valve. When you look back at that sapien valve on the first appointment, it had a very significant waist to the sapien valve itself. And when they are not fully expanded, I think those are some of the ones that will cause what we call a pinwheeling and may have some effect of valve thrombosis. So, I think those are some of the factors that we think about. We don't fracture everyone because I know that BVF does have some side effects. It can cause some complications. So,
I see. So is there any other questions or comments from the panels from the floor? If no, I'd like to thank all of the speakers, all of the panelists. So we have a very good coverage on tricuspid valve in particular, and also we have a very good discussion on that. So I'd like to adjourn this section and hope you stay tuned. We are coming next to the other section. So thank you, everyone.
Okay, so good morning, everyone. So welcome again to the Hong Kong FAFS 2022 meeting. So I would like to introduce the section, one of the highlighted section of today, which is the structural heart intervention crossover electrophysiology / device therapy session. So I think this is one of the first experience for us to have a crossover between the two different subspecialty. So first, I would like to introduce our expert panelists. So Professor C.P. Lau, which is honorary clinical professor at the Department of Medicine, Queen Mary Hospital, University of Hong Kong. So he graduated in the University of Hong Kong in 1981 and received cardiology training in the St. George Hospital Medical School, Department of Cardiological Sciences in London. His main research interest is on cardiac arrhythmia, implantable device, and he has published over 500 international papers. So he is the past president of the Hong Kong College of Cardiology and also the president of the Asia Pacific Heart Rhythm Society in 2019. So another expert panelist will be Dr. Jojo Hai, is a clinical assistant professor in the cardiology division, Department of Medicine and University of Hong Kong. So Dr. Hai received her medical degree in the University of Hong Kong and obtained her cardiac electrophysiology fellowship at the Mayo Clinic, United States. So she is subspecialized in arrhythmia management, complex electrophysiological and ablation procedures, and also device implantations. So other expert panelists will include attendant Dr. Tao Chan from Macau, who is the attending cardiologist, Dr. N.Y. Chen, which is the consultant cardiologist and electrophysiologist in the Prince of Margaret Hospital. Dr. Andy Chen is the current president of the Hong Kong College of Cardiology and is currently in private practice, and also Dr. Mickey Kwok, which is the consultant cardiothoracic surgeon in the Prince of Wales Hospital. So first of all, I'd also like to explain the lectures, which is upcoming in the coming section. So first of all will be pacemaker ICD lead-induced tricuspid insufficiency, prevalence, pathophysiology, prognosis, and the ways to minimize occurrence. So it will be given by Dr. Joseph Chen, which is currently the head of division of the cardiology in Prince of Wales Hospital. So he received his training in electrophysiology in Stanford University in 1998. He was the president of Hong Kong Inter-Hospital Network of Pacing and Electrophysiology from 2010 to 2012. So his area of subspecialty is interventional electrophysiology and device therapy. So the next lecture, with the second lecture of this section, will be the management strategy and lead extraction for severe TR related to PPM leads and also ICD lead with a decision-making tools and skill set. So it's my greatest pleasure to introduce my mentor. So Professor Hong Fat Che is the chairperson and the chief of service of Department of Medicine in the University of Hong Kong and Queen Mary Hospital, and is currently the academic lead in the laboratory of cellular therapeutics in the University of Hong Kong. Professor Che is an international expert in cardiac pacing, electrophysiology, and cardiovascular regenerative medicine. He has significantly contributed to the understanding of the mechanism as well as the development of novel therapies for heart rhythm disorder. So the last lecture of this session will be tricuspid valve repair, surgical advances, and toolbox for transcatheter repair strategies for severe TR of different etiologies. It will be given by Professor Gilbert Tang, who is the surgical director of the structural heart program at the Mount Sinai Health System and the professor of cardiovascular surgery at the Icahn School of Medicine, New York, United States. So he completed his residency at the University of Toronto and underwent training in transcatheter valve procedure in Leipzig Heart Center and also the University of Pennsylvania. So Professor Tang has performed over 3,000 TAVR, mitral clip, transcatheter mitral and tricuspid valve replacement, TriClip, and also tricuspid valve repair and replacement. And he's the leader of a number of multi-center research projects in structural heart disease. So without further ado, I'd like to introduce our first speaker, Dr. Joseph Chen, for his talk. Thank you.
Thank you, facilitator, for the very kind introduction, and thank you for the organizing committee inviting me as an electrophysiologist in talking in this structural heart intervention symposium. So my topic today will be pacemaker ICD-induced tricuspid insufficiency, prevalence, pathophysiology, prognosis, and ways to minimize occurrence. So the talking about the prevalence of this problem and has been highlighted by the previous speakers is not something rare. The reported prevalence will be between something from 7 to up to 45% in some of the series, and also in can be even as much as 50% in some other series. And the degree of the tricuspid insufficiency associated with CIED mainly is in the mild 1+ 2+ degree, but sometimes they can be quite severe. But the problem with all these studies is that most of them are only observational studies. They have a variable follow-up period. Many do not study the clinical outcomes. It's just a report, a snapshot of the degree of the tricuspid regurgitation and reported in patient implanted with a CIED. And it's a mixture of different devices, including ICD, CRT, and pacemaker. Many of them are just reported using a 2D echo. Not many of them are actually Chinese esophageal echo. Some of them are just transverse echo. Recently, more of them actually reported using the 3D echo. And there's problem of the degree of estimation of the tricuspid regurgitation because of the strong reflectivity of the device lead, and sometimes can be underestimation of the tricuspid regurgitation. And the progression of the pre-existing tricuspid regurgitation in patient with CIED can actually estimated the problem in some of this patient. And there's also been highlighted by previous speaker, just doing a 2D echo can be a problem in identifying not only the severity, but also the mechanism of the tricuspid regurgitation. When we do a transverse echo using a 2D echo, we have to use different views, and sometimes it's very difficult to obtain in some patients, and in identifying which leaflets is actually affected by the pacemaker lead. And this is one example when you actually change the angle of the study of the echo slightly, the degree of tricuspid regurgitation can be from mild to actually severe and torrential. So studying the echo study is very important, and sometimes if not done properly, the incidence and the severity can be not well reported. So this is the usual case of a lead, ICD lead in the septal leaflet, impinging of the septal leaflet, and you can see the causing severe tricuspid regurgitation. And usually the tricuspid regurgitation is eccentric and sometimes not easily picked up. So this is the case with ICD lead actually in the posterior leaflet, and actually causing impingement and adherence of the lead to the posterior leaflet and causing severe tricuspid regurgitation. Excuse me. So the prognosis associated with the CIED induced TR, and it has been shown that it not only can cause more heart failure, and actually can cause more mortality as well. So the more near the TR, the higher the chances of mortality associated with this condition. And not only it actually causes mortality and heart failure, it can also cause progressively increase in the transverse annulus diameter and also the pulmonary artery pressure as well. So this is a progressive problem, and with time, it can cause a small problem. And also the prognosis, the mortality, when we do a multivariate analysis, and the degree of the TR is actually one of the predictors of mortality when you actually using a multivariate analysis and accounting for all the confounders that can cause us the mortality. Oops. Sorry about this. So what talking about the pathophysiology. Sorry about this. Okay. So the pathophysiology that causes the the truncated regurgitation. We know that if the lead is not in the central position or not between the commissure of the three leaflets, when it's adhered to the leaflet or is impinging on the leaflet, or there's an entanglement of the leaflet, or actually sometimes the leaflet actually can perforate the leaflet, just like in these cases. This can actually causes the tricuspid regurgitation. And you can see from a surgical series from the Mayo Clinic, looking at patient with CIED-induced tricuspid regurgitation, lead entrapment is actually in 4 out of 41, leaf perforation in 7 out of 41, and the leaf injury and adherence causing the rest. And you can see that many times when you have look into the surgical cases, or if you examine the lead explanted by transcatheter technique, you can see there's a lot of adhesion between the lead and the leaflet. This is some probably from the lead in the close proximity of leaflet causing inflammation and fibrosis formation, and this can actually causes problems with tricuspid regurgitation. And not only the leaflet, sometimes it's the subvalvular parameters. And this is actually causing entanglement of the subvalvular apparatus and causing the problems of the tricuspid regurgitation. And as shown, as I mentioned previously, if the lead is in the middle or between the commissure, then it's usually causing less problem. But if it is impinging on or adherent to one of the three leaflets, it actually can cause more tricuspid regurgitation. And these are just some of the 3D, echo image of lead in different positions. So the factors actually associated with tricuspid regurgitation, some of that you can predict before implantation. People has been proposed that silicone lead may cause more problem, maybe more inflammation. Active versus passive lead, and with the passive lead, with the times, when with the manipulation, you're more likely to cause damage, especially to the cordy. Large lead and the number of leads can actually make a difference. So the ICD lead, which is larger, usually causes more fibrosis around, and the more number of leads, obviously, the higher the chance of causing a tricuspid regurgitation. And during implantation, depends on the techniques. If the implant is very rough, you may actually cause laceration of the leaflet, the subvalvular, the cordy, the avulsion and transection of the perimeter can sometimes happen. The implantation technique, and people have proposed that the prolapsing techniques actually cause more problem versus the direct causing of the tricuspid valve. And there's also some studies saying the position of the lead, whether it is in the apical position, where you're more likely to impinge on the posterior leaflet, may cause us more problem. And after the implantation, if you do echo and you find interference of the leaflet, especially with the coaptation, the leaflet entrapment, the subvalvular support entanglement, and then the long-term problem, as mentioned with the lead close to the valve, is actually can have inflammation, fibrosis, encapsulation, and causing entrapment, and this can cause us more, tricuspid regurgitation. The problem with endocarditis, And if the lead need to be extracted, when with the extraction, you can see with the transcatheter extraction, you can see there's a lot of tissue actually was removed, with the lead, and that can actually imagine that you can cause significant damage to both of the leaflet and the subvalvular apparatus. And also with the TR, once you have TR, tracheal annulus can be progressively enlarged, and you have more TR. And there's also the problem of pacing induced airway and airway dysynchrony that can cause more tracheal regurgitation. So these are some of the studies looking at different factors that may affect the pacemaker-induced TR. And they look at the fluoroscopic image, whether the angle between the lead and the tracheal annulus, the angle of entry into the tracheal whether is high or low, or whether there's a lot of slack in the pacemaker lead. But none of them really actually has significant impact in this study, except with the echo findings, whether the lead actually is impinging on one of the leaflets. Actually, is the most significant predictor of whether you have tracheal regurgitation. So this another study tried to look at whether ICD lead versus pacemaker lead, whether the lead position, but none of them, or the select score, none of them actually predict, but only the echo findings of interference of the lead with the leaflet actually predict. So as mentioned before, when you are actually touching on the leaflet, you are more likely to cause tracheal regurgitation rather when the lead is in the central or in the commissure position. So this is a study actually from the primary group, and looking at the degree of the tracheal regurgitation, and also knowing that in the central or the commissure position is actually causing less a problem when compared to the lead actually touching on the leaflet directly. So what about pre-existing RV dilatation or tracheal regurgitation? And we know that if there is a pre-existing RV dilatation or tracheal regurgitation, you're more likely to have a more significant CIED associated tracheal regurgitation. So pre-existing TR is also a predictor, and the pre-existing increase in pulmonary artery pressure is also a predictor of tracheal regurgitation after the CIED implantation. So but the most predicting is actually whether the lead actually interfere with the leaflet after the implant with the echo assessment. So this is a study from Japan, and it showed that the tethering angle and also the tracheal annulus area actually is predicting whether you will have a significant tracheal regurgitation afterwards. So also when you need to explant the lead with a transcatheter technique, and we know that the older the lead left inside, the more the tracheal regurgitation is associated after the extraction. And the extraction can actually cause really significant damage, and actually shown this a function of the premorsal after the transcatheter extraction of the lead. And but interestingly, one may think that CRT having more leads may actually cause more problem. But the airway lead is actually not crossing the tracheal annulus, and we know that with the CRT that improve the airway function, maybe improving the synchrony as well. When compared to non-CRT devices, they actually causes less tracheal regurgitation. So a CRT device, especially with time, with the improvement in the airway function and the synchrony, actually causing less tracheal regurgitation. But what about leadless pacemaker? So one without the lead, is it actually free from tracheal regurgitation? So from this study, we know that it's not. It's actually a significant number of patients with tracheal regurgitation actually has leadless pacemaker actually have significant tracheal regurgitation. And this is from one of our panelists in the data, Dr. Har data, the primary group actually also shown that linear specific actually associated with some degree of tricuspid regurgitation, and especially if the device is closer to the tricuspid valve. So the distance between the pacemaker and the linear pacemaker and tricuspid valve actually predicts the degree of tricuspid regurgitation. And this study is actually by Dr. Harris from the micro, which is actually shorter, 26 millimeter. And this study is a mixture. About half of them is actually the nanostem, which is the longest. It's about 41 millimeter. And with the new screw-in pacemaker from Apple, the Avia is 30 millimeter. So from, if Dr. Har prediction is right, they probably will have more problems with tricuspid regurgitation. What about the His bundle pacing? Now is a trendy type of physiological pacing, and it has been shown that it's not associated with significant tricuspid regurgitation. Is it because it is not really crossing the tricuspid valve and that much, and therefore or there's a less dysynchrony associated with His bundle pacing? That's why it's not associated so much with tricuspid regurgitation. We are not so sure. But what about left bundle playing? Left bundle pacing is also so not to be very significantly associated with tricuspid regurgitation, but I think we need more data to say that for sure. So last but not the least, any way that we can minimize the degree of tricuspid regurgitation associated with CIED implantation. So from all the study, we know that the slack, the amount of slack, whether you enter the valve from a higher or lower position, doesn't really predict the amount of tricuspid regurgitation. Also, there's a study. I think I actually missed a slide. They tried to look at the the position of the lead. One study actually from primary group, they showed that if you implant the lead in a more apical position, you have more tricuspid regurgitation. But there's other studies showing the opposite, showing that when you implant in a more septal, especially in the alveolar position, you are associated with more tricuspid regurgitation. So we are also not there's no conclusive evidence showing that the lead position actually make a difference. So is there any way that we can actually minimize the tricuspid regurgitation associated with CIED implantation? There's actually no definite answer. There's no large randomized study showing the answer. But there's an interesting case series like this one. They actually use the transesophageal echo to guide the implantation of a lead in a patient with very high risk of lead associated tricuspid regurgitation, like patient with previous lead induced tricuspid regurgitation under extraction. And if you don't want to have another lead associated tricuspid regurgitation, so they do a transesophageal echo guide the implantation to make sure there's no lead leaflet interference and minimizing the occurrence of tricuspid regurgitation. But I'm sure this won't be a usual practice. Won't be you won't do TE guided implantation for everyone, because that will be not only more time and also cost consuming, but this may be useful for very high risk patients. So I'm going to conclude my talks. CIED lead induced tricuspid insufficiency is not a rare occurrence and have significant clinical implication and prognostic impact, not only heart failure, hospital admission, and also mortality. The most predictive CIED lead position relative to the echo is actually the only predictor. Only the echo findings after you put in the lead is the only predictors for a significant tricuspid regurgitation so far. And other related factors, including pre-existing RV dilatation and RV pressure overload, may also predict tricuspid regurgitation after CIED implantation. But there's no definitive and systematic preventive measures, except maybe echo guidance during implantation, that can prevent CIED-induced tricuspid regurgitation. So I'm going to conclude my talk here, and thank you for the attention.
So thank you very much, Dr. Joseph Chen, for giving us such an insightful talk. So we definitely learn more information about the mechanism and also the factors associated with lead-related tricuspid regurgitation, including new information regarding new emerging pacing technique with the conduction system pacing. So without further ado, I would like to introduce the second speaker, which is Professor Jie, which will talk more about the management strategy and lead extraction in severe TR related to ICD/PPM leads. So Professor Jie, please. Thank you.
Okay, so good morning. So it's my pleasure to be invited to this symposium and talk about how to actually manage patient with lead-related tricuspid regurgitation. Obviously, one of the potential way to doing it is actually remove the lead. Okay, obviously, one of the way to prevent it is not putting a lead when it is necessary. But obviously, when you're encountering some patient who have problem, then there's limiting option that we can actually manage the patient. So I think as alluded by a previous speaker, I think the most important part is how we actually can prevent and also to treat them. Obviously, prevention, as I mentioned, if you don't need to put in a lead, like thinking about whether you can using a leadless approach, like subcutaneous device if you're not needed, but also lead positioning. Finally, we're touching about how to actually manage the patient. I think, unfortunately, the cases are limited, and there's not systematic way to help us to guide how to manage the patient. But obviously, the controversy here is when we actually encounter those patients, so we go for lead extraction versus we send the patient to surgeon for direct repair and replacement. Obviously, as a previous speaker mentioned, there's a lot of different mechanisms. But by far, the most important mechanism actually causing lead-related TR is actually lead impingement and also damage the lead. Obviously, there are other potential confounding factors, like, for example, left ventricular dyssynchrony. So I was illustrating a few cases. Different mechanisms may have different impact in different patients. So in those cases, you may need to tailor-make the treatment approach for your patient and then how to try to optimizing the management. So again, this is what been previously been discussed. But I think one point I want to highlight here, the number of lead you put across the tricuspid valve actually causing more problem. So if you see one lead causing problem, you put another lead in, or when you do the replacement, you may actually encounter even more problem. So obviously, one of the solution here is if you don't need to take a lead, one of the options is if the patient has lead failure and also with TR, then maybe you should think about now upfront to replace the lead and then try to prevent additional too much lead inside the tricuspid valve and then to prevent the complication. So I also illustrating now in some of the young patients who have lead replacement or damage, be a bit more aggressive to extract the lead and then put in new lead so that minimizing the long-term consequence. So as a previous speaker mentioned, so this is the study by Professor Yeung's group to look at the lead position. So again, when you do the implant, obviously the impingement of the leaflet, like if you go for apical, you will tend to be more impinging on the posterior leaflet. If you more go to the outflow tract, then you may need to impinging on the septal leaflet. So I think you need to tailor the approach. Obviously, something in between, if you cause the valve in the middle part, then you're minimizing the damage. But unfortunately, a lot of time, you cannot control where you put the lead, unless you're really visualizing the position. As previously mentioned, whether you can using a TE guided, but I think in practice, it's quite difficult. So again, this has also been previously mentioned by the previous speaker. So can we using a leadless device? I think Dr. have nicely demonstrated. If you actually had the device actually touching the lead, it's also very harmful in this kind of scenario. So this is one of the case series that we presented. And obviously, in some of those scenarios, I think the distance, again, whether the device touching the valve. So anything you're touching the valve will be potentially harmful, okay, in terms of the mechanism. So now we focus on the treatment. So I think depending on the severity and the management, obviously in most of the patients, okay, in most of the cases, although it's moderate, mild to moderate degree, you can usually use medical treatment, like for example, diuretic, okay, sometimes you may managing the patient may have concomitant heart failure, then you need to treat the underlying condition. Then now if you actually have problem, okay, so the option now is whether you go for lead extraction. So if this is the device which just simply recently implanted, maybe simple extraction, However, if you actually had a more chronic implant, then you may need to using more advanced technique, like for example, using some of the extraction tools. And obviously, again, if you actually had other patients who actually have more severe damage in tricuspid valve, you may need to go for valvular repair and replacement in some instance. And finally, nowadays, there are also some evolving new techniques, like some of the percutaneous techniques. Now, some of the colleagues have been presented in this meeting in dealing with severe tricuspid regurgitation. So now this become a stage of irreversible stages. So in those situations, some of these new interventional techniques may have a role in some of those patients. But obviously, the limitation with some of those issues is if the patient still put in a lead, some of those devices can be difficult. Like, for example, if you want to put in mitral crib and even some of these THV into that position, can also impinging on the lead, and then they may also damage the lead and lead to other problems that you may need to encounter. So I think this is a kind of algorithm have been proposed, how to manage patient with lead-related problem. Obviously, you need to confirm the severity, okay, make sure there are no other concomitant factor. Then I think important thing is you need to have accurate imaging. So I think imaging by 2D echo sometimes is difficult, but nowadays we probably need a TEE with 3D echo to look at the mechanism of this TR in those particular patients. Are they really lead impingement? Are they really damaging a lead? But on the other hand, even I show you some of the cases, even with TE, it can be difficult. With the lead in situ, and not until you actually remove the lead, you don't know what happened. Okay, and also more important, you need to confirm that this is a severe TR. Now, when you confirm the severe TR, after that, I think the most important thing, as I mentioned here, is can we actually able to demonstrate whether this is actually a direct impingement of the lead, and then that actually dictating what we actually need to do. So I think, again, the imaging is very important to look at the leaflet and actual mobility and coarctation. Again, if you actually have the patient with concomitant left ventricular dysfunction, then you try to optimizing the management of patient with left heart failure, maybe think about a CRT. In those patients, if the pacing-induced left ventricular dysfunction, that may contributing to the TR. However, if it actually is really the mechanical problem causing the TR, then I think the option here is either we go for lead extraction, we observe. If the TR resolve, then we may be just medically managed. Okay. However, if those cases, or if you're really damaging lead, then it may be even go for direct tricuspid valve repair and intervention in those scenarios. So let's look at some of the cases. Okay. So if really you see a patient with severe tricuspid regurgitation relating to the lead, so what you're actually making a decision how you manage those patients. So this is a patient referred to us is actually had a pacemaker, and unfortunately you see that he actually had a lead-related severe tricuspid regurgitation. And if you look at the 2D echo, it seems like that the lead is actually impinging on the septal leaflet. Okay, so I think that is one of the potential and common mechanism, but you see that it's actually very severe right ventricular dilatation already. Other thing is, when you look at that, you're still not really sure whether the lead is actually perforating the tricuspid valve in this instance, whether this is actually contributing to the TR in this particular patient. So after some discussion, so we talk to the patient, so we go to a TE, it's still kind of difficult, so there's some suggestion of perforation, but I think the option here is either we go for direct, go for TR, tricuspid valve repair and replacement, or we just try to take out the lead as a trial. So after some discussion, we go for a lead extraction first. And first thing, we're actually using the mechanical device. Now you see that we're extracting the lead. So this lead has been there for like 5 years. Okay, so we expect that hopefully not that difficult. But unfortunately, things usually happen. So when you try to extract the lead, you see the break. So you see actually remaining fragment of the lead actually still within that. So again, during those procedures, we always use TE to guide it because we want to look at the valve morphology, actually what happened during the procedure. And unfortunately, you see that there are fragment of the lead, okay, because we failed to lock the lead. So this particular HO lead is passive lead. So we start trying to using a snare. It's now hinging in the SVC, okay. Unfortunately, we failed to do that. And then eventually what we're going to do is we're using a biopsy forceps and then grab the lead, and we're able to completely removing the lead. So we successfully moved the lead, but I think the problem is here is we still need to know how we'll outcome with the TR in those patients. So you see that we failed to using a snare. So now we're using a biopsy forceps. We grab the lead tip, okay, and using a long shift. And eventually after, actually quite a long procedure, okay, we try to grab the lead tip. And eventually after we're able to grab the lead tip, we're able to successfully removing that. But it's not easy. A lot of time when you actually had this kind of difficulty, partial removal, so not always easy. But with some effort, you see that finally we're using a biopsy forceps, we grab the lead, and then we completely remove every part of the lead in this particular patient. So I think the next now we actually need to go back to look at that. So we do the TE. You see that at least the degree of TR is actually reduced. Okay, comparing to what initial, you see that quite severe. But however, this patient still have quite severe dilatation of the right ventricle. So again, we're also doing a 3D TE. So this is the area we actually see that before and after the extraction. So you see before the extraction, in fact, you have a few area which is leakage here. Although after the extraction, there's still some, it seems to be improved. However, you will look at the location, it looks like that some of the leaflet is actually perforate. Okay, so in this particular case, there may be still a issue or progression. And obviously, when we do the lead extraction, it always potentially damages the leaflet, especially when the lead is actually causing the tricuspid valve. If we do the extraction, we always inducing injury on its own on the tricuspid valve. So eventually, we follow up this patient for almost 1.5 years. Unfortunately, the TR progressively getting worse. And eventually, this patient go for an open heart repair of the tricuspid valve. And interesting, when the surgeon opened up, they actually a 2 perforation. So in fact, somehow during the initial lead implantation, they already have a lead perforation. And the second time, the lead also perforating the tricuspid valve. And subsequently, when we remove the lead, there are 2 holes. So that's why even you extracting the lead, sometimes if you actually due to the lead damage, you are not able to relieving all the TR in those instances. So that's the second case. So this is also interesting case present to us. This patient had a pacemaker implanted in a other hospital for 6-minute syndrome. Unfortunately, somehow they have the lead, atrial lead in a kind of odd position. And actually, this patient, after present to us with right heart failure symptom, in fact, one of the leaflet will be actually impinging by the atrial lead. As a result, they're actually inducing not only TR, but also tricuspid valve stenosis in this instance. And over time, actually, there's some fibrosis and adhesion, and you see actually a significant gradient across this tricuspid valve. So again, we go for the TE in this patient. Again, you can see the leaflet. You see this atrial lead. In addition to the RV leads, which is actually quite nicely crossing the middle part, unfortunately, the atrial lead is actually impinging on the septum or septal leaflet, so that they actually impinging the movement and somehow lead to some fibrosis and adhesion. And as a result, they actually need to tricuspid stenosis in this particular patient. And again, in those cases, we actually go for an extraction for this, obviously because the atrial lead is impinging on the valve, and we actually replacing with the lead actually got back to the apical, the appendage position in those particular patients. And after the extraction. So now this is the imaging. Let me show that this is. Oh, it's not moving. Anyway, so after that, we can show you, okay, you see that the degrees of turbulence is actually reduced, okay, in terms of the severity of tricuspid stenosis after the extraction. And again, if you look at the gradient across the tricuspid valve, you see there's significant reduction in the gradient. So I think those are the cases you may also try to contemplate removal of the lead in those instances. Finally, if a patient has some kind of left heart problem, probably inducing by pacing, is actually lead extraction and also to try to change to a more physiological pacing will be potential benefit in those scenarios. So this is another case actually referred by our pediatric colleagues. So this patient had congenital heart block. So you see that this patient had epicardial pacing and then also eventually need to transvenous pacing. And unfortunately, he actually developed some heart failure symptom. So if you look at the echo, you see there's left ventricular desynchrony, but also at the same time, you see the right ventricular dilatation. So again, In pediatric patient, it's difficult because of heart growth. So when you see become the lead is actually strictened, the actually impinging on the leaflet of the tricuspid valve. And also this patient is due for replacement of the pacemaker. The HO lead is also failed. So with all this indication in mind, then I think in this young patient, only 20 years old, so we decide for maybe we take out everything, okay, and then replacing with a more physiological kind of conduction system pacing. Does it actually helpful in this particular patient? So this patient also actually start to have some impaired exercise capacity before the replacement. So again, this is the procedure. So we did the echo. So this is the echo before the procedure. You see that the left ventricular synchrony because of dyskinesia, but also a moderate degree of tricuspid regurgitation, again, with this patient. And also you see right ventricular dilatation. So what we decide is actually we go for extraction. You see that we extract all the 2 lead, okay, using a mechanical conventional device. And then after the replacement extraction, we go for a more physiological pacing. Now we're using conduction system pacing. Unfortunately, I forgot to bring the ECG. You see a nice reduction in the KRS duration, and the KRS duration reducing by 160 milliseconds down to 120 milliseconds. So you see that with this, it's actually go to the left bundle band area, and also we put it back lead to the atrial location. So I think this is the echo, the latest follow-up. You see that the left ventricular function is improved. RV is still a bit dilated, but you see the degree of tricuspid regurgitation is also improved in this particular patient. So I think in some of those patients, if you restore the left ventricular synchronicity, you can also be helpful in some of those patients to reducing the TR. So in conclusion, I think I hope to demonstrate to you, obviously, if you encounter the patient, I think it's important to analyzing the mechanism related to position. But in some patients, selected patient, if you're able to extract the lead, you may able to, as a potential option, before you send the patient to the surgeon for open repair and replacement. Thank you for your attention.
So thank you very much, Professor Jia, for giving us such an enlightening lecture. So we definitely can learn different mechanisms of TR induced by transvenous leads and how to stratify patients to different treatment modalities. So I would like to invite the expert panel to share the opinions regarding this discussion topic. So may I ask the expert panelists for opinion?
May I start? Perhaps a question is, we always think that left bundle branch area pacing may reduce the incidence of tricuspid regurgitation. But as shown by the article that Dr. Joseph Chen had shown, there is definitely significant tricuspid regurgitation. And it was, in that report, it was very similar to apical septal pacing. Subsequently, there is a report to suggest the distance of the tip of the left bundle branch area pacing with respect to the tricuspid valve may have an effect. Joseph, do you have any comments on that?
Thank you, Professor Lau, for a very good question. So I think there's quite a lot of problem with the left bundle branch pacing. First of all, we do need more manipulation of the the delivery sheath within the RV, and that can be a potential problem in inducing more tricuspid regurgitation, especially in damaging some of the subarachnoid apparatus. I mean, and I think there's another problem that can be associated. There can be a problem with the left bundle branch pacing with the TR. Is sometimes, especially if you implant a quite proximal septum area, sometimes you are more likely to get trouble with interference with the subvalvular apparatus of the tricuspid valve. So that this is not well studied. I think we need more long-term data to know about this. But for sure, left bundle branch pacing is not going to induce as much LV dysynchrony than with the conventional pacing. But we're also not sure about LV dysynchrony. So just capturing the left bundle itself, to me, can actually induce more RV discipline. So this area we should look into, but I don't think we have a lot of data in this.
I agree. This is a developing area. Theoretically, if you have a more deep away from the tricuspid valve to get left bundle branch area pacing, there are longer lead inside the right ventricle, and therefore may have the similar effect to a right ventricular septal pacing, especially if it is pointing up, so it is more or less impinging on the septal leaflet. So some study, I think by Zhang Shu's group in Beijing, measured the distance on the tricuspid valve. The shorter it is closer to the tricuspid valve, the amount of septal leaflet impingement may be less. But obviously, these are observational studies. We still don't have a good method of understanding it, and we do need more data on this.
I just wonder, Professor Xie, and so if just you found that soon after pacemaker implantation, after implantation of the transvenous V-lead, and you find that there is more significant TR, before the patients become symptomatic, would you take the chance to change the position of the lead so that it may prevent a future problem?
Well, obviously the problem is a lot of patients, we don't actually do the echo a lot of time before the implant. So obviously you will see very severe. The issue is whether you will be able to take out the lead. In most instances, the patient can be medical managed. Okay, so I think, again, the option is when it's early on, within like few weeks or few months, you can simply still extracting the lead. The problem is if we extract the lead, if the patient needs the pacing at the end, you still need to put in something. So those kind of things can still be important. But I think you just want to comment, Professor Lau question. I think two things is when we do the left bundle band area pacing. So one thing is you actually have the shift to protecting. So I think the chance of perforating the valve is less. If you actually go your shift all the way to the outflow tract and pull back, then you don't have less chance to actually get the lead direct penetrating the valve. I think this is one of the advantage. The second thing is, as I mentioned, so you will look at now the pacing, the case I show you, we tend to go to a more middle to lower part. You see the lead is actually like in a 90-degree rather than like a 45-degree. And I think at least in some of those cases, we do TE, we dose extraction, and then we implant. You get the lead in that particular position. The degree of TR is actually less. And obviously, any lead causing the valve can still lead to some degree of TR, but I think we can try to minimizing that to put in more lower positions so that have not acute angle that can potentially reducing the chance of the TR.
And of course, some of these leads are luminous, so they would be thinner, and therefore the potential for damaging may be less. But I absolutely agree, yes. Would you, from a radiological wise, would you have the lead horizontal so that you may have a higher chance of getting less impingement? Because we seldom use echo to guide our implantation.
Yeah, most of the time if you go to the you see the case I show you is very horizontal. You tend to get the lead to more horizontal position. So now we have probably implanted more than 200 cases. So when we look at the degree of TR, and at least in our impression, it's actually a bit less than the usual apical position. And then we tend to go a bit more horizontal in the aerial position so that we're actually not impinging on the valve as much.
Thank you. So may I invite Dr. N.Y. Chen. So what's your experience? Do you do conduction system pacing in your center, and whether there will be a very significant incidence of lead-related TR regarding those kind of leads?
Thanks. Yes, we do conduction system pacing too. In fact, I believe that even for the conventional device implantation, tricuspid regurgitation is kind of under-recognized condition. Honestly, we don't encounter a lot severe tricuspid regurgitation, even for the conventional type of device implantation. And for conduction system pacing, as commented by Professor Se, Professor Lau, and YS, I tend to believe that it's associated with less tricuspid regurgitation, but we don't have a lot of conduction system pacing, and my observation may not be fully correct. I do have a question for Professor Se. As you mentioned, you need to wait for a while before you know whether the lead extraction for the severe CIED-induced TL work. So in your experience, what proportion of patients would you be successful just by lead extraction and saving a surgical procedure for those patients?
Well, I think in our series, not that large. I think, I mean, we have 2 cases. So as I show you for just TL, not TS, 1 case is successful. We don't need to do any surgical repair. Second case, we need to go for surgery. I think the success rate after the lead extraction very much on the pathology. So in this case, if the lead is perfect, so whatever you take out, you still have 2 holes. I mean, unfortunately, in those instances, lead extraction will not be helpful. But if it's just mechanical inducing, I think at least you will get to from severe to moderate. A lot of patients can be still medically managed without saving to send the patient to an open heart surgery. And again, the issue is a lot of those pacemaker patients are quite old. If you send for a open heart surgery, it's still not trivial. And also the other problem is even you do the surgery, you may also have potential risk of damaging the lead. Because when you open up, I think that maybe the surgeon can tell us, but if you send a patient who actually had a TL related to lead, then you may still need to put in the pacing, unless we do epicardial pacing at the same time. So things will go downhill and then become complicated. Yeah.
But may I ask Professor Chair and the panelists, what would you put in after extracting the right ventricular lead for the purpose of avoiding the TL? What would be your final system if you have everything in your choice?
Well, I said, again, if you need to do the extraction in the same section, we do the TE, we try to put the lead back. So that's one option. Other option is obviously try to put the leadless, and then again, try to not touching the valve, get a good position. And if unfortunately the patient needs to send for surgery, then I think we need to send the surgeon to do epicardial pacing at the same section. You need to open up the heart.
You won't do a left ventricular only pacing in that setting because we don't want any further damage by a tricuspid valve.
Yeah, I think people are advocating his bundle pacing and also LV pacing alone. But his bundle pacing obviously have some limitation about the stability, and then if a patient actually have a major procedure, you don't want to go in again. So I think the long-term durability is the issue. And LV pacing alone from the CS also can induce desynchrony. So I think if you're just pacing the LV alone, it will be also causing problem. But I think in some of these congenital heart scenarios, we actually have a few cases, we actually just put in a CSD for those instances, yeah.
I want to listen to Joseph comments on this question, because I noticed that Joseph did a lot of his pacing with very good results. So would you actually do a his pacing or LV pacing or LV plus his pacing in those cases?
It's a good question. I mean, LV plus his pacing probably is something that we can consider. I mean, for his pacing, there are obviously problem of long-term, the threshold can increase with time, even though if your acute threshold is good. I mean, I wouldn't say I do not have this problem. We do still have a problem with, long-term threshold with his pacing. But some of the cases of his pacing, they are doing very good even in long term. But as Professor Jian has mentioned, we have to individualize this patient since the patient already undergone like a previous implant, a transcatheter extraction. So we try to avoid a further procedure in this type of patient. So I think I don't have a perfect answer. I have implanted just LV pacing alone in some of the patient with tricuspid replacement. So it works, but pretty good in some of the patients. So I think LV lead alone, if you're not too worried about the synchrony long term, or you can try to, if the patient have some own intrinsic conduction, you can actually use a kind of adaptive CLT kind of algorithm. That can actually be a good option. So, to me, a leadless or just LV pacing alone may be my, my options, my choice.
Thank you, Dr. Chen. So may I ask Dr. Andy Chen if you have any experience regarding the suggestion on treatment of lead-related TR in general?
Thank you. Usually, if a patient don't have the heart failure symptom, we may not do a regular echo to detect the TR. I think as shown before, many patients did have TR, but fortunately, in my experience, not too many patients develop significant TR that need to manage. But one question I want to ask the Wise or Professor Shea, is it useful to have some regular surveillance echo after the pacemaker implantation? Is it useful to detect early the TR and to prevent the progression?
Well, obviously, as I say, in most of instances, I will show you algorithm. You probably manage them medically. So unless the patient is symptomatic, I don't think. Well, obviously, those patients need pacing. So I mean, taking lead out and then putting in lead is not a trivial procedure anyway in a lot of those elderly patients. So if they are not symptomatic, I probably just simple medically manage. But if patient has symptoms, you obviously need to do echo. But if it's just routinely doing a surveillance echo, you find something, I'm not sure whether we will intervene, at least surgically or take out the lead at those scenarios.
So thank you very much.
Sorry. Okay.
Yeah, sorry. Please go on. Sorry.
Sorry, I agree with Professor Jia. I mean, just a routine echo may not be very helpful. As I mentioned, there's a lot of limitation with routine 2D echo. You probably, even if the patient have quite significant TR, you sometimes just miss it if you are not really looking for TR in the echo. So I don't think a routine echo after any CID implant is our usual practice.
So thank you very much. We definitely have a very amazing discussion regarding this topic. So I would like to introduce the upcoming lecture, which will be given by Professor Gilbert Tan in the United States regarding tricuspid valve repair, surgical advances in my toolbox for transcatheter repair strategies and for severe TR of different etiology. So may I invite Professor Tang to give his lecture? Thank you very much.
Hello, can you hear me okay?
Yes, yes.
Okay, great. I'm going to share screen now. Thank you very much. Can you see these slides?
Yes, yes. Can we? Yes, yes.
Okay, great. Okay, well, thank you very much for inviting me, to present on the tricuspid valve repair surgical advances or transcatheter valves repair strategy. I'm going to focus on the repair since Vinny Bapat already talked about replacement. 多謝你哋邀請，你哋好。These are my disclosures. So we know that after isolated TR, the prognosis is quite poor, whether you're symptomatic or asymptomatic. And we also know that there are more worse survival and more cardiac events. We also know that the percentage of patients undergoing isolated tricuspid valve surgery is also very low. There are now currently guidelines in the ACCHA showing clear indications for tricuspid valve surgery, especially in patients with symptomatic severe and also at the time of left-sided heart surgery. There was two prior speakers talking about lead management. There's actually some guidelines in this JACC paper a number of years ago talking about actually tricuspid valve repair replacement as an option in patients with lead-related TR. Now, looking at the tricuspid valve surgical volume, you can see that here, in the 50,000 plus patients, this paper is now a little bit dated, almost 10 years old, but you can see that despite what most people think that the surgery is high risk, the actual risk-adjusted mortality has improved with time. And you can see that here, this particular systematic review or meta-analysis show that it's also improved with more recent data out there. And you can see that early mortality was 3.9%, but late mortality was 2.7% per year. So I think the first question is, when may transcatheter therapy prefer over surgery? In the United States, there are actually no transcatheter devices. I know there have been a number of devices approved for CE mark in other parts of the world. Typically, these patients who are included in the trial would be considered higher prohibitive risk for primary re-op surgery. The other thing that would be consideration is favorable tricuspid anatomy and good TEE imaging. Right ventricular lead, as previous speakers talked about, is not a contraindication. It is goes by case basis. And also, we typically, for repair, at least we avoid severely dilated annulus or right ventricle very poor function. So we know for surgical tricuspid valve repair, the three principles similar to mitral valve repair. It ensures the leaflet coaptation and mobility, stabilize the annulus, and avoid conduction injury. This is a review paper that our group from Mount Sinai published recently on looking at the innovations in tricuspid valve intervention, focusing on tricuspid valve repair. And you can see that historically, there have been a number of techniques that evolved by surgeons on repairing the tricuspid valve. And interestingly, a number of these techniques have been mimicked via a transcatheter approach. Currently, I would say that the mainstream default intervention is the ring of annuloplasty. As we've shown that, for example, suture-based repair, such as the Vega repair, has not stood the test of time. And you can also look at the Clover technique or Hetzel repair have been shown similarly with transcatheter repair with like an edge-to-edge or with a bicuspidization strategy. So here's the transcatheter tricuspid landscape out there. You can see that, as I mentioned before, some technologies have mimicked actually surgical techniques such as direct suture annuloplasty, direct ring annuloplasty, coaptation enhancement, and even valve replacement. However, some of these devices are no longer in development, such as TriAlign or Millipede. Now, there are a number of challenges in device and trial designs in terms of tricuspid valve intervention. The heterogeneous patient population, imaging is clearly a prerequisite. However, the imaging requirements and parameters are different across devices. The anatomic criteria for enrollment is also different. The clinical endpoints are harder to define. It's not just mortality or rehospitalization, but perhaps even functional outcomes or even physiological improvements such as remodeling. And of course, if you have significant residual TR, you may still carry a poor prognosis. There are a lot of papers now published on the tricuspid valve on transcatheter approaches, not just in terms of intervention, but imaging. And this is a seminal paper talking about imaging for the tricuspid valve. You can see that there's some of the basic views here. And you can see that recently there's a state-of-the-art paper on intra-procedural imaging, looking at transcatheter intervention with different devices. And you can see that here, that depending on which type of device you use, the imaging requirement for procedural success can be variable. Now, we also learned that it's no longer just mild, moderate, severe TR. In fact, there are patients with more than severe called massive torrential TR based on quantitative evaluation. So I think we need to separate these patients out, and most of the current clinical trials are doing that. So I will just go over here, because edge-to-edge repair from a transcatheter approach is the mainstay therapy on how to screen these patients. So typically ask what leaflets are involved, how many leaflets. We actually now learned that tricuspid valve is no longer just a 3-leaflet valve, and sometimes can be 4 or 5 leaflets. Are the leaflet length adequate for grasping? Are they thickened or severely tethered? Is there a lead in the way? Where is the jet, and is it eccentric, and where is the gap? And finally, how rotated is the right ventricle? Is there any acoustic shadowing from other structures such as aortic valve, mitral valve, or the lead? And finally, even eustachian valve, can play a role in terms of technical success in these procedures. So this is a summary of some of the key TEE views looking at evaluation of a tricuspid valve for transcatheter edge repair or TEER. You can see that particularly important RV inflow explain views, the deep esophageal grasping views, and finally the transgastric short axis views. We also talked about that there are, in fact, more than 3 leaflets on the tricuspid valve based on echocardiographic imaging. You can see that here. Obviously, the majority of them are tri-leaflet, but you can see 32% of patients on echo has a type 3B morphology, meaning they have actually 2 posterior leaflets, or what we call a deep indentation between the P1 and P2 segment. And in fact, if you look at this intraoperative image from Leipzig, you can see that it correlates actually with the type 3B morphology with a very deep P1 and P2 segment indentation in between the two. Now, I've come up with some of the commonly established, perhaps, variables that will determine if TEER will be difficult. This has been kind of put together from the mitral valve side, but certainly I think it's important to consider that for the tricuspid as well. Certainly the triclip 3-4 that I've got the most experience with, not part of the Pascal trial. Certainly if you have 3 leaflets, long septal leaflet, none of mild tethering, small gap, good coaptation reserve, no cords in the way, no horizontal right ventricle, no leads, and no shadowing, it should be a relatively straightforward case. However, as you have more of these other variables in the way, like larger gap, moderate tethering, horizontal right ventricle, lead maybe in the way, then they get more and more challenging, particularly with shadowing of the septal leaflet. In fact, the coaptation gap has been consistently shown to be a predictor of procedural failure. So the larger the gap, the more likely it's going to fail. So what I meant by leaflet coaptation reserve, and this is a concept that has published on the mitral side by Paul Saraja recently, is the whole idea of the symmetry of the 2 leaflets. So on the left side, you see the V is symmetric and the leaflets are long. With smaller gap, you're likely to have an easier case, but if the gap is larger, it can be harder. Now, if you look at the middle image, if you have this asymmetric V where the septal leaflet is more tethered, if you have smaller gap, you can still potentially tackle this, particularly if the septal leaflet is long. However, if the gap is larger, or if the septal leaflet is more tethered, it's going to be more challenging. Then finally, if you look at the right side, essentially what we call flattened V, the 2 leaflets are completely facing each other. These cases are going to be extremely difficult because as you try to grasp this leaflet and close the clip, the leaflets may slide out because there just be so much tension on the leaflets, or even maybe injuring the leaflet. So keep that in mind in terms of the morphology of these leaflets as you screen these patients. Now, why is right ventricle orientation matter in these TEER cases? You can see on the right side that when you have a more horizontal right ventricle, you have to turn a more sharper angle to steer, and sometimes what you call a septal hugger, meaning that your trajectory towards the tricuspid annulus is no longer coaxial, so making pulling up to grasp, especially in the situation of asymmetric V with larger gap, extremely difficult to try to do even with independent grasping. So it has to more of a steering situation rather than just grasping alone. Now, we've learned a lot in terms of imaging for the tricuspid valve, and so we routinely now look at multiplanar reconstruction, or MPR, to try to get all the different views of the tricuspid valve in one to optimize grasping. You can see that here, you have the RV inflow on the top left, you have the grasping on the top right. You actually have some kind of what we call a transgastric view equivalent on the bottom left and 3D on the bottom right. So you can actually see all the different views in one image. Now, of course, you have to have your raw image really well quality or high quality to be able to fit, to be able to show this in a reconstructive manner, because the resolution does drop a little bit. One thing we've also done, the complementary is 4D intracardiac echo or ICE. So we have quite a lot of experience now using 4D ICE in conjunction with TEE to do these TEER cases. You can see that there's an example where if you have acoustic shadowing of the leaflets, the ICE typically will not be an issue. And you can actually use the ICE to confirm your leaflet assertion, as you see here.
Now, you do have to watch for what we call this AP canyon because there's really no leaflets there to grasp. So you have to really watch that you're not trying to grasp the area and miss one of the leaflets. And especially this is where you would not be able to grasp. And this is the gap that you try to reduce. And so you don't want to put the clips in this kind of orientation and then potentially open up this AP canyon further. And this is what we meant by that. So if you look at the surgeon's view on the left side, we flip it around to become a transgastric view. This is kind of the orientation. You clearly do not want to be in this situation where you open this up. So typically what we would like to do is perhaps just do anterior septal and maybe one posterior septal if appropriate. So in terms of clinical experience with edge repair, certainly most of them have been off-label with the mitral clip system. The Abbott G4 system has now been CE marked. US pivotal trial had just completed enrollment. The Pascal CE marked, the current pivotal trial is underway. The outcomes, however, does vary. It depends on anatomy or pathology. For those of you who do not have access to the TriClip or Pascal, this is a TriClip implantation step-by-step using the mitral clip system that I was part of. There's published in CCI, and you can certainly read at your own leisure. But certainly the TriClip G4 system, you can see is a bit different from the mitral clip system with two knobs at the guide rather than the CD handle. You still have 4 clip sizes, and this is some of the guidance or recommendation in terms of which clip to use. Certainly longer leaflets, you can use the longer clip. However, if you have a narrow grasping zone or need the chemistry, you might want to use the smaller clips. Typically, what we would do is admit these patients 24 to 40 hours before to optimize them, especially dry them up a bit to reduce the gap. You may even consider IV Mirinol to support the right ventricle. And certainly we do a transthoracic echo to reconfirm that the TR is in fact severe and the gap has not changed. In terms of the procedure itself, we typically minimize the tidal volume like we do with mitral clip, and we increase the respiratory to minimize the respiratory variation impact on the valve and the grasping. We optimize the heart rate. We might optimize the imaging by putting a arterial line back underneath the right shoulder. We do put a Foley catheter monitor urine output. Like I said, we do give places maybe even during the procedure, especially, remember, you have these strips of flushes running through the system, so you may actually inadvertently increase the gap by loading the right ventricle. We typically no longer do central line anymore, especially since it might shadow the device itself. So the triluminary pivotal trial has actually 2 arms. One is a single arm where you have larger gap and less favorable anatomy. And typically what we do, we reduce the TR by 1 grade. That's the endpoint. However, with the randomized arm, typically these patients are intermediate risk for surgery and a smaller gap, and you do expect the TR to be down to moderate or better. The early feasibility study has been published, and I'm part of that. And you can see that most of the clips were 2 or more, and most of them target anterior septal because it's easier and it also makes the biggest impact on the TR reduction. And if you look at in terms of the coaptation line, most of them, if you put 2 clips, you would go after anterior septal and posterior septal. We almost never do anterior posterior because it has not been shown to be beneficial to the patient in terms of TR reduction. You can see that at 1 year with payer data, the TR reduction has been sustained with the early feasibility study. You can see what remarkably though is that there's positive right ventricle and right atrial remodeling, as well as reduction in rehospitalization. The triluminary pivotal trial roll-in cohort has recently been presented at ESC and recently at TCT. And you can see that here in terms of acute procedural success, 99% device time has been well less than 2 hours. You can see that most of the time have been 2 clips or more. You can see most of the clipping were done in the anterior septal. And you can see the procedural profile is extremely safe, no stroke. 1 patient had tricuspid valve surgery and very low bleeding risk and very low SLDA as well. You can see again with the call-out adjudication, 74% of patients have moderate or better TR. This is the roll-in cohort, as I mentioned before. And you can see that here's 2/3 of patients at least have 2 grades of greater reduction. And if you look at the TR reduction in terms of the spine and analysis, you can see the majority of them does improve the TR. Now, the other technology is the spacer edge repair technology called Pascal, which is also CE marked. You can see this is the class TR study. You can see similarly very high degree of success. You can see that here, very safe profile, early learning curve experience, but you can see it's around 2 hours. You can see that also here, really very safe, no excessive mortality or morbidities, very low SLDA rate. And again, the TR, you can see at 1 year has been sustained with, you can see 75% similar to the trilumet trial, achieved 2 grade or better reduction. And also functional improvement has also improved in these patients. So the class TR trial now is a randomized control trial, similar to the trilumet trial that's ongoing in the United States. Now, what about annuloplasty? Because surgeons typically do annuloplasty, they don't do edge repair. So there is, in fact, a transcatheter solution to this that is currently under development and soon to be in clinical trial. There was a trial before with early feasibility studies, small patients group, but you can see that here with the annuloplasty technique, you do have a sustained reduction in annular dimensions at 1 year with also sustained TR reduction. You can see that here, there's also improvement in right ventricular remodeling and right atrial remodeling as well. So currently the tri-band system is actually a European study because that's a CE mark approved. And you can see that there's a registry that's ongoing in the US. The early feasibility of the more redesigned cardio band is going to be coming up soon. Now I want to flip the coin a bit on when would surgery be more appropriate over transcatheter intervention, especially on repair. Well, certainly if the gaps are extremely large, the results of suboptimal transcatheter repair, we would consider surgery, especially if they're not suitable for replacement with transcatheter approach. The leads in the way, they fail annuloplasty repair, or as I mentioned before, they're not suitable, appropriate for transcatheter therapy. So we can certainly re-repair the tricuspid valve like how we do with re-repairing the mitral valve. You can see the example here where the MC3 ring was too rigid, and so we take that out and put in a more remodeling annuloplasty to improve the coaptation. However, if you can see that the lead associated damage, sometimes you may have to do a more complex reconstructive work, especially if you don't want to replace the valve. And certainly in these kind of situations where multiple leads, very tethered leaflets, there's no option other than valve replacement. So which transcatheter valve therapy for which patients really depends on the advance of the right ventricular remodeling that patients been undergoing. If they're phase 1, being they're still early, the annular leaflet devices, certainly you can consider that. However, as they are more advanced in terms of RV distortion, really tethered leaflets or big gap, you really have to think about replacement or cable valve implantation. So in summary, I think the transcatheter tricuspid valve therapy really gaining momentum in clinical studies. The early results of TR is promising with positive right ventricular remodeling, but I think the feasibility is still limited to more smaller gap patients, no leak interference and good imaging quality. I think annuloplasty solutions are still early, but I think they may be also more complex to do at this time. But ultimately, I think they'll be more physiologically relevant and also be able to preserve all options in terms of transcatheter, repair or replacement approaches, and even surgery. So with that note, I'd like to thank you very much for your attention. I'd be happy to answer any questions.
So thank you very much, Professor Tang, for giving such a great lecture regarding the transvenous tricuspid valve intervention modalities. So I would like to start the discussion to see if Dr. Mickey Kwok, maybe if you have any special opinion regarding this topic, and also if there's any question to Professor Tang, please. Thank you.
Thank you. I think I totally agree with a message that brought out earlier this morning is tricuspid valve repair replacement surgery per se is not a technically difficult surgical procedures, but rather the morbidity mortality was because of the RV dysfunction. So I would like to ask Professor Tan, most of the time we are facing a dilemma that we know that a surgical result in terms of reduction in tricuspid regurgitation is going to be satisfactory or better than transcatheter repair. But then because of the LV dysfunction, we anticipate a very high risk. So what is your opinion in this group of patients, whether you will consider a less reduction in tricuspid regurgitation, but a lower procedure risk than proceed to a transcatheter approach rather than an open surgery approach? Thank you.
Yeah, no, that's a great question. You saw all the data that we've presented, that the whole idea of transcatheter tricuspid repair is not to eliminate the TR, but to reduce the TR to sufficient degree that the patient will actually clinically benefit. And we've actually seen that, at least in my personal experience and also in the trial as well, that especially now that we have 5 grades of TR severity, you're not expected to reduce torrential TR to mild or less, because that may be unrealistic, although it can happen in appropriately selected patients in appropriate anatomies. So what we've seen is that patients with very severe or greater TR, when you reduce the TR to moderate or better, or even mild or better, they really functionally benefit. And on top of that, you saw the data that the right ventricle actually shrinks in size and do better. So what we're saying with transcatheter repair approaches is different from surgery. Surgery certainly will try to expect perfection when you leave the operating room. But transcatheter approaches, you really try to reduce the TR enough so that they clinically benefit and functionally benefit. And also at the same time, what we found is that by just reducing the TR, the quality of life improved. They don't have peripheral edema, their liver is not congested, they're more forward flow, especially in the context of patients with left ventricular dysfunction. They really make a significant clinical difference. And also from a guideline-directed medical therapy standpoint, they now be able to be more aggressively up-titrate their GDMT in these cases. So I think there's multitude benefit of patients reducing the TR, not so much aim for perfection, but certainly if you cut the EROA by half, for example, from torrential to less, then I think it actually would benefit the patient.
Thank you. Thank you.
So thank you, Professor Tang. May I ask Dr. Joseph Chen and Professor Tang whether your centers have any experience in offering TriClip to patients with transvenous lead-related TR patients? Thank you.
So in my center, we haven't really performed TriClip in patients with pacemaker lead induced TR, but we have performed some patients with just isolated TR without pacemaker lead. So I think the result is good if the patient selection is good. So, and as mentioned by Professor Tang, the perioperative morbidity and mortality associated with either mitral clip or TriClip in the tricuspid position is usually quite favorable.
Yeah, I would add to that is it really depends on 3 things: the location of the lead. So for example, if it's at the commissures and away from the grasping area, it typically is not an issue. And through the trilometric pivotal trial, I'm on a screening committee that we approve cases like this. The challenges are typically the lead in the middle that is mobile, so it currently interfere with your grasping, or an ICD lead where it's very echogenic, so it's very difficult to visualize the leaflets. So those cases can be more challenging, although some people have tried to actually snare the lead out of the way to try to do the grasping and then release that at the end of the procedure. But you do have to be worried about respiration variation, that the lead may interact with the device, with the edge to edge. And finally, the ones that we cannot approve are the leads that are tethering the leaflets itself and causing the TR around it in such a way that the leaflets are too tethered to be able to grasp safely, to be able to reduce the TR by what we call by at least 1 grade in the at least single arm. So those patients we would recommend either replacement or other options.
Thank you. So may I ask Dr. Tao Cheng if there is any experience regarding such topic in Macau, please? Is Dr. Tao Chen here? Oh, okay, so I think let's move on to the local case in a box discussion, which will be shared by...
May I ask a question? Is there any chance of the clip rubbing on a lead, such as an ICD lead, leading to early conduction failure?
That's a great question. Not that I'm aware of, and I don't know if there's any case report that's been reported that way. But having said that, we have seen and heard of tricuspid replacement devices that are actually interacting and actually rubbingly causing some erosion and also loss of pacing capture. So I think for transcatheter replacement, you definitely have to be very mindful of your lead management strategy in a patient who's either pacemaker dependent or have an ICD that needs to be functional. I think that is part of the bigger challenge than edge-to-edge repair. And of course, if you talk about annuloplasty, that's not an issue at all because it doesn't really interact with the lead.
Okay, so thank you. So if there's no further question, I'd like to proceed to live in a box shared by local Dr. Eric Chen. So please, Dr. Eric Chen, please.
Yeah, we can proceed to the case. So thank you for the chance for us to demonstrate some record case regarding structural heart and electrophysiology crossover. It's my pleasure to present to you this patient who is a 74-year-old patient, history of chronic rheumatic heart disease and also impaired LV heart failure with reduced ejection fraction. She had an APIC valve, which is a porcine valve implanted like 10 years ago, as well as tricuspid valve repair and biatrial maze procedure by the surgeons. However, she presented with degenerative prosthesis failure with severe mitral regurgitation. She also had a CIED implanted with conduction system pacing. Now, this is an TEE showing prolapse and a flare of the leaflet with severe and laterally directed MR. You can see the MR jack directing towards the left atrial appendage, which was located surgically. Very essential MR, very symptomatic. To make things worse, she also had recurrent atrial tachycardia, which was not controlled by medications. Now, we routinely perform CT assessment of, we know that the valve, we have the app by the Vinayak. However, we still want to size if there is any abnormality, and also we need to rule out alveolar obstruction. So you can see this is our typical heart team procedure. We are operating with the surgeons. Surgical fellow is actually the chief in this case. And then we know that when we do valve-in-valve procedure or ballooning degenerative prosthetic valves, there is high chance of embolization of the degenerative valve. So therefore, it's our standard practice to use the cerebral embolic protection device, in this case, the Sentinel device, which is proven to reduce disabling stroke in the protected THV study. And also, some people have done it in the VT ablation as well, and studies on AF ablation and the efficacy of it is under investigation. We definitely need more randomized data. So what we are doing, or the fellow in surgery, CT surgery is doing, is deploying the first proximal filter in the right innominate artery, where that filter will help capture any potential debris going to the brain. And then the second step will be to deploy the distal filter at the left common carotid artery. Without that, would protect 80 to 90% of the circulation. The circulation of the brain that was not protected was the vertebral artery distribution. However, this device is one of the most used device and have been proven very useful in our daily practice. We did see a lot of debris, and there were a lot of studies, even MRI studies, confirming reduction in cerebral infarcts and potentially reduction in cognitive decline, cognitive impairment after these procedures. So we are actually wiring this left common carotid artery with this 014 wire. This is the V14 wire, 300 centimeters from Boston Scientific, and then we're engaging the left common carotid artery. And then we pull back the device so that we deploy the distal filter at the left common carotid artery in a very methodical manner. And then we did try to minimize our contrast use, but we want to be sure that we were protecting the left common carotid rather than engaging the left vertebral artery through the left subclavian artery. So with this single shot, we already confirmed that. And then we went on to perform a pigtail ventriculogram to confirm the severity of the mitral regurgitation and also to check for any potential baseline alveolar tract obstruction, any gradient across the alveolar tract. And we understand that in this valve in ring or valve in valve procedure in the mitral position, that could be disastrous consequence if the alveoli is obstructed. So we plan ahead with the CT. But of course, we need to check the gradient real time. So what we're doing now is to perform a transeptal puncture. In this case, we use the Baylis radiofrequency needle, and this is the latest system, the VersaCross system, which is typically different from the conventional 032Y system. This is a radiofrequency 0.035 wire, which we could use to time the radiofrequency impulse in order to minimize potential injury during transeptal puncture, and is particularly useful when we were encountering a very thick and fibrotic postoperative septum, like repeated transeptal puncture, etc., and that we don't need to bovie the conventional BRK needle, but rather we could use this actually a wire with a new timed impulse, and upon transversal of the interatrial septum, it will actually resume a pigtail shape. So it's very safe. There's no chance that we could perforate the posterior wall of the PV with this system. And then this was an Agilis catheter. We could flex it. And then we did it under real-time 3D TEE guidance with some didactic maneuver and then communication with our echocardiographer. We could direct this directly towards the mitral ring, mitral prosthesis. It was purposeful to use a pigtail catheter to cross this, just in case there were any valvular dehiscence. And this is particularly important in mitral valve in ring procedure because we don't want to get trapped in the any subvalvular apparatus. Less of a problem with mitral valve in valve. Again, we did it in a very didactic manner. When we counterclockwise the Agilis sheath, it will move the system more anteriorly, 12 o'clock in the real-time TED, just like what we were doing in the mitral clip procedure. And without much difficulty, we were able to pass this pigtail catheter towards the LV apex. And then through this pigtail catheter, we could very safely deploy a pre-shaped stiff safari wire, which was pigtail-shaped. It's a very stiff wire at the shaft, but relatively soft at the tip, and it has a pigtail shape, so it's going to prevent any potential perforation, which could be disastrous, of course. And then through this system, we will then perform the rest of our procedure, which I'll show you later on. Now, you could take the time to, the patient had a CRTD, but there was not conventional ICD plus a LVD. It was actually a conduction system pacing with left bundle branch area pacing. Now, what we were doing now was to dilate the interatrial septum. It was thickened, it was fibrotic. It was a 10 millimeter peripheral balloon. You could see the waist. Normally, 10 to 12 millimeter balloon would be enough to allow us to pass and transcatheter heart valve through the septum from the right atrial side to the left atrial side. And that, but I'll show you what happened afterwards. The puncture was an inferior posterior puncture. You could see on the fluoroscopy it was near the level of the valve, which I will show you later on. So you could also attempt pacing wire from the left fan moving in this case, left bundle branch pacing lead, tricuspid ring, and faintly you could see the mitral valve. Now the used balloon was passed along this safari wire across the mitral prosthesis, so we felt that the trajectory was favorable, and also there was little resistance. So we then decided to pass the catheter. So there was a THV system, but then we could use it in a mitral position. The tips and tricks will be to perform an inferior posterior puncture, and then the E-sheath normally would go up into the patient, hub into the groin. However, for Asian patients, we felt that we did not have to insert the E-sheath the expander sheath all the way into the IVC. Rather, we left a part of it outside the body. The reason of it is we need to line up the balloon catheter and the valve. So we were advancing the valve and the balloon along the IVC over the stiff wire, and the nose cone of it reached the right atrium. Well, how it came out of the system from the manufacturer was the balloon was in tandem with the valve. Now we actually were exposing the expandable sheath and then advancing the valve and the balloon system into the patient's body without taking the turn. So what we were doing was unsheathing the valve actually. You could see that there were some balloon markers towards the upper side of the screen. Those were the balloon markers. Then we had to line up the markers and load them within the valve frame, inside the valve frame, and then we were able to deploy the valve. Now we were loading the balloon inside the valve frame. And we were fine-tuning the position of the balloon. And the beauty of this system is it's a flexible system. We could flex the delivery catheter, and then that would facilitate taking the turn from the right atrium to the left atrium towards the left ventricle. And then we were trying to advance this system across. There were some atopics generated by the stiff wire against the left ventricular wall. But again, it's a pre-shaped wire, it's pretty safe. Now you could appreciate the problem on TED and also on fluoroscopy. There was buckling of the delivery catheter despite active flexion, and the device just could not cross the thickened and fibrotic intertracheal septum despite different maneuvers. So what we did was to temporarily remove the tempacer from the left groin, and then we used the multi-purpose catheter and then crossed over to the left pulmonary vein, and then we ballooned the intertracheal septum using a bigger balloon, a 40 millimeter nucleus balloon in this case, with prolonged inflation. There was no hemodynamic sequelae with prolonged inflation because we were just occluding the intertracheal septum temporarily. And afterwards, we found that there was less recoil, and then we were happy to deliver our transcatheter valve across the intertracheal septum. You could still see a waste because of the thickened and fibrotic septum. Despite using a peripheral balloon, there was still a waste, but we found that because we oversized a little bit, it was probably okay. And then the rest was not difficult at all. Now on beautiful 3D TE images, you could see the delivery catheter and the valve approaching the mitral prosthesis. So we did it under fluoroscopy, multiplane, 3D TED. And we chose a angiographic view where we could line up the sewing ring of the epic bioprosthesis. Now we have advanced the valve across the mitral prosthesis, and then we pulled back the pusher or the delivery catheter. And at this point, we could fine-tune the position of the valve, but we could not move so much because there was less of support once we pulled back the delivery catheter, or the outer shift of the delivery catheter, and then we mapped up, and then we found the fluoroscopic angle when we could see the sewing ring of the epic prosthesis, and then we wanted to deploy it like 80 to 20 in terms of proportion in the ventricular aspect compared with the atrial aspect. The problem with two ventricular deployment will be a potential LVOT obstruction in case of a perpendicular aortomitral angle or small LV or very thickened basal septum. The problem with two atrial deployment will be a potential late embolization and also the presence of paravalvular leak, because the outer cuffs of the sapien valve mainly was located in the basal aspect of the valve. So we were happy in this position, both fluoroscopically and also on TEE. So many people do it doing in different manners. Some people did it under rapid pacing. Some people did it under a very controlled inflation. So we tested our temperature. It was capturing well. We could dampen the cardiac output, and that will provide an even more stable deployment.
Ready.
You could see the hemodynamic tracing on rapid pacing, the blood pressure fell down, and then we took the time to maintain the coaxiality of the valve and also fine-tune the position. We were happy with this, and then we went all the way up with full inflation. You can now faintly see the sewing ring. So a lot of speakers have talked about intentional bioprosthetic fracture of valve-in-valve interventions. We found that in this patient, we were putting in a 29 sapien valve, which was the largest in the sapien family. We would not routinely fracture this valve unless the gradient is really high. So it's now time to defer to our echo expert to check for any paravalvular leak and also any gradients across this newly implanted prosthesis before we decide to do any further bioprosthetic fracture, meaning we use like a 28 millimeter non-compliant true balloon to intentionally fracture the old valve using a controlled inflation. And the pressure gradient, mean gradient across this newly implanted bioprosthesis was fortunately in single digit at 3 to 4. So we felt that with this degree of gradient, we did not have to perform bioprosthetic fracture, which carries a small but potential risk of annular rupture and also damage to the leaflet of the new prosthesis. So we were happy with this EROA. Probably there will not be any patient prosthesis mismatch. And we could see a nice flare over the ventricular side of the device and the constraint over the atrial aspect. TEE looks good. No significant LVOT obstruction as evidenced by the absence of any turbulence across that area, and also the blood pressure was fine. There was mild to moderate MR in this case, but probably associated with the stiff wire and the Y bias, so we removed the Y over a pigtail catheter, and my MR was gone. However, this patient did not only present with mitral regurgitation, but also recurrent admissions for heart failure precipitated by uncontrolled atrial tachycardia, which was not controlled effectively with high-dose AV nodal blockers because of the poor cardiac output, of course, and the frailty. We checked the gradient, we checked for any paravalvular leak, we checked for mobility of the leaflets, whether they were mobile, and rarely we could see some stuck leaflet after manipulation of valvular deployment. We make sure our ACT was in appropriate range. Again, the mean gradient was 3 only, which was ideal. Of course, we could take all the time to assess for any LVOT obstruction by both invasive hemodynamic tracing and also by echocardiography. Now we are left with iatrogenic ASD. So it has always been an ongoing debate whether we should close this ASD in the same go. In this particular case, we could not see any right to left shunt, and there was no history of recurrent emboli. She's on anticoagulation anyway, so we did not close it right now. So hemodynamic tracing previously did not show any LVOT obstruction, and on left ventriculogram, there was basically no mitral regurgitation at all. Yeah, you could see no gradient on real-time tracing anyway, but we did the pullback anyway. So again, we took the time to assess the interatrial septum, whether there was any hematoma, any laceration with the manipulation, whether there is any right to left shunt. It's not difficult to put in another occluder device just to seal this iatrogenic ASD. I think there are many people who reported different risk factors when we should close them right away, but we felt that we did not have to, and there might be potential need for future access to the left side anyway, so we did not close it right now. So I defer to our electrophysiologist to perform this, and Professor Jian and his team did a great job. And we did employ a retroaortic approach in this case. Basically, we were trying to target the non-right commissure, the membranous septum, the His bundle, and then you could see on the EP tracings, the patient was in atrial tachycardia with 4-to-1 conduction. We lowered the backup rate of the pacer. There was some intrinsic cardiac output. Basically, what we were doing was try to localize the His signal. Once we localize the His potential, then that's our target for ablation. And then you could see the small spike near at the ablation catheter after any conducted P wave. So that's pretty our target. So ablation was performed using RF for 60 seconds, and then you could see the results. So it's a pretty stable position, not much PVC. So I can take the time to ask our expert panelists, will you perform another atrial ablation, or will you go ahead with the device in situ, will you perform an AV nodal ablation anyway?
I would have done exactly the same. Given that parts of the atrial tachycardia could have arisen from torrential mitral regurgitation, now you have reduced the mitral regurgitation. I think in some they simply disappear or reduce in severity. But the AV nodal ablation is great because after all, the patient requires a pacemaker.
Yeah, that was what we thought, and then we felt that this patient has structurally abnormal heart, and then also repeated surgery, history of ablation. Then we would rather just go ahead, and she has a conduction system pacing anyway. So you could see we set up the backup weight from 40 to 30, and then we confirmed there was no conduction. You could see the beauty, the RSL at V1, and the short stem to peak interval in V6, mimicking conduction system pacing. So we felt that it was a great result, and then further ablation attempt was performed, and the patient did well. And
may I ask, why don't you perform it on the right side? I noticed that there is a ring there, but why don't you perform it right side and choose to do it on the left side?
May we direct this question to Professor Teh, please?
Well, obviously, I think there's a choice of doing from the left or right side is, well, it's pretty simple because obviously he just had a device implant recently, so I just don't want to entangle him on the lead. And in fact, the left side ablation is actually much easier, especially the patient already have access. So the patient have all this intervention, have access to the artery, and in fact, you can see that doing in the left side to do AV nodal ablation is in fact much simple. In the other cases, if you don't need to want to access the atrial side and also need to anticoagulate the patient, right side may be the preferable initial approach. But from our previous experience in the University of Michigan, so we actually do a randomized study. Actually, from the left side, it's actually much faster and easier to do AV nodal ablation by doing this approach.
I just wonder, because that was a newly implanted mitral valve there, and would there be a little bit a concern because you're so close to it?
Well, we never close the mitral valve, so we just go close the aortic valve, and then we just pull back, and we just go to his area. So it's actually pretty straightforward in terms of ablation. It's actually, you see that only one ablation, you actually get the heart block. Right side sometimes can be also difficult, especially this patient had this dilated atrium and distorted anatomy. So doing AV nodal ablation from the right side may not be easy or trivial, but on the left side it's pretty straightforward, and in his position is always just below the aortic valve, and usually are much straightforward.
I see that there was very small atrial electrogram in the site of ablation. Of course, the patient is in atrial tachycardia. Do you normally get a very small A when you ablate on the left side or not?
On the left side, on the left side, you don't usually see A because it's on the ventricular side. So only you see the His bundle potential we just ablate. You don't actually see the A potential. So, and I think this patient already on a miorodon very high dose is still in AT. And I think atrial ablation probably not helpful because it's probably a lot of atrial disease. So that's why we go for AV nodal ablation, because you actually admitted with heart failure with rapid AT for 2 or 3 times already. Yeah.
Thank you.
Hello. Okay. So thank you very much again for this amazing EP/structural heart program, which have unfortunately come to an end. So I would like to conclude this morning session, and I would like to thank you again for all the panelists, Professor Lau, Dr. Hai, Dr. Andy Chen, NY Chen, and also Mickey Kwok, and also Dr. Tao Chen, and also the lecturers as well for giving such amazing lectures for us. So I would like to invite all the panelists to join the lunch section in the 7th floor of Alumni Chamber. Please remember to get the meal ticket at the registration as well. So we'll see you again in the afternoon. And remember, there will also be echo workshop and also other exhibition area, which we encourage every one of us to join. So thank you very much.
good afternoon in Hong Kong and Asia, good morning in Europe, and good evening in the United States of America. I'm Eric Chen from Hong Kong. Welcome back to Hong Kong Valves 2022. We just had a fantastic session on transcatheter mitral and tricuspid valve intervention and imaging, as well as crossover with electrophysiology and structural heart interventions. Now we're privileged to continue the discussion on the innovations on mitral and tricuspid innovations. We are blessed to have the expert panelists from both overseas and Hong Kong. May I introduce the Chief of Cardiology, Dr. Hashinori Daisuke in Sapporo Heart Center, who is also the Director of Structural Disease Center as our expert panelist. We also have Dr. Anurag Jimanukukit, who is a consultant cardiologist and expert PCI and THV operator in Vajayani Hospital and Police General Hospital in Bangkok, Thailand. Locally, we have Dr. Gary Yeung, consultant at Union Hospital, and who is also the current president of Hong Kong CASH. Dr. Y.Y. Lam, who is the director of Hong Kong Asia Heart Center, Canossa Hospital. He is one of the first operators in tricuspid edge-to-edge repair, as well as a lot of structural heart interventions in Hong Kong. Dr. Ryan Goh, who is the consultant at Hong Kong Heart Clinic Central. He is the first mitral clip operator in Hong Kong and an expert interventional cardiologist. Dr. Kelly Ho, who is Chief of Service and Consultant Cardiothoracic Surgeon at Queen Mary Hospital. Dr. Arthur Yeung, who is the Honorary Clinical Assistant Professor at the Hong Kong University, who is an expert in chip and structural heart interventions. And Dr. Timothy An, who is the Clinical Instructor at Hong Kong U, who is right now doing an advanced fellowship in the Guy's and St. Thomas's Hospital in London. We have expert speakers from abroad. First of all, we have Dr. Maurizio Taramaso, who is a cardiothoracic surgeon and an assistant professor in the University Hospital of Zurich in Switzerland. He completed his training in San Raffaele University Hospital in Milan, Italy, and then did an advanced fellowship in Hanover Medical School in Germany. His main areas of interest include surgical and catheter treatment of valvular heart disease, as well as transfemoral, transapical interventions, multimodality imaging, and heart failure. He is an author and co-author of numerous publications on these topics. Then we're honored to have Dr. Kong Kyung Yo, who is a senior consultant and interventional cardiologist in the Department of Cardiology in National Heart Center, Singapore. He's also the deputy CEO there. He's a clinical associate professor at Duke NUS Medical School and scientific lead for the Sciences and Database Core at the National Heart Research Institute in Singapore. He is a reviewer and also has published numerously in international journals such as Circulation, JACC, Cardiovascular Interventions, American Journal of Cardiology, and he's also the founding editor-in-chief of the Journal of Asian Pacific Society of Cardiology. His expertise lies in mitral valve and tricuspid valve intervention, and he has established the MitraClip Asia Pacific Registry. Without further ado, let's start our first lecture by Dr. Maurizio Taramaso.
Hello, everybody. Thanks a lot for the kind invitation. It's really an honor and a pleasure to be here with you. And I will try in the next few minutes to share with you some tips and tricks regarding the transcatheter edge-to-edge therapy with the TriClip device, and actually mainly how to try to optimize the result is the focus that I try to give to my lecture. These are my disclosure. And I think it's not only a matter of technical performance when we aim to achieve procedural success with transcatheter edge-to-edge with TriClip. More important than this, there are other 2 points that comes a bit before. The first one that I put it in red, which is the most important, is the patient selection. If we want to have good result, we need to treat the proper patient. The patient selection means clinical, but also anatomical selection. Both of them are really important. Then the second point in the patient management, we need to prepare the patient before the procedure. We need to support the patient peri-procedurally, and then we need to follow him at the follow-up, not only from a clinical standpoint, but also we have to properly give him medication in order to stabilize the result and to have a durable result. And then obviously the technical performance. We need to know our device. We need to know the TriClip catheter, the TriClip implantation, and also the anatomy of the right heart, mainly of the right atrium, right ventricle, and also of the tricuspid valve complex. So these 3 elements are equally important and are the key point to achieve procedural success, in my opinion. Let's start from patient selection. We are learning quite well how to select the patient for TriClip therapy. And I like to divide the patient selection aspect in 3 groups. Obviously, we need to have suitable anatomy, which is marked in blue in this table, and we will focus a bit on this aspect. So proper anatomy is important. Clinic, as I told you, we need also to select the patient from a clinical standpoint. Basically, we need to treat the patient before it's too late. It's still quite difficult to identify when late is too late, and any procedure could be futile, even if the anatomy is okay. Obviously, we should not treat patient too early, but the tendency should be to go earlier than what we do now in order to avoid any futile procedure and not to miss the therapeutic window. And then last but not least, we need good imaging, the red part of the table. The quality of the imaging, so the quality of the echocardiographic window is as important as anatomy as clinic. If we don't have good imaging, actually the patient is not going to be a good candidate for transcatheter edge-to-edge. Few words regarding the clinic. I think this drawing summarizes exactly what I mean. There is a therapeutic window for all treatment of valve disease. It's still a matter of learning which is the therapeutic window for tricuspid regurgitation. The tendency now is to see patient when it's too late. So when the point of non-return, this red point, is already passed away. And obviously the chance of recovery after this point, even if we achieve perfect result, is low. So we should try to treat patient a bit earlier, obviously not too early, but still, which is the proper therapeutic timing for tricuspid regurgitation is still at the moment under investigation. What we know is that we should treat the patient before this point of non-return. Second aspect, and this relates to the anatomy, after identifying the correct procedural timing, we should identify the patient where we are able to reduce TR, because only if we achieve procedural success, so only if we reduce TR, we have good clinical outcome. There is a clear difference between patient where we reduce TR and the patient in whom we are not able to reduce TR. So there is a clear correlation between TR reduction and clinical outcome. So it is of tremendous importance to identify the predictor of procedural success and treat only those patients. The patient where the chance of reducing TR is low, of 0, should probably undergo other therapy or should not be treated. And actually, this is something that we are learning more and more with the experience. Now we are quite good in identifying good clinical, good anatomical predictor of procedural success. I like this 5A classification that identify the 5 most important aspects that we have to look at when we select patient. The first one refers to the imaging. We need to have adequate imaging. Then the jet should ideally located mainly in the anteroseptal part of the valve, because this is the easiest to treat and it is the location associated with better result. There should be no gap, or a gap which is as small as possible, so absence of gap between the leaflet. We need to have leaflet which are long enough, so abundant leaflet length, and ideally, in an ideal case, there shouldn't be any pacemaker lead through the valve. There is even a score to predict the chance of procedural success, which I like it because it's really easy to verify in every patient. This score has not been validated on a large clinical scale yet, so it's based only on a mono-center experience. But I think it's quite reassuring to see that if we have only 0 to 2 points among the score, we can achieve almost 100% of procedural success. If you have more than 6, then the chance of achieving procedural success is less than 50%. So we should always look at the gap, we should look at the location of the jet, we should look at the morphology of the valve, quality of the imaging, and the morphology of the jet in the ENFAS view. There are these simple parameters that we can easily quantify, and then we can predict quite well the chance of procedural success. This is just an example that shows you a good case and a bad case. At the end, the most important predictor of success is the gap between the leaflet. The first case on the left, you see the gap between the leaflet in the anteroseptal location is more than 1 centimeter. This is obviously not a good case, and the chance of get good procedural success in this case is low. So most likely in this case, we will have a score which is above 6. The case on the right is an ideal case where the gap between the leaflet is about 4 or 5 millimeter. We have good quality of the imaging, and there is a 3-leaflet valve. So this is a case where we can achieve procedural success in almost 100% of the cases with a score of 0 to 2. So this is a good case. Other element that we have to look into patient screening to select patient for procedural success is obviously the length of the leaflet. Usually posterior and anterior leaflet are always long enough. The one that could be short is the septal one. Ideally, we would have a septal leaflet which is at least 1 centimeter. So we always need to measure the length of the septal leaflet in order to have good leaflet insertion. And then the location of the jet. The jet should be ideally located anteroseptally or centrally, like in this case. And again, this is also mentioned in the score that I showed you. If you have a small gap and a jet which is located anteroseptally with good imaging, then usually we can achieve good procedural result. Let's move to the second point, which is patient management. Patient management includes the preparation of the patient. So the patient should arrive to the procedure in an optimized status. So we need to optimize the patient before the intervention. We need to have proper peri-procedural management, especially for high-risk patients with some degree of right ventricular dysfunction. And then obviously, we need to have a clear way to follow the patient after the intervention in order to stabilize the result. What does it mean, optimize the patient before the intervention? Actually, we need to identify the underlying reason for the secondary TR, which is the most prevalent etiology of TR, and try to treat the underlying causes, for example, to optimize the left side pathology, to optimize the atrial fibrillation. And then obviously we have to aim for a proper decongestion of the patient. We want to reduce the preload of the patient in order to have a gap which is as small as possible between the leaflet, because this is the picture that I showed you before. Obviously, the first patient here is a bad case because the patient is overloaded, the preload is too high. So it is not only a matter of anatomy, it's also a matter of preload. If we decongestionate the patient, we can move a condition like the first one to a condition like a second one. So we can reduce the gap by just increasing the diuretic therapy of the patient, because the dimension of the right ventricle are really sensible to the preload. So we need to diuretize the patient intensively in order to reduce the gap between the leaflet. And this can be done a couple of days before the procedure. Usually, if you have a patient with a big gap, we hospitalize him 2-3 days before the procedure. We repeat the echo. And in case the gap is too big, we prepare the patient with intravenous diuretic therapy for 24 to 48 hours before the procedure in order to reduce the gap. Because the gap actually is the most important predictor of procedural failure. If the gap is more than 7 millimeters, let's say, the chance of getting a good procedural result become lower. And this is what we can achieve. Maybe the quality of this picture is not that good, but this is a patient that arrived to our attention with a big gap of almost 1 centimeter. So we put him under intravenous furosemide therapy, and after 3 days, the gap was almost abolished. There was only 3 millimeters left of gap. And this is a patient well prepared for the procedure. Now to grasp the leaflet in this valve, it's much easier, and to reduce TR is much easier as well. So it's extremely important to prepare the patient and to reduce venous congestion before the procedure. Another really important point to achieve procedural success is to identify the patient at risk of right ventricular dysfunction. We know that the right ventricle is a chamber which does not tolerate increase in afterload as good as the left ventricle. So if we abolish TR during the intervention and there is an underlying right ventricular dysfunction, we may have acute afterload mismatch and acute right ventricular failure. So it's really important to identify the patient at high risk for right ventricular dysfunction after the treatment of the tricuspid regurgitation. And it's not really clear how to identify those patients, but probably there is a role for stress tests. But for sure, if we identify a patient which is at high risk using stress tests, using MRI, or just looking at the morphology of the ventricle, there is probably a role for prepare those patients as well with levosimendan and anyway with inotrope, by admitting them in ICU the day before the procedure to try to prepare them like we do for mitral intervention. And then if right ventricular dysfunction occur, we should be ready to treat them and to prevent them. Usually, this is done by using inotrope. We should use inotrope to support the right ventricular function. We should avoid vasoconstrictor. We should avoid overload of volume. And probably there is also a role for pulmonary vasodilator for the patient with pulmonary hypertension. There are no studies in this, but I think everybody has experience of some patient that develop right ventricular dysfunction after reduction of TR, and the combination of inotropes and pulmonary vasodilator could support this transitory phase of afterload mismatch and bring the patient back to a stable condition. So it's really important to support the right ventricle of those patients if the right ventricle has afterload mismatch. As important as preparation and perioperative management is the follow-up. If the patient has a large annulus and we achieve a good result, it's really important not to reduce the diuretic therapy immediately. We should keep the diuretic therapy at the same dosage as before the procedure for some weeks, because otherwise, if the annulus dilate immediately after the procedure, then the tension on the leaflet that we have just clipped is too high, and then we may have single leaflet detachment. So we should keep high dose diuretic after the procedure, even if we achieve good result, and this is extremely important. Third point, we need to know the device and we need to know the anatomy. I will not focus on this too much because you have been listening to other sessions, but the device of the TriClip has been specifically developed to achieve perfect coaxial trajectory to the tricuspid valve and to navigate in the right ventricular chamber. We have 4 different clip sizes, so we can tailor the therapy to the patient. Usually, we always use XTW because the gap are quite big in tricuspid. So this is the most used device, but obviously we need to be able to tailor the therapy to the anatomy of the patient. And then the steering of the device allows us to navigate really safely in the right atrium. We can steer toward the tricuspid valve by using the F and D knob. Then we can correct the height of our catheter by using plus and minus, and we can optimize the coaxiality of the catheter by using the SL knob. So if you are too close to the septum, we can go far by using the L knob and then correct the coaxiality. So it's extremely important to know how to achieve coaxial trajectory to the tricuspid valve. So the first step of each procedure is navigating the right atrium without touching anything. So it's really important to check in bicaval view and in fluoroscopy and to know how to steer the device in a safe way. And then after steering the device, we need to have this kind of trajectory. We need to achieve coaxial trajectory. And this is the most important aspect, to have coaxial trajectory to the leaflet and to the tricuspid valve in order to grasp them. This is an example of non-coaxial trajectory. You see, we are coming from the septum. And now by using L, we go far from the septum, and then we gain coaxiality again. And this is feasible in basically all the patients. Now you see the catheter is coming back in the picture, and by going clockwise, we are now able to have coaxial trajectory. Now we are coaxial. So the TriClip catheter allows the operator to be coaxial in basically all the anatomy. Obviously, since the tricuspid has a lot of anatomical variation, it's extremely important to be perpendicular to the line of coaptation in order to avoid opening of cleft. So always important to check the perpendicularity of the clip arm. And this is an example. Look at this transgastric view. There is a cleft-like indentation in the middle of the anterior leaflet, which is divided in 2 scallops. And it's extremely important to be perpendicular to the line of coaptation, the anteroseptal one. Otherwise, we may open this cleft. So extremely important to check perpendicularity of the clip arm to the line of coaptation. Third key point is the grasping of the leaflet. We need to see the leaflet well in order to grasp them. And we need to have enough leaflet inside the clip So leaflet insertion is as important as in mitral. We want to have at least, let's say, 9 millimeter of leaflet insertion for XTW clip and 6 for NT or NTW clip, as for the mitral. So it's always important to check leaflet insertion and measure the gradient. The maximum gradient that we usually tolerate in the tricuspid is 3 millimeter of mercury. So it's rare to have more than 3 millimeter of mercury, but if you put more than one clip, you should always be aware that the threshold of gradient is lower than in mitral. Always important to check leaflet insertion in transgastric view as well. We need to confirm the tissue bridge. And now I show you two quick cases which are challenging, where we use some tricks to achieve procedural result. The first case is a patient with severe right ventricular dysfunction and pacemaker lead through the valve. We know that we can treat patient with pacemaker lead through the valve if the lead is not impinging one of the leaflet. So this patient had two challenges. One, the presence of the pacemaker lead, and second one, the right ventricle dysfunction. You see the right ventricle is bigger than the left one, if you see in this picture. So this is a patient where you should have, let's say, you should be prepared to deal with severe right ventricular dysfunction after the clipping. You see the longitudinal function of the ventricle is really low, so it's a really bad right ventricular function, but this patient was inoperable and highly symptomatic. So we decided to prepare him with diuretic and with levosimendan. So we put him in ICU to prepare him, and then we went for the procedure. Here you see the transgastric view. The valve is almost a bileaflet valve. The main jet is anteroseptal, and the lead is central toward posterior, so the lead is not really impinging the leaflet. So this is a case that we can treat. This is the first clip. We decided to use an XTW clip. We put the first clip in the anteroseptal line of captation. And then we went for a second clip, more centrally. There was still a mild to moderate jet centrally between the second clip and the pacemaker lead. But look at the right ventricle. The right ventricle, after the second clip, due to the reduction of the TR, became even worse. So now there is really severe right ventricular dysfunction, and the patient became hypotensive. So we stopped. We didn't want to abolish TR in this patient to further increase the afterload. So we were happy like this, and we put the patient back in the ICU, and we support him for 24 hours with dobutamine. And after 24 hours, the patient became stable, and it was feasible to discharge him to the normal ward. And after a few days, the patient was discharged home. 1 week after, the patient was asymptomatic, but still with renal dysfunction. So it was not feasible, not easy to keep him under maximal medical therapy. Now we have 1 month of the follow-up. The patient is doing well, but this explains you all the challenges. It's not just a matter of reducing TR. We should take care of the patient on a, let's say, under all the aspects. Another case, a case with suboptimal imaging and pulmonary hypertension, is a patient who had mitral valve replacement several years before with a mechanical prosthesis, and came to our attention in a decompensated way with severe pulmonary hypertension. Obviously, the presence of mechanical prosthesis creates shadowing. You see there was also pleural effusion, and you see the mechanical prosthesis. So it's a decompensated patient with actually bad imaging. The tricuspid regurgitation was severe. It was not feasible to achieve a good transgastric view in this patient due to the shadowing, unfortunately, which is quite rare, but it may happen. Pulmonary pressure, systolic one, was 61. But the grasping view was acceptable. So we decided to go for triclip, and here you see the insertion of the triclip system in the superior vena cava. So the first step is access with the guide catheter in the right atrium. Then the dilator is removed. There is also floppy septum, so you should pay attention during the steering. Now we steer, we insert the clip, and we do the straddling. And then we steer towards the tricuspid valve. Pay attention to avoid the floppy septum. After this, next step is to optimize the trajectory in the grasping view, which is RV inflow with X-plane. So now we are optimizing the trajectory. And once you have coaxial trajectory, you put yourself above the main jet. Usually you go transgastric, but in this case, again, a good transgastric was not achievable due to the mechanical prosthesis, which is unusual, but may happen. And then the clip, which was an XTW clip, was advanced. So we used 3D. 3D was excellent. We used 3D to orient the clip arm perpendicular to the anteroseptal line of captation. The aortic valve is at 12 o'clock in this view. Now we are perpendicular to the clip arm. And now you cross the valve and you close the clip with the reduction of TR. After one single clip, in this case, we had already 3 millimeters of mercury of gradient. Now we are just optimizing the grasping, because having the independent grasping feature allows you to optimize the leaflet insertion. It's quite common to optimize, especially the septal leaflet insertion, because the septal leaflet usually is shorter. And now the clip is released. And there was a tiny residual jet. So with one single clip, we were able to reduce TR in this patient despite the suboptimal imaging. The right ventricle tolerated really well in this case, despite the pulmonary pressure. This is pre and post. And this is the pre-discharge echo with mild residual TR, 3 millimeters of mercury of gradient, which is the maximum that we usually tolerate in the patient that clinical improvement. So in conclusion, I think the most important tips and tricks are related to patient selection, which again implies clinical and anatomical factors. The medical management is crucial, not only the preparation of the patient, but also the peri-procedural management and the post-procedural continuation of the therapy. The quality of the imaging is part of the screening. We should not treat patients with bad imaging. And then obviously, in order to speak everybody the same language, we need to standardize the definition, and the TVARC manuscript is finally almost coming out, and we are really looking forward to this standardized definition. Thank you for the attention.
Thank you, Dr. Taramasu, for the didactic lecture, methodical walkthrough, and the excellent cases. I think we are open to our panelist discussion by both overseas panelists as well as local panelists.
Hello, Taramasu. I'm Dr. Lam from Hong Kong. Thanks for your excellent talk.
Hi.
Good to see you again. And I want to ask, you mentioned about when the disease progressed, the RV becomes worse and the anatomy becomes terrible and the pulmonary hypertension actually may get worse. So what would be your approach nowadays to treat TR patients? Will you really treat it early, well before they respond to diuretics?
Yeah, obviously the tendency is to treat them earlier, as you said. And fortunately now, after a few years that we are running this tricuspid program, we are starting to see patients a bit earlier. At the beginning, when we started, like in 2016, even 2015, we were just seeing this terrible anatomy. Now we see patients a bit earlier. If the anatomy is terrible, let's say if the gap is too big, but the right ventricular function is still acceptable, probably transcatheter edge to edge is not the right therapy. You can try to optimize them with diuretic therapy, but if the gap is 1.5 centimeter, even if you if you reduce the gap acutely and you can clip the leaflet, then the chance of further dilatation of the ring and recurrent TR is too high. So those are probably patients for replacement or heterotopic implantation. If we see that the gap is still reasonable and the ventricle respond to inotropic preconditioning, we still try to repair them, because with the safety profile of repair, of edge-to-edge repair is higher than replacement, obviously. But obviously we need more data to really identify which patient should undergo in the direction of repair and which patient should undergo in the direction of repair and replacement in this gray zone. I would say that early treatment for sure is repair. Late treatment before the onset of irreversible right ventricular dysfunction should be probably replacement. In the middle, there is a gray zone where we should probably accumulate more data to really identify in which direction to go.
Yeah, I would really suggest, if possible, because we don't have so many patients, but in your centers or in parts of Europe, maybe we should conduct a trial like early TAVI trial. So we should actually randomize patient to diuretics alone versus early TEER in patient having a first episode of like right heart failure. And I think that's the way to go.
Yeah, absolutely. There are at least there are three ongoing randomized trials comparing medical therapy versus repair with TriClip. There is also one comparing with Pascal and one comparing with EVOLUT, which is a replacement device. So we will have this randomized data quite soon, but we need to wait still a couple of years. And obviously, these are really highly selected patients, so they will not necessarily reflect the everyday clinical practice. But yeah, this is the way to go, absolutely.
Okay, great. Thank you. It's Gary Jian from Hong Kong. So thank you for your lecture. As you mentioned, and also in verbal, that TER is becoming more popular and becoming more mature. But on the other hand, surgical options should still be one of the treatment options. So in your center, in your heart team, what kind of clinical criteria or echo criteria you will consider that is a surgical candidate or that is a catheter candidate? So what is your opinion in your team or also in Hong Kong? How about our local expertise? What's your opinion about whole? So can you share with us what kind of criteria we need to differentiate which kind of treatment is best for certain kind of patients?
Yes, it's a really good question because the bad result of surgery are related to late presentation of the patient. So there is this misconception that surgery is always bad for tricuspid, which is actually not true. It is bad if you treat patient too late. And for many years, we have been treating late patient. But now that there are transcatheter treatment available, we see also patient earlier and we see much more surgical candidates than before. So the surgical treatment of tricuspid is increasing as well again, fortunately. I think the most important parameter, together with the right ventricular function, is the age. So if the patient is young, and there are also young patients with isolated TR, we should really consider surgery. So I think age is the most important parameter. And then there are some dedicated risk score for tricuspid surgery. The most used in Europe is this TRI-score, which has been developed in France. And there is a clear correlation. You measure the age, the renal function. There is also the presence of other copathology like liver dysfunction, pulmonary hypertension. There are few really easy parameters, and you can predict the surgical mortality quite well. And let's say that if the predicted surgical mortality is above 5, according to this TRI-score, in our center, we consider transcatheter. But if it is less than 5 and the patient is young, we consider surgery. So I think this score should be implemented in every clinical practice. It's really helpful.
Thank you, Dr. Ho.
Yes. In Hong Kong, basically, the development of TriClip is still new. So for patients, especially with concomitant left side heart surgery, we'll offer early tricuspid valve surgery as well. So as I also agree with the speaker that in case the patients with very high risk surgery, cardiac surgery, we often consider catheter-based intervention.
Totally agree with you. Okay, thank you. I think time is up. I think we should go on for the second lecture, right?
Thank you.
Thank you, Dr. Masu. So now we have the honor of Dr. Yo from Singapore to present his excellent lecture on a novel device in treating tricuspid regurgitation. Dr. Yo, the stage is yours.
Thank you very much. Thank you for inviting me to Hong Kong Valves. This talk is titled Trick Valve Bicable System for Severe TR and the Rational Procedure Overview and Clinical Updates. We know that TR is a bad thing. It has a severe impact on long-term survival, especially in patients with chronic heart failure and LV dysfunction. This combination of 3 studies with the various Kaplan-Meier curves show that in patients with severe TR, outcomes are worse, whether it is in patients with a history of heart failure or in patients with an LV ejection fraction of less than 50%. There are various algorithms proposed for how we might want to approach TR. And in this day and age, as you heard from the previous speaker, you can have TIR, but now you also have other technologies coming into play with transcatheter valve replacement technologies, as well as annuloplasty devices. And in this case, we are talking about a trick valve, which is a heterotopic valve implantation in the IVC and SVC. So what is the trick valve? We have already mentioned some of these treatment options, and what we're talking about is a heterotopic cable valve implantation, as you can see in this slide here. And really, this addresses a population segment which would include those with severely dilated tricuspid annulus. You saw from Maurizio's presentation that he had a selection of cases where the coaptation gap was significantly large, and these may not be suitable for TIR. And then there are those with prior pacemaker leads, and you know that approximately 10 to 15% would impinge on the valve leaflet, making them not suitable for TIR and related devices. The trick valve bicable system comprised of two self-expanding biological valves, and essentially they bypass the tricuspid valve. They don't care about the tricuspid valve, and they treat the problem upstream where the SVC and the IVC are. And this is meant to help treat the underlying complications arising from severe TR with the cable reflux. And based on the original premise of the technology, it was meant for patients at high risk for open heart surgery. And the objectives of treatment are to improve NYHA class, improve the 6-minute walk distance, and the quality of life. And so some of us, when we first deploy this technology in our respective institutions, see it as the one option where other options have failed. And essentially, if you look at it in this slide, what you do is you reduce congestion, especially in the below the IVC and the hepatic and the renal systems, and this hopefully would improve right ventricular remodeling and improve cardiac output. Now, there are some questions that remain unanswered, and I won't say that we have all the answers. For example, to what degree must we prevent the backflow, and will the increased pressures in the right atrium prevent any filling of the right atrium when the valves do open? But ultimately, the goal is to improve symptoms and hopefully demonstrate the ability to reduce mortality as well. This is the trick valve system. The valve is dehydrated, and there's anti-calcification treatment applied. It's meant to be easy to use. In the IVC on the left side, this is a somewhat larger valve, and it has a short skirt to avoid hepatic vein occlusion. And there's a skirt and a suture line that you can see on fluoro with some landmarks that will allow you to avoid the impinging on the hepatic vein. In the SVC, there's a little bell in the middle that helps you to oppose against the SVC, and it is important to avoid the left brachiocephalic vein, as well as to also avoid impinging on the pulmonary artery as it rides over the SVC. Both systems are based out of a nitinol self-expanding stent platform. There's a matrix of sizes, and to be perfectly honest, I can't remember this thing. Usually we have to look at the, after the CT sizing exercise, we would work with the vendor to size the device accordingly. In our series of cases, we have all required off-label use of non-CE approved devices of the largest size, which is now available, at least in my country, by special access. So this is the SVC valve positioning. You will see here the device on the diagram on the left depicts some of the key landmarks. You really want to avoid where the bell is. You want to avoid the pulmonary artery where it rides across the SVC. So the bell is I can't remember the exact technical term, but the bell is above the pulmonary artery, and the upper margin of the bell is where the upper border of the brachiocephalic vein is. And on the right two pictures, you can see the device as it is deployed in the SVC. In the IVC, due to the canting of the IVC entrance into the right atrium, positioning is a bit more tricky, depending on the angulation of the IVC as it enters. But the key principles are to make sure that you have adequate cover of the RA IVC junction, And the landmarks shown here are the skirt, as you see on the on the depiction on the, if you can see my mouse over here, you want to make sure that you are well into the RA, and the skirt would avoid the IVC, the hepatic vein entrance as well. In this case here, they have used a landmark with a pigtail at the hepatic vein. There are some important selection criteria. One is that the V wave has to be at least 15 millimeters of mercury for there to be a clinical benefit. Ideally, the RV shouldn't be failing, and the company would like to make sure that these are not patients with significant pulmonary hypertension. And in patients with high volume overload, there is a recommendation for adequate diuresis. Some clinical data, the system has been in place in various parts of the world. There's early feasibility trial and a TRICAS Euro study, which was just published fairly recently. And I just want to highlight a few key points, and that is in a TRICAS Euro study, the vast majority of patients had atrial fibrillation, and up to 25% had a pacemaker, and about 9% had chronic kidney disease, liver disease. In terms of the results, I think the in-hospital mortality, very good results. Technical and procedural success were excellent, in excess of 95%. And whether you look at the KCCQ quality of life score, clinical improvement, whether you look at MHA class, persistent improvement, or 6-minute walk distance, also clinical improvement. And in this summary slide from Jack interventions, you can appreciate that the summary is that there is a high degree of technical success with 0% 6-month cardiac death and persistent functional improvement. With, as I mentioned before, improvement in MHA class. Now, of all the major adverse cardiovascular events beyond 6 months, you do have some associated cardiovascular events. And in this group of high surgical risk patients, obviously there will be some complications. But the one that is most common is that of transient right shoulder pain, which can be really annoying. In our first patient, it was really quite a pain, but it resolved after 2 weeks. TRICAF is a prospective multi-center randomized controlled clinical trial that's underway and will randomize 1:1 200 symptomatic severe TR patients to trick valve versus medical therapy. So we await eagerly the results, which I think will take some time to accrue. Very quickly to the last part, this is a case report and basically shows the deployment of this trick valve system. I wanted to show this here, which is that with a successful implantation of the device, you can see the improvement in the IVC pressure waveforms, which I think results in a clinical improvement. And in heart center, this is our first case. This patient has a lot of hardware, EVA, THVs, mitral clips, tri-clips. He has like 3 or 4 cardiothoracic heart valve surgeries and whatnot. He's got a history of bad Marfan's. And you can see that we have now the trick valve in place. He's obviously not a great surgical candidate, and the surgeons refer him to us. And I want to demonstrate here the very nice improvement in the IVC pressures from a V wave of 33 with abolishment of the V wave and the mean from which shows a very nice hemodynamic result, which is anticipated on this device. This patient did very well. He had the right shoulder pain, which was treated, and he has done well. So now in our armamentarium, we have a whole bunch of devices. Not all of them are available in parts of Asia. We still don't have the Pascal device. We have the tri-clip, and I think we appreciate the tier devices with tri-clip here as well in parts of Asia, and the trick valve is now available for us as well. And I think there are pros and cons of each of these devices. For us, trick valve, we apply if they are not suitable for tier. Tier with the greater clinical data available is still our first choice, but of course there are all these constraints and limitations as to the patient selection. So for trick valve, we consider them in the patients who are not suitable for either high-risk surgery or tri-clip. So in summary, the trick valve heterotopic valve replacement system is a new promising treatment option for patients with severe TR at high surgical risk. Early data suggests clinical benefit with improvements in quality of life, 6-minute walk distance, and MIHA class. Thank you very much for your kind attention. I believe there's a video after this, and we have a discussion after that. If I may suggest, perhaps we could go to the video first. Thank you. I think the video is
Thanks everyone for being here
one
with
of
us
our
today.
cases.
My name is Dr. KK Yo from the National Heart Center, Singapore. With me is Professor Jack Tan and Dr. Wong Ning Yen, working on this procedure together, the first trick valve in Singapore. We also have with us Professor Yu Si Hui, who is our lead echocardiologist, and our Sister Tina, who's going to be with us today. So the V wave on the IVC is 34, 33, 34, so recorded. So the V wave on the SVC, as you can see, is about 37, 39, which is of course consistent with the severe tricuspid regurgitation. All right, very good. Okay. So now we'll come down to the RA. Okay, so this is RA pressures. See? So right atrial pressure is consistent with both the IVC and the SVC. Our picture is here. Okay, now we are ready to go up with the unplugged super stiff wire and then ready with the device.
So we'll use the clavicle as a road mark just at the level of the clavicle. I'm going slowly down. Okay. I don't know when I can do it fast, so I'm just doing it slow. Because you don't know when it's going to jump.
Wait, stop.
Yep.
Save. Okay, floor on again.
You know when, but you don't. Yeah, I don't know. Okay, it's jumping out a bit.
I pull back a touch.
Do you need a bit lower, or this is okay?
The
It's
left,
okay.
the left edge of the device is on the clavicle, so I pull back again.
You can feel some tension, right?
Yep, okay. My hand is tired from resisting you.
Really, opening up.
Yep.
Resistance is futile. Okay,
Safe.
so it's like semi-open on the...
I think the roadmap doesn't help, Jack.
Okay, let's off the... It may help a little bit. We off the mask. Off the mask, yeah.
I pull back again.
Yeah.
Try to hold the position and don't let it go higher or lower.
Yeah, I'm supporting it.
So at this stage, I should go very slow, or
Safe.
this is okay?
Mask
off the mask. Okay.
Slower the better.
Yeah. I just let it slowly come out. Off the mask, yeah.
Okay, safe again.
Off the mask first.
Can we off the whole roadmap function now? Yep.
Is this position still okay?
Yes.
Okay, looks good. Yeah, continue.
Has it moved already? No, right?
No.
It's still at the clavicle.
The left side is still on the clavicular edge.
The position is perfect.
See?
But we have the space enough to put the valve. You can continue.
Is it going out a bit?
The belly is being exposed already.
We need to pull back the picture.
Now the belly.
Oh, so the pigtail, can we remain here, or do we need to pull back the pigtail? Is it okay?
Yeah, we do get the rock a little more.
Okay, save that.
Anyway, if the pigtail is placed, doesn't matter. You can remove a wire.
Okay, I'm going to take a bit slower here, huh? It looks, we all agree, has it ridden a bit higher? I'm not
I pull back a bit.
You pull back?
Yeah, pull back a bit. You see the edge of the circle is right on the edge of the clavicle.
Anyway, we're way above the swan, huh?
Yep, belly is way above.
Can we stop here on the lid? If you remember, at the distal part of the valve, at the bottom, the vestibular mesh, there are two connectors. So the intention is to release the connectors one by one, waiting 1 minute between each connector.
Okay, but we are very far away from that at the moment.
I think for now I think it's a good moment to
Yes, to see the left innominate, which we can see.
You ready?
Give me a minute.
We'll do injection.
Okay, I'm going to go down some more. I'm just going to go very slow now. Okay, I'm going to slow down a bit more. It's tempting to just crank it.
Save that.
Oh, you get what I mean, right?
Yeah. We will be. Ideally, it should be between, right, the innominate vein and the wire.
Oh, let's concentrate on part. I think it's riding a bit. Okay, I'm going to crank down. You're holding pressure down now.
And I pull back a bit actually.
Okay, so I'm not too sure when the first one will be released. You tell me. I'm going to go slow. Still some more. Is this too low? Would it be still above the...
The belly is actually way above, right? So are we in a good position? We are, right?
Yes.
Okay, one is released. I felt it give.
I didn't do anything.
Yeah,
so,
I felt it happen in my hand.
So we give it a while for it to stabilize before releasing the other one. That's the point, right?
Yeah. Wait.
Okay, we'll wait now. At this moment, do I pull down the pigtail or do a test shot?
Do we pull the pigtail down?
Remove. Pull down.
Let me do it. Just hold it now. Okay. Actually, you wouldn't jam. It doesn't feel like it.
Yeah. He said it doesn't. He says it's okay. He said you cannot just go away. Yeah, but I mean, for
safe.
First time.
It feels stable. I didn't feel any more jumping.
You know, I'm going to release. No need to wait, huh?
Release a second.
Okay, it's released.
So we released everything already, is that correct? Safe?
We recover slow. Yeah, inferior is very important.
So this is okay, yeah?
So
we are fully released, yeah? We are fully released.
Just feel a few more turns. Okay, I'm at the end now.
Okay, unlock.
So now I lock it, correct?
Unlock it.
Unlock it.
I'm pulling down. Okay.
Okay. Pull down the device.
Yes.
Is that correct?
Yes.
Let's see the top end of the wire for me.
Actually, you can stay here. It's not, you want to watch it. Not enough?
Okay, I'm gonna, okay, enough. I just pull back the wire.
Just focus on the valve, man.
Okay, I'm gonna pull back now. Very slowly.
Leave the wire.
So we're going to close the nose cone in the IVC. Is that what you said?
Exactly.
No resistance. Very smooth. Okay, the nose cone is out. Then we'll go and close it in the IVC. Let's pan down, please.
Wait, say first. Say.
Inside the IVC. Okay. Can we scroll down some more?
More.
Okay, now we're in IVC. Okay, you hold the wire. Can I see the bottom part where it's going to move? Let's pan down some more. Down some more. Okay, good. Save. Stop there.
Yep. See?
Okay.
Lock.
Okay.
See the wire on top.
See the wire on top, please. Let's make sure the wire isn't drifted too much.
Then again, it doesn't matter.
You don't want to go too high. Okay, that's good.
Push the wire in.
Yeah.
Okay.
Good. So let's get our second device out. All right, we're going in with the second device now, the IVC. Okay. Doesn't matter, that's not wire. See?
So let's agree that the initial deployment is at the level of the clip now, based on what I'm saying. At the level of the sternal wire,
wire,
the last one, so we go a bit higher.
I've gone up higher.
somewhere here. He's going to jump. So
You like this position?
Yes.
Okay, good. Okay, so this is actually a good picture to look at again. So let's look at this together. So the hepatic vein is actually, the entrance to the IVC is actually above, way above, at least 2 millimeters above the last sternal wire. So we should remember that, yeah?
The spine and the...
Yeah, at the level of the spine, at least, yeah?
Between the spine and the sternal wire.
Yeah, in between. In between.
Got
so
it.
let's Laura and see. Maybe a bit higher. Okay, yeah. Higher?
Yeah, I think it's here, you know?
You think it's here? I think it looks a bit too high. No?
No, I think it's fine. Okay, let me show you. Let's go through this together. So you see the top part of the IVC where the hepatic vein joins. You can see where it is. It is right at the bottom, near the lower level of the nose cone. And that is at the level...
Top end of the
correct,
spinal
but
column.
on top of it, you want it a little bit in. You want it still a little bit in on top. That's why they want it at the inferior border.
So minimum is the top end of the spinal column.
Yep.
Okay,
Yeah.
got it. So about here is good.
Yep.
Maybe a bit too high now.
This is fine.
No, this is good.
Okay, I'm going to open the first 8. This is the second click round. You're feeling any tension?
This level is good, yeah? Right?
Yeah. It's a good position to start.
3, 4, 5,
Got
6,
it? Don't go higher. I hear
7,
you.
8. So I'm at 8 turns.
I'll pull back a touch because I don't want to go higher.
Here is good. I thought it's not too high. Laura? 9. You feel any tension now?
Not yet. I'm pulling back a touch.
Okay, I'm going to give you a while. It's going to deploy already. Okay. Now I'm going to go very slow now.
Okay, we won't let it go forward.
Okay, the reason why I'm thinking of injection is we are at the upper lip, but is this too high, too low? Do we need or do we not need an injection now?
No, I think
You think it's good?
I think it's good.
Okay.
You can recapture it. You see the right side is very high up. Very high up.
So you need the upper lip.
We need the upper lip. Where we are now is pretty good. Otherwise you'll be blocking a lot of that hepatic
Yeah,
osteum.
that's true. Okay.
So we are 2 cm inside. So I'm going to pull back a touch, huh?
So are we happy with the ocean before I turn some more? Okay, that's good. That's all I need.
Stop there.
Stop there. Are we still good? Our echo looks good still, huh? Okay.
It doesn't look very high, you know.
Yeah, I think I'm happy.
I'm going to release some more.
This is very, very slowly because the very unstable position is very related.
You're holding, okay.
Are we in a stable position? No, Swan. Do you like this position? Okay. Yeah, we're happy. So we have really released one of the...
Then we wait a while.
One of the markers is really released, you
Can
know.
we have a timer?
See?
How many minutes now? Where's the timer?
52 seconds.
Okay, we will release at 1 minute now, I think. Everyone is okay?
Yep. Okay, it's 1 minute. Okay, we release another one. Save that.
We didn't move. I think we'll release the last one after 1 minute now. Let's slowly.
Okay.
I can't see the timer thing.
No, it's here.
Oh, okay.
Okay. 1 minute.
Releasing the last connector.
Very slowly.
I
don't think you're released.
I know. I just very, very slowly. You're holding.
Oh, yeah,
okay.
there. Save that. Okay, that's released. Okay, are we fully released?
It's not fully. There's still a bit.
We give it a while. I think it will pop out. I'm not actually fully back. Okay, I'm gonna just walk back now.
Release.
Okay.
Save that.
In fact, it's centered a bit more.
Yeah, it didn't jump.
It's centered about. Shall we?
Okay, ready?
Yeah, ready.
Very good. Not off limit.
Okay, Bill.
So now we're going to walk down to the IVC to recapture, right?
Yeah, lock it first.
Sorry, what is it?
Lock it.
Okay, we're going to walk back down. We walk down to recapture, not recapture here, right? Is that correct? So we're going to walk down to the IVC. Okay. Let's make sure we don't catch the top end. It's smooth. It's a bit on the offset. Huh?
Yeah. Didn't catch.
I didn't catch anything.
Nice.
Nice. Okay, good. Safe.
Let's check the valve first. The valve okay? There's still a wire across. Okay, let's see the bottom.
How many millimeters are inside the
Let's see the bottom part when I push in. Help me hold the wire. Okay, I'm gonna push in the actuator.
Yeah, not really.
Let's center below. Let's see more the IVC valve.
Okay, this is good. Too much. Okay, good. Perfect.
Okay, good.
Ready, huh?
Full everything.
You gotta whack all of it.
Nothing.
Yeah, because there is no reflow in the pure. The result of the pure is perfect.
Yep, looks good, huh?
Very challenging, and the result is
I've never seen so much hardware before.
Thank you.
Thank you, thank you.
Okay, and then now we're measuring the PA pressure.
ACT, Yong.
And ACT, yep.
Okay, let's measure PA.
This PA pressure.
Not much change, huh? In fact, higher.
Higher.
Why is it so?
Because all going forward.
Yes, yes.
We'll measure that shortly. Well, we want these numbers because we can understand what happens to the hemo. So the pressure now is a more going forward flow, so it's higher lah. Okay, so good. We have got that. We're going to pull back to the RV. We'll pull back to the RV first.
RV pressure.
Okay, so this is RV pressure.
The long exchange wire
Which is good. You will remodel.
Yes.
Okay, now we're going to go back to the RV.
You got RV pressure? You got
Yeah, better.
Okay, back to. Make sure I don't hit the. Don't pull on the wrong structure.
Should my second IVC now first.
Okay.
RA.
RA.
Okay, we're going to go in
Wait,
change
RA
out the
pressure.
JR.
Hold on, I haven't recorded yet.
You got RA pressure? Of course, RA pressure is still high.
We are going to just measure pressure, that's all.
Pull back some of the wire. Okay, connected. Okay, now this is.
Pull back a bit. It's against the wall. Okay, good. Okay, this is denominate.
It's SVC pressure.
Still high, yeah?
No change, eh? It's about the same.
So now this is IVC pressure.
It's correct, lah.
Okay. No more.
No
There's
more
no
V
V
wave.
wave.
No more V wave. Good respiratory variation.
Mean is still around, but there's no more peak.
Thank you very much for staying with us. Thank you. Good night. Thank you. Thanks for all your help and guidance.
Thank you.
Have a Merry Christmas, great year ahead, please.
Merry Christmas, Happy New Year. Bye-bye.
Bye.
Yeah, sorry, that was our first case. We did it late last year, and I think Christmas is around this, coming along again soon. So we, anyway, that case was our very first case. As you see, the procedure was we had to do it very slowly to make sure that the device didn't jump for both the SVC and the IVC valve. Each time we make a turn for the deployment of the self-expanding stent, we had to give it enough time for the stent to deploy. I think we are into discussion. Yes. Back to you guys.
Okay, Dr. Daisuke and Dr. Jimanakuki, welcome to Hong Kong Valves. So what's the situation in Japan and Thailand? So are medical therapy and surgery the mainstay treatment for these patients, or do you look into any transcatheter options?
Yep, so...
Yes, okay, go ahead.
Yep. In our country, we have the heart failure specialist, and before we decided to manipulate the tricuspid valve, we have to out many things like the pulmonary hypertension from the pulmonary artery disease or from the left side disease. Many times we discuss and that we will teach the left side and teach the pulmonary first, and after a lot of discussion, sometimes the tricuspid valve will be the last thing that we try to treat. And that's why we don't have a lot of experience for treatment of tricuspid valve. But I think with you invited me to join, I think I have a lot of inspiration to touch this field. Thank you very much.
Okay, in Japan, so first of all, we usually consider medication for TR, but if so diuretics is prescribed and the renal function is worsened, so we usually consider surgical treatment. Especially in our hospital, we can do beating TAP. So in that case, we do mixed surgery for this patient. Actually, in Japan, the TriClip or other devices are now clinical trial, so we can't do such transcatheter treatment in Japan.
Thank you.
Hi, KK. It's Gary from Hong Kong.
Hi, Gary.
Congratulations for your successful cases on trach valve. So I would like to ask you that, in your opinion or in your experience, how to choose between the trach valve and also TriClip for those patients with severe TR? And so can you share with us what's your opinion?
Yeah, thanks very much, Gary. So for us, we have both the TriClip and the trach valve available here. In general, because the TriClip platform, the tier devices have a lot more data, we generally would consider them as preferred treatment options in patients who fail medical therapy and who are not surgical candidates. So in patients that we are reviewing for trach valve, for TriClip, the same considerations that you saw from Maurizio's talk apply, which range from the anatomy, whether there's a coaptation gap, how big the coaptation gap, whether there's a pacemaker lead, and in patients that are suitable, we'll go for the TriClip. The first patient we did for the trach valve, in fact, the first two patients that we did were those who failed the TriClip. Either the coaptation gap remained, too large, such that even though we clipped the leaflets near the commissures, we were not able to meaningfully reduce TR, or in whom we had single leaflet attachment. So those were our first two cases in which we did a trach valve. Our third case was where we said there's no point in trying because the coaptation gap was like a 2 cm. So we did the trach valve straight off the back. So in terms of the algorithm in our minds of the heart team here in Heart Center is, number one, patients who are high surgical risk and who have failed optimal medical therapy and who remain severely symptomatic or with other evidence of right ventricular dysfunction or end organ injury such as cirrhosis, and in which case we will consider the TriClip first. If they are suitable, we proceed with TriClip. If they fail the TriClip or if they're not suitable for the TriClip, then we offer the trach valve. The trach valve does have, of course, certain considerations as well. Our biggest headache is actually sizing. We had one patient that we had to reject because the IVC was like 55 or 56 millimeters, and there was no size available for that at that point in time. I hope that helps. Over.
Okay, thank you, KK. So I would like to ask, is the renal impairment, kidney function, is a contraindication for trick valve because it seems that it use contrast more compared to TriClip.
Yeah, that is certainly a consideration. A lot depends on what is driving the renal impairment. If it is the TR itself that is causing renal congestion, fixing the TR may help the renal function. Having said that, sometimes the patients present to us too late and the creatinine is already CKD stage 4, then there's a sort of a risk-benefit calculation that you have to do with the patient. We had a patient in whom we felt would be better treated with a trick valve rather than a TriClip, but the creatinine was 200 over, and the patient declined at risk because you need the contrast for both pre-procedure planning and then also for the procedure itself. So I think that is one of those, how do I put it, pros and cons discussion you need to have with the patient. And some patients, we would try the TriClip first before we would, offer the trick valve, especially if we are stuck with this kind of scenario.
Thank you, KK. So, YY, can you share with us what's your experience of your trick valve in Hong Kong?
Maybe I just briefly discuss what tools we are available in Hong Kong. Yes. So we have annuloplasty devices. So cardioband is not available. So we are doing a focal annuloplasty with a K-clip device from China. And also we have TEER, of course, with TriClip, and we have trick valve. And meanwhile, we still don't have transcatheter TVR, so orthotropic replacement. I think for my experience with trick valve, one thing very important is really about the afterload increase after the procedure, because we have patients really respond quite nicely after the procedure, and there are patients really don't do that well. I think the THVs that they are using to assess the RV function is probably too low. 12 millimeter, I think, is signify quite severe RV dysfunction already. And if the patient also had pulmonary hypertension, like approaching 60, 50, 60, these probably are not patients really good for trick valve implantation, because after you abolish all the TR, the afterload will increase. And I even think about in one of my patients, really very borderline, because these are really no option patients, running out of option, very poor patients. Usually they tend to present very late with low RV function and pulmonary hypertension. I skipped the SVC portion. I think by this, I still preserve some of the reservoir. So I only implant the IVC portion of the trick valve. And in that case, the patient's actually doing quite okay with a resolution of lower limb edema. And I think that's more important for them. I think at this stage, if they present really late, what we are aiming at is not really improvement in mortality. We want just to improve symptoms, give them better days in their remaining days. So I think this is very important. I think in the future, when we have more options, like annuloplasty device or TEER are more for early presentations. And for late presentations, I think we have to look at the RV function. If the RV function afterload is really bad, then maybe I still think suboptimal TEER, some form of TR reduction surgery with a bit of TR reduction, residual TR may be good for them. Otherwise, maybe transcatheter tricuspid valve replacement at the original position is my first choice. And if that is not feasible, then maybe trick valve is another option.
Thank you for the insightful discussion and the excellent case and the sharing. We would like to proceed to our recorded case in Hong Kong. So Dr. Michael C., our interventional cardiologist, will present the case. Well, this is meant to be an interactive discussion engaging all the overseas and local panelists. So please.
Thank you, Eric, and all the expert panelists here. So I'm Dr. Michael C. I will present our case. So let's move on to our case in a box. Okay, so let's begin playing our case. Thank you. So this case is a case we are performing transfemoral mitral valving ring with an ASD closure and a trach valve. So the patient is 60-year-old with underlying rheumatic heart disease with previous aortic valve replacement with the old generation Medtronic Hall valve, and also mitral valvuloplasty around 30 years ago. He had multiple comorbidities, including lung disease and recurrent heart failure, and the patient presented with severe mitral stenosis and torrential tricuspid regurgitation. And in fact, the patient is very cardiac cachexic with a BMI of only 16. So from the echo, you can see that in the annuloplasty ring, the valve is degenerated and stenosed, and you may not appreciate the wide coaptation gap for the TR, but mind you that the scale is actually very large, and the gap is more than 1.5 cm. So I think we will agree that it's a very difficult case for TEER. So for this case, we like to perform the mitral intervention first. So this is a semi-rigid ring. So we plan to perform a transseptal crossing, and then plan to implant a sapien valve inside the previous annuloplasty ring. So this is us performing the transseptal puncture. Again, we're aiming at the inferior and posterior area. This is the previous Baylis, now Boston VersaCross transseptal toolkit. So for all of our transseptal mitral cases, we perform balloon dilatation of the septum, as you will see very soon. And you can see the Medtronic Hall valve, which is a single tilting disc device in the middle of the screen. So with the Agilis catheter, we will cross the mitral annuloplasty ring, and from the measurement on the CT, the widest diameter is around 29 millimeters and a shock axis of 18, and we will be putting in a 29 millimeter sapien 3 through this valve. So we're positioning this pigtail catheter into the apex of the LV. Sometimes we do encounter difficulty with the positioning of the safari wire. It does require exchanging, and we change to a small safari curve. And then we perform a balloon dilatation of the septum. And we are ready to cross the septum with the sapien system. This is around a 12 millimeter peripheral balloon. And again, you can see that the RA is very enlarged. It's very difficult for us to position even the pacing lead into the RV. So we are using a Agilis device, a Agilis serial sheath, actually to guide us into the RV, just for the pacing lead, the temporary pacing lead. So this is the 29 millimeter sapien crossing the annuloplasty ring. And we are trying to position it with the skirt around 20% inside the LA side. And of course, we will be performing under rapid pacing. So in general, we don't require any contrast injection for these deployment, just a very slow, and using the annuloplasty ring as a landmark. Okay, so this is the final deployment. So we're taking it very slowly. We're pacing around 160 to 170. So you can see that we are doing it very slowly with gentle push. The device will actually self-center itself around the annuloplasty ring. So in fact, this is a semi-rigid ring. So with a 29mm Sapien, you will expand the annuloplasty ring and make it more circular as compared with a very rigid ring. So I think we are done with the mitral. So as you will see, we will be again performing assessment of the tricuspid and also the atrial septum, which we've performed balloon dilatation. This is the final angiogram. You can see there's no trace of mitral regurgitation. And also on the echo and hemodynamic monitoring, there's no significant mitral stenosis. So this is the atrial septum after performing the mitral intervention. You can see the bidirectional shunt. So we are concerned about this shunt because after correcting, implanting the trick valve, this shunt may cause significant reversal and even desaturation in the systemic circulation. So we also implant an ASD device to close this septum iatrogenic ASD. And then we'll proceed to our trick valve implantation. So may I ask the expert panelist, in general, all of these patients present quite late. And is there any other way, because all of the patients don't have any significant symptoms, or at the time of presentation, they already develop very severe RV dysfunction. So would there be any advice on monitoring in these sort of patients? Perhaps Dr. Ko, in your clinical practice?
You mean how to...
So in patients with multiple valve pathologies and tricuspid regurgitation.
Yeah, I mean, with patients with multiple valve pathologies, we just...
so with also tricuspid regurgitation.
Yeah.
So some people may have some monitoring, like monitoring the liver ultrasound, the degree of fibrosis.
For us, it's mainly clinical. I mean, we would obviously do the serial ultrasounds and the echocardiograms and everything. But for us, we often consider pushing them into interventions when they clinically become symptomatic. And I think if you look at a lot of the speakers today, it's about how to make it so that you do it early without making all the procedures futile. We will often start pushing our patients into consideration, at least for the intervention, when they have the hints of lower limb edema. We'll often monitor during ultrasound the IVC diameters and so on and so forth.
Yeah, so the problem is really that they present with a very long-standing history of asymptomatic state until they do decompensate. So this is the angiogram.
Can I make a comment on that?
Yeah, sure.
I always say diuretic is the enemy of RV. If you have a left heart failure, you give diuretics, patient feel better, you treat the mitral valve. Why we are treating differently for tricuspid regurgitation is this is something historical, because the surgical results for isolated TR surgery is not nice. That's why we tend to forget this valve and treat it really late. We think we are helping the patient, but in terms of symptom, but we are delaying the treatment progress. The RV gets worse, the pulmonary hypertension get worse, the RV annulus get bigger. So then you ended up with a very late stage. You don't know how to treat. There are, in fact, a data from Rebecca Hahn published in JACC they're actually using the RV long axis function and pulmonary pressure. They have this ratio, THV over PASP, very simple pressure to measure the degree of afterload, how high the patient will develop after mismatch, after any kind of intervention. They show that if the ratio is less than 0.4, it means that you have uncoupling of RV and PA function. So these patients are not going to do well after intervention. So I think with more knowledge these days, with more treatment available, option available, be it early surgery or early transcatheter intervention, we are going to change this practice. And hopefully the science, including the few randomized control trials that currently being planned between transcatheter and medical therapy, we are going to change this practice. And we don't see patients like that. That's really bad.
Yeah, unfortunately, this patient already presented very late, and all these procedure is sort of, as you have said, a palliative procedure. And as you can see that we have already implanted the SVC portion of the trach valve. So for this patient, the difficulty is that the distance from the right jugular, right subclavian, and also left innominate vein is quite long. So that the left innominate is positioned quite close to the RA. So that's why we need to implant the valve quite deep and with the belly partially covering the inlet of the innominate vein. Fortunately, still the innominate vein is patent, and there's flow around the valve. So this is the angiogram from the hepatic vein. So as you will see from the CT scan, actually the landing zone of the valve is very small. Actually, the valve should land all the way inside the RA, even touching the atrial septum. In this case, it's even touching the atrial septal occluder in this case. So it's nearly impossible to not have some impingement or covering of the hepatic vein based on the CT assessment. So we are unsheathing and deploying the IVC portion of the trach valve based on fluoro and of course echo. As you can see, the medial portion of the trach valve is actually all the way inside the RA and touching the atrial septum and our ASD occluder.
Okay.
So we are preparing to release this device.
So keep downwards tension. Shall I remove the pigtail?
Yeah, you can.
Oh. Okay.
No.
So the positioning of the trach valve is the anchorage is from the oversizing. The device is actually more than 40 millimeters at the bottom. So it's anchoring from the oversizing and its trapezius shape all the way into the inferior part of the IVC. So you can see that the valve is all the way inside the right atrium. And there's a faint radiolucent line, which is where the skirt ends, which will be inside the inferior portion, somewhere in the hepatic vein. So we're taking extra caution not to have any interaction with the frame of the trach valve.
Before you do the angio, remove the wire because otherwise the valve
yes.
not.
So we remove the system first, together with the wire, and we close.
Okay, it's nice, it's nice. At least we don't have leaks.
So from the echo, there's no significant PVL into the IVC and also the SVC. Angiogram may be misleading with the contrast, stasis. So with time, we do expect all these patients will have progressive RV dilatation and RV failure, but I think this is the best we can do for this particular patient in terms of palliation, and with a simple groin puncture and device intervention, we can improve their symptoms. So thank you very much.
Thank you. I can update you with the patient progress. He's right now ambulatory discharge, much improved kidney and liver dysfunction, and he's doing well. So thank you very much for the case, and thank you for all the local and overseas panelists and speakers. Thank you, Dr. Tamaramasu. Thank you, Dr. Daisuke. Thank you, Dr. Jimenu Kuki. And thank you, Dr. Yo. And let's move on to our next session.
Thank you.
Good afternoon, everyone. I'm Dr. Anthony Wong from the Hong Kong Sanatorium and Hospital. So welcome to the last session of Hong Kong Valve 2022. So in this session, we'll try to continue to cover the innovations on tricuspid and mitral valve management. And we are very honored to have invited distinguished guests from both overseas and also local area. So without further ado, may I introduce our expert panelists. So first, we have Professor Junsun Kim from the Yonsei University Hospital from Korea, and Dr. Payanat Prayanod from Thailand. And locally, we also have invited Dr. Lam Ho, consultant cardiologist from Tuen Mun Hospital, Dr. Danny Chow, consultant cardiologist from St. Paul Hospital, Dr. Kevin Chen, associate consultant from PYNEH, Dr. Lau Yukong, the co-chairman of the very famous conference ECHO Hong Kong, and Professor David Seal, the honorary professor of in medicine in the Hong Kong University. So first we will have a masterclass lecture from our very honored guest from Korea. So we have Professor Du Park. He's a professor in medicine in the Asan Medical Center, and he graduated from the Aosan University, Aosan College of Medicine in Korea, and he received MS and PhD from the University of Aosan College of Medicine. His primary research interest has been in coronary revascularization treatment, such as PCI, CABG, and most famously left main intervention, TAVI, antiplatelet therapies, and biomarkers. He has been the investigator of many clinical trials, including landmark trials published in the New England Journal of Medicine. He's the deputy editor of JACC Asia, and also co-chair of TCT-AP. So without further delay, may I pass the stage to Professor Park, please.
Okay, thank you, Anthony. And having this year Hong Kong Valve 2022 meeting, I'm very honored to present this wonderful lecture for the audience. And absolutely, I would like to participate the next year in person HK meeting 2023. So today my topic is about the coronary masterclass in TAVI procedure. There are many issues. The timing of revascularization, how can you protect, what are the high-risk factors, and valve-in-valve procedure, and tips and tricks on post-TAVI coronary access, and more. So this is my disclosure. So I'm going to start my case with a very interesting case presentation. 78-year female, initially presented non-STEMI, and she had a multiple risk factor, diabetic and hypertension, and the right internal carotid artery stenosis. STS score is quite low, and the sinus rhythm and the echocardiography showed severe AS and normal ejection fraction. And looking at the coronary angio view, as everybody easily recognized, there was a significant left main added ostium and subostium disease. And so as a usual practice, we put the two stent and the left main proximity giant stent and prox-suck and giant stent, and the result was excellent. So, and this patient has concomitant aortic valve stenosis. Usually simple region, we do simultaneously PCI and TAVI procedure. Like this left main case, we do left main PCI first, and then a couple of days later, we did TAVI procedure. And looking at the patient anatomic by CT, and short diameter is 19, long diameter is 24, mean diameter is 22, perimeter is 69. So sinus of Valsalva ratio and slightly low, 1.7, our usual patient, 1,000 patient mean is 1.83, and also ST junction and slightly narrow. So calcium score is not much, and just 130, and the House per the unit. And the problem is coronary height is relatively low, 9.2 left coronary artery height. and the RCA is 16. And this patient decided to, and considering the PPM processes patient mismatch, we put the EVOLUT R26 and the 23% oversizing, and also patient is stabilized, the patient ending is good, and discharged well. Unfortunately, 6 months later, patient visit emergency room with acute chest pain, and as you can see, there is a significant ST elevation in the LAD part, and we tried to check coronary angio. Right coronary angio was easily and the annulated, but it's unfortunately we couldn't engage left coronary system. We tried to over 1 hour attempt and several times. The not easy process, and the final we decided to just the aortogram. As you can see, there is some thrombus region is the left distal main, and the LAD and the sarcoosteum is a filling defect. We suspected stent thrombosis. Finally, this patient is subsequently received the bypass surgery like this, and coronary artery disease and the rate complication, early complication is coronary is sometimes is quite common, not rare. So coronary artery disease and the access interval, why is it so important? As everybody knows, well, this is a well-known slide, aortic valve and the coronary artery, and the two diseases and the share common soil pathophysiology, and the aortic valve disease as having coronary artery disease is not the rare things, is very common, and the reported literature showed approximately 40% to 60% combined concomitant coronary artery disease. Absolutely, everybody recognizes even low-risk type of procedure that could be more important. In the next year, the CAG PCI are quite important. And many clinical study in the published important article, and the overall study showing this is very feasible. And the PCI after TAVR and the frequency is reported from 1% to 6%. However, recently, in the guideline recommended the younger patient is TAVR could be okay. So, and this rate is quite increase in the over time. So coronary access after TAVR, how to approach? We should recognize and the valve design as well as the patient anatomic characteristics. And if you put the EVOLUT system, is a wrapped panel, and if you put the right the SAPIEN 3 is a light panel, we should recognize what is valve feature and what are anatomical feature that is important. Then this slide is published. The JAG is a very well-known slide, and we in the inpatient part, and we consider anatomical factor and device and procedure. Also, we should recognize is the frame height and the overall the frame length that is be essential component to consider coronary access risk. And the especially if you put the EVOLUT system, the valve post covered coronary ostium, absolutely coronary engagement nearly impossible, and that is a well-known phenomenon. And also, and if you put the SAPIEN 3 and the implantation and the sinus of Valsalva is quite important, and compared to EVOLUT system, SAPIEN system is much easier. However, even in SAPIEN series, we recognize the implantation depth. Sinus of Valsalva is an important factor, and the factor to consider feasibility coronary re-access, and that is a well-known risk factor. The frame height, also SD. The junction facing frame and the native leaflet length and commissural alignment is well known the risk factor determinant for coronary re-access, and is compared to the SAPIEN system, EVOLUT system, unfavorable coronary access and the failed coronary re-access rate is quite high. Even as I mentioned, the valve frame covered coronary ostium is a posterior part is nearly engagement is nearly impossible. So, and over instance, coronary obstruction after TAVR procedure, and as everybody know well, usually coronary ostium is associated like some calcium chunk. Calcium chunk block the coronary ostium that could absolutely catastrophic. The phenomenon is that is the most important part. So, and the reported case and the well-known risk factor compared to native aortic valve coronary ostium, the obstruction reported less than 1%, 0.62. Valve-in-valve procedure is much higher, more than 3 and 4 times higher. Overall reported instance 2.48, and the self-expandable 0.34, and the balloon expandable is 0.81. That is procedure related, but now the valve-in-valve is much different result. So also we consider early coronary obstruction and late coronary obstruction. My first case showing the 6 months later, coronary flow was compromised. That is a delayed coronary obstruction. And the overall, although overall instance is not high, sometimes the patient presented a late coming coronary obstruction shown in the first case. So, and the problem is if coronary obstruction occur during or after TAVI procedure, that could be associated incredibly high incidence of a mortality rate. So, and how to treat if coronary obstruction occur during the TAVI procedure, and this is a well-known technique and easy to perform, and chimney technique that could be applicable and EVOLUT system as well as a SAPIEN system. And this is our case, and the provisional the chimney technique. We put the SAPIEN 3, and usually in our center, Assam Medical Center, we protect using NC non-compliant balloon. Another center put the stent itself. But however, if too much strongly kinking in coronary ostium, if you try to pull back the stent, that could be peeled out of stent itself. We have a very catastrophic experience. After then, we just default coronary protection strategy, just put the NC balloon and then pre-dilation and then put the stent. And this is our very typical example case of the coronary obstruction. So this case, NC balloon inflation, and then put the drug-eluting stent 4.018. But you know, some problem is just if you're gonna put the one stent, that could be a radial force is not strong, and sometimes collapse if you check the IVUS, and many cases require 2 stent overlap to guarantee sufficient and elastic recoil. And this is we put the additional DES 4.0 and the 2 stent overlap, and the single stent layer is upper panel, and the 2 stent overlap is the lower panel. And as you can see, IVUS, and we can more larger lumen area. So, and usually if calcium chunk was blocked the left main ostium, many cases 1 stent not enough, and at the time we put the 2 stent. So another important case, simultaneously TAVI and the left main chimney case, was a many center reported like this case. However, absolutely we should consider, and the chimney technique, there could be some compression of a stent by the TAVI valve, also high risk of stent thrombosis, and the need for lifelong depth, and the unfavorable coronary reaccess. That is still the inherent limitation of the chimney technique. I would like to share for the audience, this is a very high chimney technique. This is some rescue case, also very important delayed coronary obstruction case. And the 72 female, and risk factor diabetics and hypertension, put the 6 years RCS-10, the severe AS, STS score 3.9. So, and put the 4 years ago, and the right coronary arteries patents, left main is okay. We didn't see any left coronary artery system significant disease, just mild disease in the LAD. So, and looking at the anatomy, The short diameter is 17, long diameter is 23, and the perimeter is 63. And the interesting part is sinus of Valsalva is a relatively shallow 1.7. Our mean is 1.8, and the ST junction is 1.5. The calcium was not much, just 143, and the height is 11 and 15. Usually more than 10, we didn't do coronary protection. So might be some audience is remember this case. This case was done in the TCT-AP live case, first day live case demonstration by Jung and the Bapat group, and unfortunately device embolization after the deployment. So at this moment, and as a rescue therapy, we put the valve-in-valve procedure in the 2 overhead EVOLUT system 26, and the vital was stabilized. The patient was okay. And looking at the aortogram, we didn't see any significant abnormality. Its coronary flow looks relatively okay. So, but however, unfortunately, after 2 days, patient complained the chest pain, and there is some new developed ST depression in the LAD territory. Also, troponin was elevated. Patient complained the resting chest pain severe. So we tried the coronary angio. Right coronary artery is okay, but the problem left coronary the engagement is impossible. So we tried to the several attempts and put the caster, and we are forceful coronary angio, as you can see, using the guide Gila. As you can see, some coronary part, coronary sinus part is a sequestration. That is a very important factor. Some coronary obstruction. During the forceful injection, coronary the flow looks like okay. However, it is not physiologic. This is a forceful injection. That means it's coronary sinus sequestration, typical example case. At this moment, we measured coronary sinus pressure is quite low, relatively normal, the artery pressure, and we try to release the sinus sequestration and the chimney technique, and put the one stent Giant's 4.0, 30A, and but even high fresh balloon, the stent still some not fully implanted, and finally we decided to put the additional stent Giant's 4.023, and then we achieved well open the stent strut over here. So final angio looks like this, and the flow was much improved at this moment. We measured the additional sinus pressure, and the sinus pressure is going up from the 50 to the more than 100, and the ECG was normalized. The patient symptom was improved. I think that this is a very nice example sinus sequestration case. This is a post-PCI CT imaging and the serial echocardiography, and the immediate recover and the non-STEMI moment, and the ejection fraction is compromised. After chimney technique, 2 days after, ejection fraction was normalized. The patient pain was stabilized and discharged well. Now patient is okay. So sometimes after put the Sapien series, we try to the chimney, but in Sapien series and the chimney technique, we can overlap over here, and we can use top cell. If you re-engage the additional guiding caster, you can pass the top cell of the Sapien series and put the stent over here. There is a much the expanded the stent strut, and if the Sapien series was put and we try to the chimney technique, we usually re-engage in the upper cell and try to put the stent implantation over here. That is a very helpful to avoid then the valve frame and the stent itself interrogation. And this is our top cell chimney technique by Sapien 3, and just put the one stent, and the stent flame was expanded well. This is the top cell, some snorkeling technique, we try to slightly pull back to avoid too much stent hanging out. And this is the right is our usual practice if you put a Sapien 3. And absolutely prevention is better than cure. How to predict and prevention is there are many portion we should consider sinus of Valsalva and the coronary high, and also and the important part is ratio is also very, very important. And this patient is the diameter is enough. However, the sinus of Valsalva is a 2.0. If ratio was big, and usually, although coronary height is low, diameter is looks like a narrowed, sinus of ratio is okay, and the patient usually okay. And just to put this patient, even though 26 oversizing, and there is no obstruction of coronary access, and we should further consider sinus of Valsalva annulus ratio relationship. Also, we should consider leaflet length, and this case is coronary height is left coronary 15 and the right coronary 16 is quite high. But however, if you measure and the leaflet length is the leaflet length is quite long, so the leaflet length is much longer than coronary height. It can close the coronary ostium, and in this case, the length of left coronary cursive is 22, could be coronary artery obstruction. At this moment, we usually predilation protection for this case. So this is usual our practice, a rule of thumb, consider low coronary height, or sinus of Valsalva annulus ratio. Also, you should consider long native valve leaflet. And for some rescue case, sometimes we do the basilica, but however, basilica is published in some important journal. This is still very challenging, not easy to do in every type of center. We quite, the many experience to perform easily in basilica. So this is my last slide. Coronary access at the TAVR is not uncommon, especially in the era of a low-risk TAVR procedure. We should know valvular anatomy characteristics for coronary access of TAVR. CT absolutely can help to identify the feasibility of coronary reaccess. Rescue stenting like a chimney can manage coronary obstruction during TAVR procedure, and the CT-guided prediction. Prediction is much important rather than the treatment. Is help to prevent the coronary obstruction. Thank you for your attention.
Okay, thank you so much, Professor Park, for your excellent lecture. So the floor is now open for discussion.
Hello. Thank you, Professor Park, for the excellent sharing. We don't have much experience on post-TAVI PCI. Thank you very much for your lecture. We know more tips and tricks on how to handle this situation. We expect more TAVI patients in Hong Kong, and then we may encounter post-TAVI STEMI. So in this sort of situation, what is the first guidance you will choose when you encounter a STEMI with post-TAVI? I mean left side STEMI. So which guidance is the recommended guidance, or how to choose?
Okay, thank you. I think it's Lamho, and this is a very important question. Absolutely. Sometimes, for our experience after TAVR procedure, we experience delayed coronary obstruction presented sometimes non-STEMI and sometimes STEMI in the right coronary, and usually easily cannulated, but left coronary is very problematic. In the Sapien series, and everybody, more than 90 and 95%, we can easily access, but the problem is EVOLUT series in the self-expandable valve. Sometimes so much difficult. At that moment, we our first attempt to just try to the Jackin system. If failed, we try to the another amperage or multipurpose. Finally, all is failed, and we try to the guide Gila is like some Dorocaster, but even try them as shown in our first case. We use a 3 and 4 type guiding caster, even guide Gila. If finally failed, they we don't have no, no easy method at that time. We just aortogram, and then patient required urgent bypass surgery. We the communicated cardiac surgeon, and then immediately to bypass surgery.
Thank you, Professor Park. Dr. Lau.
Okay, I could use that. Hi, thank you, Dr. Park, and excellent presentation. Could you enlighten us that how would you ensure the rescue stent protrusion will be optimal? And in case if it becomes suboptimal, protrude too much, how will you tackle that? And in case you leave it there, and in future when there's you need to get access to it, what's the tips and tricks that you would like to share with us?
Is it said again? I didn't recognize your question.
Okay. YK Lau, my question is, in the rescue stenting after TAVI, and how would you ensure the optimal standing position?
Okay.
And then in case if it protrudes too much, and what's the tip and trick to tackle it subsequently?
Absolutely. Yeah, that is a very important question. For TAVI case, patient usually the blood pressure is going down, and most of interventional cardiologists are very anxious about that. So usually, and we try to the chimney technique. Sometimes to put the much stronger stent is having the big rider first. For instance, Giant's stent is good rather than the Boston Scientific, more the Sinstra stent. It's a 6. I recommended the 610. Also, even though you wanna put the 610, owing to the interrogation, the valve frame and stent itself, radial pulse many times not maintained. At the time, as shown in my case, we tried to recommend the additional stent. It's a 2 stent overlap. It's much better to guarantee achieve the enough lumen area. Is a key point. I recommended 100% IVUS. If you check it up the IVUS, you can make sure lumen is sufficient. It's not sufficient. So first I recommend the secure stent, and for instance Megatron, the Promus Megatron is good. The second one is IVUS final evaluation is essential stent.
Professor Park, can I ask one question? So you have demonstrated an excellent case of this amazing coronary sinus sequestration. So any thought about doing open heart surgery at that time?
Yeah, so initial time is we are experienced coronary sequestration case in the 4 and 5 case. At first time we didn't recognize what is if you're gonna do forceful angiogram, looks okay, but for sinus sequestration case, a typical example usually occur patient having narrow sinus. But if you're gonna do forceful aortogram, hemodynamically, is a figure, it looks okay, but that is not physiological. So that is reported in Cedars-Sinai large macro case. They reported consecutive training case in JAG intervention. So as shown in our case, and the coronary forceful aortogram looks okay, you should suspect it if patient having narrow sinus, blood pressure is less than 10, looks like cardiogenic shock, there was no explainable factor, absolutely you should consider coronary sinus sequestration. If coronary sinus sequestration, if you relieve the pressure using put the stent, like our long stenting, is usually blood pressure is going up. If that finally failed, absolutely we should consult bypass surgery.
So thank you, Professor Park. Your
talk. So one more follow-up question on coronary access is you share some of your experience in assessing with one valve. So how about those patients with valve implants in place? So is there any tips and tricks in future assessment for the coronary access?
Yes, coronary access absolutely not easy question, and now still a lot of data are published and reported by different interventional cardiologists. I think the initially, and if you put the EVOLUT system, and there are many guidance, we try to match the direction, and the hand marker is outside. Also, now there are some technical, the consultation technical point we should consult during the implantation. Also, if calcium chunk is big, if you're gonna put the Sapien series in our catheter, we try the more deep implantation. Now is some booming of a shallow implantation. It's okay. It is much prevent permanent pacemaker insertion, but that is some opposite side of coronary protection we should consider in both parts. So, and the first, we should keep the current updated guidance to implantation technique. If coronary reaccess is always not easy. So, and I think the experience is much important. Even we tried 1 hour, 2 hour, some case finally fail. It's like this coronary reaccess is not easy things, and I think experience is much important, yes, than some literature.
I have a follow-up question concerning left main stenting and chimney technique. Because have you encountered any very short left main in which you have to put a stent in the chimney technique, and then obviously you have no landing zone, and then you have the size and length estimation is very difficult. Is that have you had that kind of experience?
Yeah, absolutely. In the usually, and we are try to, and the 23 and the 28 is 3.5 or 4.0 is okay. We usually should cross over to the proximity and left main, and some hanging out. And if you put the Sapien 3, and if you re-engage the top cell in another guidance catheter and put the small protrusion, 2 or 3 millimeter, the left main stenting is okay. But however, if you EVOLUT system, if you want to do chimney technique, we usually put the very long stenting in the 32, sometimes the 38. And then it sometimes do is a final kissing balloon dilation. After that, and we check it up the final IVUS, and the lumen is sufficient. There was a recollapse of the recoil of the stent. If is absent, we just finish. Yes.
So, Dr. Pranath, so could I ask you for your opinion on your experience in doing PCI in TAVI? I mean, in TAVI patient in Thailand. So, can you comment that? Dr. Pranath?
Oh, yes, I'm here. Can you hear me?
Yes, yes.
Hello? Yes. Okay.
Hello.
So actually, I apologize that I don't have more experience for the PCI in post-TAVR patient as well, because we in Thailand we just did not many cases of the TAVR, but I believe in the future, in the very near future, the patients with acute coronary syndrome after TAVR the number is increasing, and I just don't want to say I've been waiting for it because it's not good for patient, but for Dr. Park's lecture, I think it's very informative, and I just would like to raise some questions. That it sounds like if the patient if we are truly unable to access the coronary, so there will be, sounds like there will be only 2 ways for the patients to end up. Number 1 is the conservative treatment. Number 2 is undergoing bypass surgery. Dr. Park, do you think will there be any innovation that can help us with the access the coronary in patients who is very difficult to or look like unable to?
Yeah, absolutely. Finally failed any re-engagement. And first we try to the medical therapy first, but usually patient if the patient do not tolerate and the patient blood pressure, cardiogenic shock, and continuous chest pain, we don't have another option. We directly refer to bypass surgery. Yeah.
Sorry to interrupt, but time is running short. So may I introduce our next speaker? Professor Stephen von Bardeleben is the head of the Center of Structural Heart Disease and Interventions and the Heart Valve Center, and the head of cardiovascular imaging in Mainz, Germany. He's an imaging, interventional, and also heart failure specialist. He is experienced and participated in many early in-man implantations of different structural heart devices like mitral clips, cardioband, Pascal, NeoCord, etc. He's the co-author of the first European position paper on heart failure on secondary mitral regurgitations. And he's also the chief director of journal Echocardiography and reviewer for JACC Intervention, Circulation, and other famous journals. He's a board member of Heart Valve Council of the European Society of Cardiology, Heart Valve Society, ESC Heart Failure Association, and he's an experienced interventionist also in this field. So yes, Professor von Bardeleben, please.
Thank you very much for the kind invitation on day 2 of Hong Kong Valves. It's my great pleasure to point the attention now from TAVR to the mitral space, and I will talk and give you a life-in-the-box case of a tendyne implantation, and I have some slides of the ongoing data afterwards if we need it for discussion. So without further ado, I would like to continue. And these are my conflicts of interest. So the goals for a successful mitral procedures are to achieve an MR grade 1 or 0. This is surgical-like. It can now be achieved in about 90% in TEER patients, but there are pathologies that I will point out later, like MAC, like very short posterior leaflets, where you cannot achieve this. The mean gradient should be below 5 millimeters mercury, and there are 2 profiles of the tendyne valve to achieve this. One is using a 28 millimeter valve inside, which is the standard profile, and then there is a second, which is the low profile, which is for narrow anatomies, starting at approximately 2.6 centimeters, and this is very well suited in MAC, and I'll show an example there too. So, of course, the low LA mean pressure means that we get positive cardiac remodeling, and we want to have mitral valve area that is well above 1.5 centimeters square. So in these valves, we achieved more than 2 centimeters square, and we need durable results. At the end, we also need high survival rates and low risks, which will be achieved in the further iterations as we move from transapical, where the tendyne is located nowadays, to further valve systems like the Intrepid and the Sophia valve system that will be applied transeptally and transvenous. And we've already seen and shown that this further reduces especially short-term mortality at 30 days and 3 months by more than 50%. So just a comparison of transcatheter mitral repair on the left-hand side, which shows a high procedural safety. Mortality ranges in Europe and in the US are now in the range of 1 to 1.5% only. MR reduction is very anatomy dependent in repair and not always predictable. There is an interaction with the native anatomy. We have the advantage that we don't need almost any anticoagulation. So in sinus rhythm, you can use aspirin alone in TEER patients, whereas in the transcatheter mitral replacements, you have a risk of valve and valve leaflet thrombosis, as the sealing skirts and the double stent design actually evokes thrombogenicity between those 2 layers. There may be a risk of MR recurrence. We have to see how durable the transcatheter mitral valve replacement results will be, but there is data and patients out from London and also from our side that have up to 8 years of Tendyne experience in patients in human implants that were still durable. So here I would start, as indicated in the program, with a live in the box case from Mainz, together with our surgeon Henrik Trede. And it's my great pleasure to show you this about 10-minute video, and then we would go further into some discussion slides and then into the discussion. Sorry, I have to go back once. This should actually start. So this is the preparation where you see the poke test with the finger. So it's very important to have a lateral. We just work with the soft tissue retractable rib scanning. So these are Teflon arm patches. Now you see the Tendyne valve, which is put in water. You nicely see the stent frame. There is a central tether that goes to the apex. This is the loading system and the deployment system. This is the funnel where the valve is now pulled into the system. The valve is flushed, and now you pull on the tether, and it gets into the connectable system. So you see these are large bore devices. The French size is around 42 French in the end, but it's transapical. This is the securance of the safety wire, where we hold the valve later in place.
Hello, Professor. So I think we are not very familiar with the Tendyne valve. Could you introduce us or guide us through?
Yes, I can. I put this down. Just a second. I go back and I can guide you through a little bit more. Let me see. I have to go to this position again. We loaded the valve. I'll explain this. I'll put down the sound. So there will be other explanatory videos after, but in the program was, of course, the situation of the valve system. So you see the setup. It's a transapical access. The Tendyne valve is the valve with the highest human experience. We currently exceed 1,200 human implants. The valve is CE mark since approximately 2.5 years in Europe, and there have been more than 800 commercial implants now, and we will have a late breaker on this at PCR London Valve. So you see the setup. Their free hemodynamic controls will now go into the procedure. You've seen the access, which is done by CT evaluation first, and we will go here into the implant situation now. So the patient is now being presented. It's a 76-year-old male presenting with progressive shortness of breath. He has a known coronary artery disease, multiple PCIs with congestive heart failure, severe MR of mixed etiology. So there's an underlying leaflet tethering, new onset flail. So it's a complex interaction that will cause actually replacement to be one of the strategic options in this patient. Ischemic cardiomyopathy. So the valve is indicated with an ejection fraction of above 30%. He had an infralateral myocardial infarction, typical risk profile, as you see, anemia, hemorrhagic cystitis, additionally, atrial hypertension, hyperlipidemia, diabetes. Here you see the situation. So it's a 40% ejection fraction. You see that the posterior valve is destroyed, as you see in the lower left. You see there's a posterior prolapse, but the underlying disease was functional disease, and secondarily his chordae ruptured too. So it's mixed etiology. Here you see the CT analysis. We look for the outflow tract. You see that the three-mentio system predicts a vector of the valve implanted, and you see there is enough space in the outflow tract. Extremely high operative risk. STS and Euroscore 2 is 18.7. So above 6 to 8 is almost inoperable. LAD without a decent target for a bypass situation, very high pre and post capillary situation. The SPAP was estimated to be pulmonary hypertension with 75 millimeters mercury. TIA was not possible because of the MAC component at the posterior prolapse and the rupture. So the heart team decision was to do first a PCI of LAD and the circumflex artery, and then, as we see it now, a TMVR with the Tendyne valve. Here is the coronary angiogram. As you can see, the circumflex before and after intervention, and also the LAD. Neo-LVOT is quite favorable. We need 200 to 250 millimeters. There are 530 here, so very favorable anatomic situation. And after this Rementio pre-planning, we go now into the implant, which you will see is pretty fast. The first thing is to have a soft tissue retractor, typically in the 5th or 6th intercostal space. We then do a finger poke test in order to go to a perfectly symmetric intercostal in an IC position, so medial lateral, and also a very posterior position. This is important with the tether to pull away the Tendyne valve from the outflow tract. So it's important always to be posterior in a 3-chamber view with the access, and the access predicts also the way we do the implant situation. So this is the discussion in the heart team with Hendrik Treder. I shortened this slightly. We discussed this patient, and now we go to here you see the anatomy, anterior and posterior sclerosis and calcium. You see a destroyed posterior leaflet, large PISA zone. The arrow A in this case was 0.65. So really much more than we normally see. You see the quite distension here, especially of the lateral papillary muscle, which is outside. There's an infarction zone at the base, as you see posterior in the circumflex territory. Septal contraction still good. There is some apical wall motion abnormality with the LAD situation. Now we have the 2 Perseus strings where we can pull the heart. So they're connected to this U-shaped sutures that will help us to immediately close the access situation. Now we puncture the apex, normal needle, like in a transfemoral TAVR. We input a wire and transit the valve symmetrically between the papillary muscles. This is 3D true view that we use in our hybrid OR, and you can nicely see the normal J wire going into the right pulmonary veins. We then take a balloon and flush through that we're not entangled in the cords. You see it moves nicely between the papillary muscles on the left lower. You see that to the apex and back. And if this transition zone is maintained, we switch to a large bore sheath to implant the 10-line valve. Now the balloon, it's normal Fogarty balloon, is put out. The valve is connected to the implant system, and we have a dilator that is inflatable. So the whole system there can be removed, and the dilator can be unfolded by simply putting out the water. This is the secure pin that's put to the end, and we can then control the power to pull, which is in the range of 1 to 2 to 3 kilograms that we put on the apex in order to have no rocking of the valve and no paravalvular leak. Actually, we've implanted in mine so far 26 10-line valves, and we have no single paravalvular leak. All have an MR0, all 26 patients. So here you can see that we put out the wire. We use the normal J wire to get into the system. You see that the J wire goes out of the heart shadow in the right pulmonary veins. We now are in the atrium. It's very fast. The whole procedure only takes 20 minutes. This is now minute 11. And you can see now that Henrik, as heart surgeon, holds the sheath and aligns the sheath, and I will implant the valve. That's the typical heart team situation. It's a collaboration between heart surgery and cardiology, as you see. So the ribs give enough space, and you see the angle is also predefined by CT analysis. You see a 45-degree angle up, and also the posterior angle depends on the situation of the heart. We have a REO, a slight cranial rotation to be perpendicular in the fluoroscopy system. Here you see REO 9 and cranial is only 2, which gives us, now I unflush the dilator. You see there, I return fluid out, and we will remove the dilator and then continue with the valve implantation. You see it's side port only. Now there are 2 dials, 2 rotational knobs that you see here. And I'm controlling first the upper knob 1, which is at the end of the catheter. You see there's also a right heart catheter to control the hemodynamics. Very important during the procedure is to give not too much inotropes, but to give volume. The patient switches immediately from an MR3+ into an MR0. So the preloading of the ventricle is very important during the implant procedure. I now turn the valve. The first knob, as you see at the end, is turned by me, and we bring the valve forward. You will see this in the fluoro image and also in the echo image, where we can look into the sheath. The sheath position has to maintain a normal movement of the anterior mitral valve. This is very important. Now the valve comes out. You see it in fluoro on the right-hand side. And then we rotate the system that the 2 ears of the system come towards the trigones of the native anatomy. So the valve is D-shaped. So we have the D actually towards the outflow tract. Here you see we're turning the 3D volume, and the valve is deployed in echocardiography mainly. You see that we turn the aorta up. It's a surgical view now. Now I deploy the valve with the second knob with my left hand. We can still correct the position. We pull the valve back into an intraannular position. You see the large flange on the right echo image side, which goes to the LVOT in the aorta. And now we simply expand the valve slowly. I do this only with my left hand. You see slight movements. And the same way, Henrik Trede is pulling back the valve intraannular. You see, we're now there. There's always hemodynamic stability. Now I'm fast, and now the valve is functioning. This is without rapid pacing. It just takes 2 seconds. It's very fast. The valve you see is outside the sheath. It's fully functioning. but can still be retrieved and repositioned if needed. Already there is no paravalvular leak. We see a perfect valve functioning, and we see that now we pull the valve on the string. This is the positioner here. So this controls actually the pressure of the pad against the valve. I'm still holding the valve with the wire, and now we are connecting the pad, and the pad will take the pulling power of my hand towards the pad, which will also seal the entry into the ventricle with 2 sutures, 2 U-string sutures. Now it's a very controlled situation, and we have the yellow line, which gives us the pressure line. Typically, we want to have this 1.5 over the dynamic pressure. So you see the tensioning is 200 millimeters mercury. And we now check the posterior side that the valve seal works perfectly at the hinge points of the native valve. And you see there's no PVL. We control this in color Doppler on both sides. You see there's no gradient. Gradient is 1 to 2. Here there's sinus rhythm, so very perfect result. And you see no Doppler CV signal going back, no regurgitation whatsoever. So very much echo-driven procedure. Now the mean gradient is defined, and you see that the mean gradient is very low. It is actually, in this case, between 1 and 2. Now a Doppler is done across the valve again. And you see biplane that this looks excellent as a result. You can appreciate this in the echo image, which you see to your upper right side. A hemodynamic is given with LV. We have a pigtail in the ventricle, a sheath for the arterial pressure, a pressure of the device. And now the pad is being locked, pulled down. I hold it on the black, and the system is then released, and the whole pressure is taken by the pad. And this is like a tongue that you put out, a crimping situation. We open it. Here you see I'm holding, and we remove it. Still at this moment, we could still retrieve the valve with a retrieval system if needed, but we have excellent results. You see the PA pressure drop from 70 to 50 millimeters mercury. We have normal arterial pressure, 116/53, 100% saturation, sinus rhythm, 55 beats per minute. So this looks really excellent. We now go to the workup of this patient. I go a little bit forward. So you see we're evaluating the patient, close the access. So here you see it, soft tissue retractor removed. Here you see 3-dimensional true view with artificial light. You can easily see the new bioprosthesis, works very well. You see the nice sealing of the tendine valve, and there is no PVL laminar flow through this standard profile prosthesis, which is 28 millimeters. And this concludes the whole implantation, and I think has been a very nice implant technique. Some discussion is ongoing. Again, just to have a look at the echo, perfect opening and closure of the valve, no PVL, D-shaped situation of the outer stent. And here in color, you see no PVL across the whole annulus, central opening and closing, very soft leaflets with high pliability, and also in the biplane image, I think a perfect result. And here the mean gradient is 2 millimeters mercury for the whole valve. So this concludes, I think, this implant demonstration, and I would just move on with just some explanatory sides. So here a patient with severe MR, patients with partial calcium, which are perfectly suited. You see the spider web indentations of calcium at 12 o'clock and at 2 o'clock. So we will do pre-dilatation in those. There's the Guerrera score. There are 2 publications by Paul Saraja from Minneapolis. No strokes in a series of patients, high procedural success. And this is far better than using TAVR valves in MAC for these patients because the stability is much better. Here you can see the aspect that you've already seen, no regurgitation, perfect sealing. Criteria favoring replacement primary MR is commissural jets, MAC, short posterior leaflet, multiple jets, Barlow's disease, clefts. On the right-hand side, some arguments also for a possible replacement, still having a good ejection fraction above 30%. The red paper by Scott Lim that you know with straightforward but also prohibitive tear anatomy, which will speak for the Intrepid program and the Tendyne program. Here are just some examples. Patients with severe secondary MR, you see the leaflet tethering of the posterior leaflet, and also here you can implant easily a device, planning by through Mentio and CT. And just some data, the Tendyne mitral valve was presented with 2-year follow-up by David Muller from Australia. You see a technical success of 96%, re-interventions only 1%, 6% 30-day mortality, and complete obliteration of MR regurgitation with about 99% of MR zero. New York Heart Association class is positively influenced. KCCQ increased by 21 points. And you see that hospitalization rates go down by more than 50%. And that's also something we see in tricuspid repair. Just two outlooks. Here, a paper that I seniored, which is the first 100 commercial patients. And we've now collected 265, which will be presented at London Valves in November this year. And you see some additional off-label use, which is a annuloplasty before in A. In B, you see the combination of a TAVR, a Tendyne valve implantation after MitraClip that you see here with the red arrow, and also valve in MAC for these patients. And I think this is very successful. The Summit trial is ongoing, having a single-arm MAC cohort, a non-repairable cohort, and a randomized cohort. It has included more than 100 patients. You see how the deployment is done. You've seen this in the live case video with TrueView possibilities, heavily echo-guided procedure. You can also maximize, like we heard in the Basilica maneuver with the lampoon technique, the outflow tract. We did this with sutures. We're now electrosurgically cutting into the interior leaflet if the outflow tract is narrow. And you see very nice results also in Portico and Tendyne for severe AS and severe mitral regurgitation in those patients. So my sum up is TMVR is able to address both primary and secondary MR. TEER is an extremely safe and low risk comparator. TMVR eliminates MR. It's still a little bit invasive procedure because of the thoracotomy. The cut is only 3 centimeters. But transapical is available now. Transfemoral is to come. And with this information, I would go into the discussion. I thank you very much for your kind attention. I hope that these live case was visual and important for your experience. Thank you very much.
Thank you a lot, Professor Stephen, for your excellent detailed explanation of the Tendyne valve. But I think the Tendyne valve is still not yet available in many areas. So actually, could I ask Professor Siu, so with now the excellent availability of many different kind of medication for heart failure, sometimes we see many patients after optimal medical therapy, actually the mitral valve regurgitation reduces with time. So when would you consider really appropriate selection criteria for referring a patient to undergo any kind of mitral valve intervention?
Okay, for me, most of the time when we started on medication, I would take something like 2 or 3 months, okay, to see the clinical response. And after that, we would like if for patient with severe MR, if there's no significant clinical improvement, I think that's maybe a time frame. And I would like to ask Professor for the mitral valve replacement procedure. I realize that the procedure is sitting in the mitral annulus. Is there any concern about the potential implication on the coronary blood flow because of the valve placement?
No, there is no issue for the circumflex artery in this, unlike with annuloplasty. Because it's a passive movement down to or towards the hinge point of the annulus. And all this can be well controlled because we can control the impingement and also the dynamic power with which we pull from the apex. So there's no involvement in the circumflex artery. There may be a slight impingement of the coronary sinus, but this will never close the coronary sinus. You've seen that the seating of the valve is very intra-annular, and there is no involvement with the coronary artery whatsoever. So there's no suture. It's only a passive pull. And the valve has not a high radial component because it's just using the atrial seal versus an apical tether. So this is quite favorable for both MAC patients, but also coronary patients. It's easy to reaccess the coronaries. It's unlike the Carillion system. There is no issue in circumflex access or circumflex closure in more than 1,200 patients. So I think that's not an issue in this case.
Okay, and Professor Kim, so I know that you are an expert in mitral clip. So what do you think about this different modality, like this TMVR?
Thanks for your question. And I think TMVR is now available in Korea. We did several cases of valve-in-valve case, but not yet available in Korea. But I think TMVR is also another very important option because there are lots of some patients who are not candidate for the TEER procedure. So one question is, you already recommended TMVR for the primary and secondary MR, but I think I fully agree with your opinion for the primary MR. For secondary MR, especially atrial MR or other MR is due to the annular dilatation. So in this situation, I think it's possible to apply this kinds of strategy with the TMVR.
Absolutely. The results are very durable. I think we also see a learning curve. So the mean number of procedures in the more than 35 centers here in Europe has increased. In our first publication, the mean implant experience was 3 procedures. Now it's above 6 procedures, and we already see that this influences outcome. The highest volume centers do between 20 to 30 implants, and for us, it's about 10% of the mitral valve program. 90% still is TEER. But for MAC and for, as you said, for certain anatomies, and the number of primary MR is increasing. We still have some limitations. So the smallest situation AP that we can treat is approximately 26 millimeters. The highest is in the range of 40 millimeters, and intercommissurally somewhere around 46, 48 millimeters. We cannot treat larger annuli so far because we would need larger valves. There is a number of 12, 14 different valve sizes, but it does not cover every patient yet. So there will be still some more valve designs and sizes needed in the future. But I think it's an important extension of the toolbox. And I'm sure that also this 10-9 valve with its future iterations, and you've seen it's a fast 20 to 30 minute implantation, will come to Asia. And I think it will contribute to the possibility to treat more patients beating heart, no heart-lung machine, no cardiopulmonary bypass, simply beating heart in half an hour with intubation. I think that's a key for success and for patient safety. But currently, these 10-9 valve implantations still involve a sicker population than TEER. So we have to read the 30-day mortality is 6 to 11%, still with caution because it's a negative bailout situation. And we know that MAC patients do very badly also with surgery. They have 16% 30-day mortality. So we always should keep this in mind, that TEER is safe, but it cannot treat all patients.
Thank you. So I think Dr. Lau have some comment. Dr. Lau?
Hi, Stephen. Thanks for showing us a very neat procedure with encouraging results while waiting for longer term of durability data. And as you mentioned, that the 30-day mortality is quite high. What's the worst portion? Is it because of sick population, or is there anything that we could learn from the initial experience, how to reduce the high initial 1-month mortality?
Yeah, I think this is a very sick population. On the other hand, of course, there's risk of infection and other things because of the large bore access. We treat this with approximately a 3 centimeter access in a hybrid OR, which is of course different to TEER procedures where we have an 8 millimeter access via a vessel. This is always safer, less bleeding situations, less others. We don't have to anticoagulate them as aggressively as the valve design in a replacement. So I think it's a combination of much less procedures, so 1,200 versus 160,000 TEER procedures worldwide is of course a huge difference and a huge gap. We see also that the next generation of valves will go transvenous, transseptal. So the Intrepid Apollo program is coming to Europe at the first quarter of 23. The Sophia program will roll out from Abbott next year, which will go next to the Tendyne program. But the highest experience of any transcatheter mitral valve replacement is Tendyne so far. So we should acknowledge this. More than 1,200 patients, works very well. If the patients survive, if they're not too sick, and we learned we should not do 20% ejection fraction, we should not do narrow LVOT, then we have a screen fail rate also of about 50% in those procedures. We have to recognize all these points, and this means further iterations, next generations, and center experience is key.
Thank you so much for your excellent discussion. And in the hurry of time, and also especially thank you, Professor von Badelepen, for your excellent lecture. And I know that you are in a very rushed schedule, so thank you so much. So let's move on. We will have two distinguished lectures from our guests, and I'm going to introduce our next two speakers, distinguished speakers. And the first one will be Dr. Takashi Matsumoto. He is a chief physician of the Department of Cardiology and Catheterization Laboratory at Shonan Kamakura General Hospital, Japan. He received fellowship training in cardiovascular medicine and interventional cardiology in Sendai Kosei Hospital, and he's a visiting scientist in the Cedars-Sinai Medical Center. He's an expert and have many researches on mitral valve transcatheter intervention. And actually, he visits abroad and also Japan in many centers to do many multiple mitral valve operations and published numerous research articles in peer-reviewed journals and textbooks. His experience in mitral clip, ASD, VSD, and PCI. And the next speaker would be Professor Minoru Tabata, who is a cardiothoracic surgeon, professor and chairman of the Department of Cardiovascular Surgery in Juntendo University. He is also the executive chair of the Department of Cardiovascular Surgery in Toranomou Hospital. He received his undergrad degree at the University of Tokyo, and he went on to complete his cardiac surgery fellowship at Brigham and Women's Hospital and further fellowship at Harvard School of Public Health and OLV Clinic. He is a clinical instructor at the Division of Cardiovascular Surgery, Columbia University College of Physicians, and he obtained his PhD in the University of Tokyo. His clinical and research interests lie on mitral valve, aortic, complex, reoperative cardiac surgery, TAVI, and large database research and outcome researches. He has published numerous publications and is frequently invited as a speaker in multiple international conferences. So first, let's welcome Dr. Matsumoto to deliver his lecture on functional mitral regurgitation. Dr. Matsumoto, please.
Okay, thank you very much. It's my honor to be here and present this presentation. I'm Takashi Matsumoto from Shonan Kamakura General Hospital. My topic is focused on functional mitral regurgitation, mitral clip G4, my master case series. So this slide shows history of mitral clip. The first in human, since first in human in 2003, it's already passed about 20 years. And in 2020, mitral clip G4 became available in Japan. You know, this system has 4 types of clip, NT, it's standard grip, NTW, it's wide grip, XT is long grip, XCW is long and wide grip. This system provide tailor-made mitral valve therapy, and also we can control gripper independently, so we can grasp each leaflet one by one. So this system allows us to challenge very complex situations, but we still face very difficult situation because of anatomy of mitral valve and poor image of quality. So today I will show 3 cases of my G4 system and 1 additional case. So the first one is 68 years old man. He presented with shortness of breath, NYHA functional class 3. He has a history of sustained VT, the ICD implantation, and in 2020, MR was detected, and he had 2 times of catheter ablation for AFib. And this year he developed heart failure and hospitalized. His STS is 3.0%, and this is baseline transthoracic echo. LV DDDS was 81.71 millimeter, and the ejection fraction of LV was 20.5%. EROA of mitral regurgitation is 0.6 centimeter square, so it's severe for sure. But when we checked TE, as you can see this on this slide, the image of TE is so poor. We cannot see enough. We cannot visualize space in LA, and also hard to see a posterior leaflet. In that situation, we always check gastric view. The right side is gastric view of short axis of mitral valve. Here we can see a coarctation line from up to bottom. Then we can create, in that case, we can create a bicommissure view from this using explain mode from this gastric view. This is a baseline. This is a procedure TE. Here we created a bicommissure view from gastric short axis view. Then we check trajectory in this view, and also we check arm orientation and location in this short axis view. Some previous study reported ICE during mitral grip. It's effective, but personally I think 2D ICE, I tried several cases, but 2D ICE is very difficult to control. So we should wait for 3D ICE. So this is a summary of case 1. So when the quality of bicommissure, standard bicommissure and the LVOT view is poor, gastric view is very useful. This case, when the coarctation line is up to bottom, we can create a bicommissure view from gastric view. And if the coarctation line is left to right, to this like this echo images, then we can create LVOT view from gastric view. And the 2D ICE is technically difficult to gain optimal view for mitral grip, so we should wait for 3D ICE. Maybe it will be approved in Japan next year. The second case, he is 75 years old. He developed acute heart failure and admitted to our hospital. New York NYHA functional class is 4. And he had a history of OMI and multiple PCI in CKD, DM, hypertension, and hyperlipidemia. He had no surgical history. This is baseline transthoracic echo. EROA of mitral regurgitation is 0.28. So severity of MR was moderate or moderate to severe. So at this moment, we decided to manage this patient with medication first. But this patient developed urinary tract infection and sepsis, so charged doctor started noradrenaline. But after that, the butamine could not be stopped. So at 14 days after admission, we checked transthoracic echo again. Then it showed a severe MR, and both leaflet looks like not touching each other. This is baseline TE. In LVOT view here, there's a large gap between anterior and posterior leaflet. It's 7.3 millimeter. So at this moment, we thought to manage this patient with only medication, it's very difficult. So we considered mitral clip, but it also has risk of tear of leaflet. So first we inserted IAPP to make leaflet coaptation better. Then, this is wedge pressure and PA pressure pre and post IAPP. Post pressure improved, and on transthoracic echo, severity of MR became mild, and both leaflets touching each other. So we performed mitral clip for this patient. This is a procedure TE. Here, still there was gap in targeted region, but got better. So we grasped these leaflet using independent grasping, and after one clip deployment, severity of MR became just mild or moderate. This is summary of case 2. Of course, independent grasping is very useful to grasp difficult situation, but it also has risk of tears. So if possible, we should make leaflet coaptation better using a high PEEP or nitro, which decrease venous return, or IAPP, which decrease LV after load. And also, guideline recommend GDMT before mitral clip. But right this case, sometimes we don't have time for medication. So of course, heart team discussion is very important. But in that case, I think mitral clip may be considered before a GDMT. Then this is third case. This is short presentation. This is baseline TE. It looks like strange. Two valves are opening into a single ventricle. This patient is a 44-year-old man with double inlet LV, TGA, pulmonary atresia, and AST and PDA. So this is adult congenital heart disease patient. This patient, of course, had multiple open heart surgery when he was a child, but after that, his clinical course was very stable. But recent 2 years, he developed heart failure symptom because of this severe tricuspid regurgitation. But of course, his surgical risk is very high. So this patient referred to our hospital for transcatheter therapy. We used mitral G4 XTW for this tricuspid valve. Then grasping was very easy, and after one clip deployment, severity of TR became just trivial or mild. This is baseline and 1 month follow-up transthoracic echo. It shows just mild or trivial tricuspid regurgitation. This is summary of case 3. In Japan, number of patients with adult congenital heart disease is increasing. Most of those patients have a history of multiple open heart surgery and high risk for open heart surgery. So I think in this subset of patients, catheter intervention is important and a strong treatment option, and mitral clip G4 and triclip play important role in this subset of patients. This, and also let me show one more interesting case. This, you can see both leaflets are not touching each other. Same as our second case. First I started a medication, then looks like both leaflets are touching, but I didn't perform mitral clip for this patient because this is 12 years toy poodle, my dog. She developed acute heart failure this year, but got better just with optimal medical therapy. Thank you very much. This is final slide.
Thank you so much, Dr. Mashimoto. In view of time, so let's move on to the next lecture on degenerative mitral regurgitation by Professor Tabata.
Sure. Can you hear me now?
Yes, very clearly.
Oh, okay. But somehow my video is not working well. Let me try again. Can you see my slides?
Yes, we can see it.
Okay. All right, let me try to turn on my video, but it doesn't work. Oh, now it's working. Okay.
Right.
Oh, thank you for your kind introduction, Dr. Wong. I wish I could visit Hong Kong this time, but hopefully I'll be there next year. Here is my COI. Well, first of all, I want to look over the advantage and drawbacks of minimally invasive cardiac surgery. These findings are from risk-adjusted observational studies. There have been only a few randomized control studies in this field, and they have only very small sample size. So the advantages of MIGS include a faster discharge and faster return to work, and less bleeding and less transfusion and no sternal complications compared to the conventional heart surgery. But it also associated with longer cardiopulmonary bypass time and aortic cross-clamping time. And it also has a risk of peripheral cannulation related complications, which does not exist in conventional heart surgery. So patient selection is very important for minimally invasive surgery, and it has to be done by mixed experts. Otherwise, operating time takes too long and the quality of repair might be impaired. So this is our routine standard approach for mitral valve surgery, which is a non-robotic total endoscopic approach. In this approach, we make a 3 to 4 centimeter incision, usually in the fourth intercostal space, and we make a couple of 5 millimeter holes for camera ports and left-hand instrument holes like this, ports like this. And there is no rib spreader used, so it causes much less pain after surgery compared to conventional or direct vision mix in which rib spreader is used. So it's definitely less invasive than conventional heart surgery, but since this main incision is too small, we cannot look into the chest directly. But the endoscopy provides excellent visualization like this, so we can look at the screen instead of look into the chest. So this approach is less costly and simpler than robotic approach. So there is a couple of advantages of surgical treatment over transcatheter approach. One of those is that we have a variety of techniques and we can combine them in one surgery. Here is a list of procedures we do have in our toolbox. The ring annuloplasty is a very common procedure. We do this procedure in almost all DML cases. And we also we have rigid ring, flexible ring, and full ring and partial band, and many kinds of rings. And we also resect the leaflet when the leaflet is redundant or sclerotic in any shape, like a triangular, quadrangular, butterfly, or whatever. And of course, we can suture them back together. Artificial caudal placement, caudal transfer are useful procedure for elongated or ruptured caudae. We can fold the leaflet instead of the resection. And we can do edge-to-edge or indentation closure. When the leaflet is very small, we can increase the size of leaflet with a leaflet augmentation or neo-leaflet creation with autologous pericardium. So this is a wide range of anterior leaflet prolapse. You can see two major caudal disruptions. In this case, I placed the two pairs of neocord on the anterior papillary muscle and one on the posterior papillary muscle. Now I connect these neocord to the A1 and the A2 segments, which was prolapsing. And with 3 pairs of neocord and ring annuloplasty, the valve has been nicely repaired. And next case is a Barlow disease. You can see the very excessive leaflet tissue. I think a standard approach for Barlow disease is a leaflet resection, but there are other options like this procedure. I have chosen to use a non-resectional folding technique using a neocode, multiple neocode. I'm just attaching the neocode to the mid portion of the posterior leaflet instead of the tip of the leaflet. With this technique, neocodal threads can prevent the SAM by blocking the posterior leaflet from moving forward. So you see the coaptation line is situated posteriorly, despite I didn't cut the leaflet. And there's no SAM on preoperative echo. And the ink test shows a large coaptation surface. So uninked area is coaptation surface. This deep coaptation is known to be related with durability. And this is another anterior leaflet prolapse. The medial half of anterior leaflet is sclerotic and prolapsing due to elongated coda. And importantly, the opposite side of the leaflet P3 segment is very small. This kind of unbalanced valve is very difficult to repair. To reduce the size of anterior leaflet, I'm resecting the anterior leaflet in a triangular shape and sew them back together. And I also put 2 pairs of neocode on the anterior leaflet. For the very short posterior leaflet, I created the neo leaflet using autologous pericardium, while the ventricular side of this pericardial leaflet is attached to the posterior papillary muscle. So this procedure is invaded our team, and we published last year. And the name of procedure double leaflet technique, in which we put another valve on the native leaflet. And the advantage of this procedure is it can create a very deep coaptation zone. So hopefully we have a very good durability. And another case is, the saline test looks pretty good. And another case is commissural prolapse with sclerotic commissure. Sclerotic commissure is not easy to repair because we cannot use a simple plication or artificial coda. So in this case, I made an incision of the commissure toward the annulus and sew them back together. Rejoin them by approximating the atrial surface of the anterior and the posterior sides of the commissural segment. So this atrial surface approximation is very important because it creates a very good coaptation between A3 and P3 segments. So this is like a well-designed edge-to-edge repair that only surgery can achieve. And of course, we can repair the infected valve. You see a vegetation and destruction of a lateral P2 segment. Actually, this video is run with a 2x speed. And now I'm resecting the whole infected area, like a whole lateral P2 segment. To fill in the gap, I slide the medial P2 segment with knife and pull this part toward the left side and sew the medial P2 and P1 to fill in the gap after lateral P2 resection. So in this case, I also added the ring annuloplasty and 2 neocodi on the posterior leaflet. And the valve is nicely repaired. So another strength of surgery is we can do more than one procedure in one surgery. We very often do tricuspid valve repair. Sometimes we do aortic valve replacement with a mitral valve repair. And we can do Mays procedure and left atrial appendage closure for AFib patients. And we also can close a ASD concomitantly with a mitral valve repair. So lastly, I want to show you the video of left atrial appendage closure. through an endoscopic approach. So we don't have to extend the incision. We can do everything with the same incision. And now you're looking at the left atrial appendage through the transverse sinus from the right side of the chest. Now I'm putting pledgeted sutures at the base of the left atrial appendage as markers. So we have to clamp. We have to put the clip at the base. Otherwise, we cannot prevent thrombosis after atrial clipping. So this is just markers. And now I put these sutures on the fabric part of the clip. This clip is designed for atrial appendage closure. So these sutures are going to be guiding suture. So clip is being seated at the base of atrial appendage and deployed. And this is a clip placed at the base of the left appendage. And good thing is that we can confirm the nice closure from the inside of the left atrium. So in summary, totally endoscopic mitral valve repair is a less invasive surgical approach and provides clinical and social benefits when done by an experienced team. Complex DML can be repaired with a combination of various techniques, and other valves and arrhythmia can be treated simultaneously. This approach should be the first choice for young and or low-risk DML patients. Thank you.
So thank you for your excellent talk, Professor Tabata. So, well, it's a bit confusing to me because both of you are, Dr. Matsumoto and also Professor Tabata are expert in your field. So Dr. Matsumoto is an expert in doing transcatheter approach of mitral valve repair, while Professor Tabata is expert in doing minimally invasive surgery for mitral valve. So if I have a patient with mitral regurgitations, how should I decide which of you should I refer to the patient to you?
That's a good question, Dr. Wang. Actually, let me say about DMR. I know Dr. Tabata's technique is super nice. Actually, I sent 2 patients to him this year, DMR patient. So if DMR patient and the risk of surgery is standard or intermediate, I think we should send those kind of patients to surgery. But if patient has too high risk for surgery, then I think I want to treat with a transcatheter technique. But when we see ventricular FMR, its situation is different. I think in this subset of patients, the evidence of mitral is very high. See a COAPT trial. In these kind of patients, we should treat with transcatheter technique, H2H, mitral clip.
Well, I totally agree with Dr. Matsumoto. I do have some experience in mitral clip. I'm sometimes operating on the transcatheter technique, although I don't have so many experience as Dr. Matsumoto does. Even surgeon, I agree with the first, the mitral clip should be the first choice for ventricular FMR. And also, very high-risk DML patient should go to the cath room other than instead of an OR. Yeah, I totally agree.
So, but sometimes we find mixed mitral valve disease, and most of the time the functional and versus degenerative is not so clear. So how about for Professor Kim? So what's your approach when would you refer your patients with mitral regurgitation to surgeon?
Yeah, I think that's a very important question. In Korea, I think the mitral clip, especially tear procedure, is very, very costly. So I think it's very expensive. So I think that it is one of some issue to perform some tear procedure rather than a surgery. So also the other issue is that there is some conflict between surgeon and interventionist. So it's not so easy to decide which treatment is better only based on the guidelines. So actually we usually discuss about the risk and the outcome of the patient in each patient with between the interventionist and surgeon, as well as some imaging specialists. I think this is very important. So I have one question to the Matsumoto and Tabata. And in some patient has a functional MR, but the patient is very young. So anatomy is, I think, somewhat mixed, but more functional. And usually, I think which treatment option is better? And is there any conflict in Japan?
You mean a ventricular FMR?
Yeah, ventricular or atrial functional.
If patient, a young patient with a ventricular FMR, let's say 40 years old or 50 years old, I think we should consider EVOLUT and transplant first. So I asked heart failure doctor, we should treat with H2H mitral clip or just send to surgeon and replace mitral valve and wait for transplant. Oh, is that? How about you, Dr. Tabata?
Well, I mean, I would choose a mitral clip if the anatomy is feasible for the TEL, because yeah, as you mentioned, young functional ML patient is likely to require like a LVAD or a transplant in the future. But if the patient had a previous heart surgery, the LVAD and heart transplant is going to be more risky. So I think using a TEL as a bridge is very helpful. So I would send the patient to you maybe.
Also, one more question to the Takashi. And yes. I think I'm so impressive to apply IVP in case with the incomplete coarctation, and especially in functional MR. So is it usual practice or is just a patient with a very severe depressed heavy function and low blood pressure?
I mean, use IVP before mitral clip?
Yeah, mitral clip, yeah. So yeah. Decrease some coarctation. Yeah.
Yes, if the gap is just under 5 millimeter, just we do a mitral clip. But if it's over 5 millimeter, like this case, it was 7.3 millimeter, I think we can grasp, but it increases the risk of tear. So in that case, I consider IABP, especially in ventricular FMR patient, to stabilize hemodynamics also.
So how about in Hong Kong? I mean, maybe Dr. Danny Chow. So especially in private sector, I think both mitral clip and surgery are extremely expensive. So when do you decide to refer which patient to surgeon, or you do the mitral clip yourself?
Yeah.
Yeah, in the private setting, it's very, very expensive to have the valve replaced or undergo the catheter-based surgery. So it's actually most of the time if the patient can afford the TEER procedure, we would do it. But most of the time, if the patient cannot, we will refer back to the public sector. It's a very, very expensive procedure because it requires post-op ICU care as well. So it's not very commonly done in private sector.
By the way, mitral clip G4 is available in Hong Kong and Korea?
Yeah, it's available in Korea. We also introduced, I think, this year, April.
It is very, very useful device. When I used G2, mitral clip G2, the clip rate is 1.4 to 1.5 per patient, but now it's 1.1 per patient. So in most of the cases, we can finish just one clip deployment. So the average procedure time is 40 minutes to 50 minutes. It's made procedure very simple.
And do you often use the independent grafting?
Not so much.
Because that's the selling point of the, the system.
Yes. It's selling. It's useful tool, but it also has a risk of tear. So I use really difficult case.
How about the use of XTR?
In my center, I think 40% XTW and 40% NTW. So it's very useful, XTW. I mainly use XTW for A2P2 prolapse or ventricular femur, which has enough length of leaflet and enough mitral valve orifice area.
Okay, so how about Dr. Lau? Do you have any comment on referring patient for mitral clip?
Thank you. I think, as Danny mentioned, in a private setting, it's very difficult, and the experience is somewhat limited compared to a public system in Hong Kong. For example, with Simon, and they've been doing quite a lot of cases with accumulation of experience, expertise. So for cost and also expertise-wise for the patient, I sometimes also would like to refer to him and to have his advice to consider with a heart team to see whether the patient should go for a mitral clip or go for the surgery.
Okay, thank you so much, Dr. Lau. So I think if there's no further comments, so let me conclude this wonderful afternoon sessions. And please stay tuned, and we will have the official closing. Thank you.
Thank you.
Thank you very much for joining Hong Kong Valves 2022. So on behalf of the organizing committee and heart team, which is not just for Queen Mary Hospital, it's kind of cross territory and cross the border, and also involving a big heart team, including every parts of the world, to make this Hong Kong Valves conference can be able to complete in a successful manner. I would like to thank all of you for joining. This year we have 1,200 participants that have been registered, and at the peak moment we have 500 to 700 actively joining the program. So this is something that we feel happy, and we really hope that you enjoy this educational meeting and have a good time during the weekend. So we would like to thank our supporting organizations, including Hong Kong College of Cardiology, Hong Kong FIX-CA, CSI Foundations, Hong Kong Cardiac Nurse Association, Asia Pacific Society of Cardiology, Macau Cardiology Association, and Cardiovascular Research Foundation in Korea, ECHO Hong Kong, Hong Kong InPace, and Hong Kong Cash. Thank you very much for our conference secretariat, Calvin and Wendy, and Angel, the amazing team to support the IT aspect, and also all the logistics for our guests, so that you have a good experience today. And all the participants, all the delegates and speakers, faculty, joining from all over the world to make this happen, and hope to see you in year 2023. hopefully we'll bring you a new experience. So this we keep reminding ourselves, we'll bring you a new experience every year. We'll never repeat ourselves. And hopefully with the COVID situation become better, we can move back to in-person contact, because nothing could replace person-to-person contact, social networking, gathering, chill environment, and we can have a drink together. Thank you very much, and see you in 2023.